A very warm welcome to day 2 of the KSCASI-midCON 2025 here at Kanachur Institute of Medical Sciences, Mangalore.
Yesterday was a day filled with knowledge, innovations, and brilliant deliberations. And today, we continue this academic odyssey with even more enthusiasm, diving into intricate case presentations and expert discussions.
Day 2 promises to bring forth clinical realities that surgeons must master, not just in theory, but also in everyday practice. So let's begin our first academic session of the day, a case presentation on peripheral arterial occlusive diseases. To moderate this session, we are privileged to invite Dr. Bhagwan K.R., the moderator for this session, a distinguished surgeon known for his clinical excellence and mentorship. The case would be presented by Dr. Subramanya Hegde, PG, KMC, Mangalore. To enrich this session with their expertise, we are honored to invite the chairpersons, Dr. Anand IP, Dr. Majjurat Kutanavar, Dr. Sunil Subhash Joshi, and Dr. John Joseph Mattis.
Welcome all of you for this beginning of the day, and this is an excellent academic session, because some time back we thought a peripheral arterial disease affects only the downtrodden people. No, it doesn't. It affects all of us, whoever has got an age. I would request our postgraduate Subramanya Hegde to present it. We will know what is this incidence in the general population as we go ahead.
Good morning, everyone. Myself, Dr. Subramanya Hegde, second year General Surgery PG from KMC Mangalore. I am presenting a case of 72-year-old male named Abdur Rahman, hailing from Gandhinagar, Mangalore. Occupation, he was a cashier before, now retired, and he's been staying at the home. He presented to the government Venlock Hospital with the complaints of blackish discoloration of second and third toe of the left foot since 15 days and foul smelling discharge from the same since last 7 days. The patient started noticing a blackish discoloration of the second and third toe. First he noticed in the third toe tip, and which the blackish discoloration progressed to the proximal side, and again he had gone to a local hospital. He was given empirical antibiotics, and certain treatment was given. Still the blackish discoloration didn't disappear, and regular dressings were done for the wound. Then patient also started noticing the blackish discoloration in the second toe, which also developed from the tip and progressed to the proximal side. And since last 7 days, patient also noticed foul smelling discharge, which was scanty in amount, but it was mixed with blood. And he thought it to be a serious condition. Then he presented to government Venlock Hospital for the further management. And when patient came, he had a blackish. Yes, sir.
Slides here? Slides?
No, not in this.
In the meantime, sir, this is a typical presentation, Ignatius, sir. Anand, what is your take on this kind of a story?
Finish the history first before we comment on something there.
Since the slide was not moving, I thought I will take this opportunity.
No, if I give my opinion first, then he'll get biased of giving the history then.
Yes. Then the patient underwent the second and third toe ray amputation with debridement on 6th of August, and patient is here for the case presentation, sir. Patient doesn't give history of any trauma, any chest pain, any gluteal pain, any claudication pain, or patient doesn't give any history of breathlessness on exertion, climbing up the stairs, or any other like leg pain on rest or something, sir. Leg pain. And past history, patient is a known case of diabetes mellitus since last 28 years on oral hypoglycemic agents, and patient is also known case of hypertension since last 8 years on medication for the same, and patient had a history of CVA left-sided 10 years back. For that he is on medications on tab, ecosprin and clopidogrel for the same, and patient no history of any TB, asthma, epilepsy, or any other adverse cardiac events were noted. Personal history. Patient is moderately built and nourished. Patient is a consumes mixed diet. The sleep is adequate. The urinary bladder movement, now patient is having urinary incontinence. Bowel movements are regular, and patient is a non-alcoholic, no non-smoker, no other substance abuse noted. And family history, there is no significant family history, and no patient's father or mother was not diagnosed with any hypertension or diabetes. Yes.
It's working? Yeah. Can I just interrupt you with that thing? See, you said there was a blackish discoloration.
Yes, sir.
Was it spontaneous?
Sir, he noticed 15 days back, sir. From the tip of the third toe it started, sir.
Because if you are asking a patient without any this thing, there no trivial trauma, no pinprick, nothing there, suddenly you won't get. Either it will be a minor trauma, or it will be an injury, or it will be something is wearing a boots or something is walking around. He may not be having any sensation there. I think you may require to highlight on that. Now, since this episode has started within a period of about 15 days,
yes.
I am looking at it as a complication of any other underlying disease which has been there.
Yes.
So you may have to emphasize a little bit more on the treatment aspects, whether he had previous episodes, whether he had any other thing, he was advised to do anything there exactly, and then go about with your history there.
Okay.
Now, if you say it's only a straightforward case, I don't think it's a straightforward. Now, since when you completed the history, I came to know that he is a diabetic.
Yes.
Recently diagnosed maybe about 8 to 9 years as an hypertensive.
Yes,
He's on treatment, had a CVA, followed by which he has come back on medication or something. That means I'm looking at a high-risk individual here, which we require to categorize before we do anything more on a clinical examination.
Okay.
Because there are many red flag signs here. So we have to interview. First is his age, second is a diabetic, third is an hypertensive, fourth is a CVA, already had an episode. We don't know what is the condition of his kidney and so on and so forth. You may have to little bit stress on that. You got the point? Yes. So anyway, if anybody else requests.
Hello, good morning. Nice presentation. Just I want to clarify. You said no history of claudication pain in the calf, thigh and buttocks. Suppose you want to rule out higher up, block higher up, what other history you ask? Aortic disease. You said fainting, chest pain, abdominal pain. Suppose you want to rule out aortoiliac disease, what history you want to ask? And
impotence history.
How you ask history of impotence?
Sir, we can, but the patient has 5 children, so I didn't emphasize on.
He has not given up. You saying he has given up. It is early morning erection.
Yes.
That is how we rule out aortoiliac disease.
Doctor, indeed it was a good presentation. I want to know, since patient has got frank gangrene, isn't it?
Yes.
There is blackish discoloration of toes, without any history of intermittent claudication. That means without any history suggestive of chronic arterial insufficiency.
Yes, sir.
So what could be the cause for this gangrene? Obviously, it cannot be acute case, isn't it? Like embolus or thromboembolism.
Sir, it may be because of atherosclerosis, whatever the...
There will be pain. There will be long history of intermittent claudication pain followed by rest pain before development of gangrene.
Patient
but
is
in this case, you can explain something. What is that?
Diabetic neuropathy,
very
which would have led to the loss of sensation of the foot and the pain sensation, sir.
Yeah.
So patient...
Yeah, many a time,
Yes.
diabetic patient may not have classical symptoms of arterial insufficiency. That you have to highlight,
yes,
isn't it?
So, a blackish discoloration you said in one of the foot, isn't it?
Yes, sir, left foot, sir.
So when you ask history, wherever, whether it's a swelling or any symptom for that matter in surgery, the question that you ask is if it is present in other limbs as well.
Yes, sir.
Whether it was present on the other leg, whether it was present in the upper limbs, that is the history you need to elicit. And second thing is, you said there is no claudication. Can you tell me what is claudication?
Claudication is...
How do you define claudication?
Claudication is a patient complains of pain after walking certain distance, sir. where the muscle will start accumulating substance P and substance S, which will aggravate the pain, and that distance is called claudication distance. And
We need to have a better definition. Let's say, is it reversible?
yes, sir.
Okay, it's a reversible pain.
Reversible pain, sir.
Okay, that is brought on by exercise.
Exercise and taking rest sometimes.
Walking for certain distance, and relieved by.
Taking rest and even.
And where is it felt?
Sir, usually in the calf muscle.
It is felt at a level occlusion.
Upper.
Below the level of occlusion. Wherever the occlusion is, below the group of muscles which are below the level of occlusion. So that is where you get the pain.
Yes.
It's a reversible, episodic pain that is brought on by exercise, relieved by rest, which is felt in a group of muscles below the level of occlusion. That completely defines your claudication pain. Okay?
Yes. Yes.
What is the type of the pain?
Spasmodic pains.
Typically cramp-like pain
Cramp
felt
pain.
in the muscles upon exertion. It can be in the lower limb, it can be in the upper limb. So don't restrict yourself to the lower limb
lower limb.
whenever you are asked for some definitions,
Yes.
isn't it?
Sir?
Is your patient a smoker?
No, sir.
He's not a smoker?
Non-smoker, non-alcoholic, sir.
Okay, what is rest pain? You were saying something like there is no rest pain in the leg.
Yes.
What does it mean?
Sir, in the peripheral arterial occlusive disease, the patient will have pain even on rest, sir, because of the nerves which are getting involved, and there will be rest pain also is present, sir.
You need to have definitions and you need to specify it clearly. It's a intractable pain.
Intractable pain.
Okay, and you need to compare it with the claudication usually.
It is
what is the difference between claudication?
It is
it's an intractable
irreversible
pain
intractable,
that is felt in the most distal parts of the limb. Okay,
Yes.
which is continuous in nature, not relieved by any factors. In fact, at times patient has to sit in the chair, not to lie down. If lying down worsens his pain, so he has to sit in a chair with the legs hanging down, and they sleep in the sofas, they sleep in chairs. So that is rest pain. What is anything else?
One more thing to contradict the sir's statement. Sir was concentrating more on impotence. He is a 72-year-old patient, non-diabetic.
Yes.
Diabetic patients do suffer from one more type of neuropathy, that is autonomic neuropathy, isn't it?
Yes.
So impotence is the first symptom or sign of autonomic neuropathy in diabetic patients.
Yes, sir.
So since this patient is suffering from diabetes since the last 20 years, 30 years, so that is the first symptom or sign of impotence. So you cannot contribute into impotence in case of diabetic patients for ischemia.
Yes.
Got it?
Yes.
What is the cause for rest pain? You said ischemia of the somatic nerves.
nerves.
What part of the nerve is affected there?
Endoneal.
Ischemia of the nerves means what supplies the nerves? What blood vessel supplies the nerves?
So these are arterioles and
That name of the arterioles?
was
Vasa vasorum, there can be.
sir.
Like vasa vasorum,
Vasa
supplying the
vas-
arteries. What are the vessels supplying the nerve? Fine vessels. Vasa nervosum.
Vasa nervosum. If patient has rest pain, how the patient will hold their foot?
So they will sit by the side of the bed and they will be holding the.
Called hen holding
Hen-
position. Hen holding position, they get some relief of pain.
This patient,
Yes.
according to your history, neither had rest pain nor had claudication,
Yes.
isn't it? So, did you go back to his routine activities? He had a CVA, he's 72. Was he walking at all
Yes, sir. He was walking, sir.
regularly?
Regularly.
What was
walking.
his regular activities? that you
Sir,
asked?
he used to do his household activities, sir. After going to the market, getting the vegetables, and helping the children at home.
So, he used to walk.
Yeah, he used to walk, sir. Sir, it is in the same affected limb, sir. So the
theoretical thing which I am asking you. If you can get the answer, it will be more of the because when we normally see patients who come back with 1% who are on there. And if you have a patient who has come back with a CVA, most of the time it gets on the foot where there is a CVA. Why?
more of the patient will have loss of sensation of the foot of like
Both the thing is symmetrical. He is able to walk. He is walking with a limp.
Yes.
I am giving you a clue. He may drag the foot. He may overlimp it. He may not be able to do something. Most time gets affected in the foot, which is having the CVA. Why?
the stance
I'll
and
give you a foot for third. There is a change in his foot. The foot kinetics changes. The pressure increases is more. He may not be able to put a footwear there or something. He may not be able to walk properly. So deviation there. And the second aspect what we are looking is since he already had a CVA, that side if it gets affected, even the blood circulation is going to be affected more than what is required. And he's already been a dual platelet ducts. One is ecosprin and one clopidogrel. So most probably if there is anything there, I am thinking that there could be a minor trivial trauma you may not have noticed, mainly led to a complication, then he would have come to you. So you have to emphasize that.
Okay.
You got the point there?
Yes.
See, when you give clues in the history, it is where we think and concentrate more what could be the underlying pathophysiology, how is going to present and what exactly is going to be the outcome of it. So your history is the key to main thing what exactly your treatment is going to be there. Clear?
Yes.
One more thing, since these are non-diabetic patients, you know the diabetic foot triad, they can be neuropathy component, they can be vasculopathy component or immunopathy component. So which component predominates, that also you have to highlight.
So usually the neuropathy components which predominate.
Pertaining to your case, isn't it?
Pertaining
You have
to
to
my
highlight
case,
that.
yes sir.
Even in history also.
Yes. Okay. Coming to the general physical examination, patient is well built and nourished, conscious, coherent, oriented to time, place and person. Patient with due consent examined in a well lit room. Patient's blood pressure 130/80, right arm supine position, and pulse rate of 84 at the time of examination, normal in rate, rhythm, volume, character, and there was no radial or no radiofemoral delay, and a saturation of 98% at room air, and patient systemic examination, patient's cardiovascular system, normal S1, S2 heard, no muffled heart sounds noted, and respiratory sounds, respiratory system, normal vesicular breath sounds heard, no added sounds noted. Central nervous system, patient is conscious, oriented to time, place and person, GCS of 15/15, bilateral pupil reactive, and power in the right upper limb is 5/5, right left upper limb is 5/5, right lower limb is 5/5, left lower limb is 4/5, and patient's power tone of the muscle is normal, and the per abdomen examination, per abdomen soft, non-tender, no guarding or rigidity noted, and no all the hernial orifices intact, no organomegaly noted, bowel sounds heard, no bruit noted. And coming to the local examination, patient was examined in the well-lit room with the due consent.
1 second. Let's hold on. Let's talk about your general physical examination.
Yes,
what
sir.
you wanted. You were saying something about radial delay, radiofemoral delay. I would like to know what it is. Why are you looking for it, and what inference you can get
Sir,
from this?
in the case of coarctation of aorta, there will be radiofemoral delay which is noted, sir.
Okay.
And radial delay is seen in the cases of so the upper limb stenosis in the axillary artery stenosis or the cervical rib. Sometimes we get to have the radial delay.
So if there is a occlusion in the blood vessel or vascular system,
Yes, sir.
you get this delay, isn't it?
Yes, sir.
Okay. What else do you look for when you palpate a radial pulse? What are the things you look for?
Character of the pulse, volume of the pulse, rhythm, and the volume pulse, and sir,
Rate.
rate 84 rate.
You have to go in order: rate, rhythm, character, quality of the vessel wall. Yes?
Yes, sir.
What is the quality of the vessel wall you're looking for?
Sir, whether it is compressible or non-compressible, we'll look at first.
Okay. So what do you expect?
Sir, it was compressible in the upper limb, sir.
It is compressible in the upper limb.
Compressible.
Okay. And what other signs? So this is a vascular case, isn't it? He's got.
Yes, sir.
You definitely know that there is some problem with the vascularity. What are the signs you would look for in general physical examination in case of a vascular disease or atherosclerosis?
Sir, we look for the carotids also, sir. Carotids, whether there is any.
What signs you look for if there is any problem which is there on the hands? If you have a no, be very specific. Sir is asking only few signs.
Not sure.
Go back home there, take up the thing there.
Yes.
See, especially you have an upper limbal vessel disease. Can you see some nail changes?
Yes, sir.
You can see. Can you see something which is happening in the pulp of the finger?
Renault.
Can you see something like a weight loss or something, or it could be a muscle loss or anything with a loss?
Weight.
Same things you require. Now, if you have a patient who has come to you with a familial syndrome there, especially a hypertriglyceridemia, something you will be looking in the face, especially below the
this thing, sir.
around the
xanthoma, this thing, sir.
or around the
Orbicular is this.
no. Inside the eye.
Inside for the this thing. Plaques which are deposited, sir.
What can you see, especially in the pupil and in between the pupil? Can you get a cataract or anything else? You have to look into that.
Yes, sir.
Can you see any changes in the air? All things are there. There are signs of mainly familial hypercholesterolemia, hypertriglyceridemia. You have to look into that.
Okay.
Now, why do we don't see in such an individuals in the Indian thing? Population is mainly because most of the time we fail to notice such things. And we ignore them. And if you have any patient who comes back to you with any other history of maybe thromboembolic episode or something that he already has one, head drilling, eyes, ears has to be asked. Already a known case of CBA. You may require to be asked and completed further.
Yes.
Okay? Yeah.
You have specifically mentioned there is no radiofemoral delay, no radioradial delay.
Yes, sir.
So do you think coarctation of aorta is so common?
No, sir.
Have you make it a routine in any case of peripheral arterial disease? This examination point. My point is, if it is positive, mention it.
Yes.
If it is not, then you don't mention it.
Okay.
But it is not so common. Coarctation of aorta is not so common. If it is there, but you have to mention.
Yes, sir.
If it is not there, you need not mention it. So may I ask the opinion of senior professors regarding this in a case of vascular disease, sir? Bhagwan sir, please.
Normally, the they make it as routine is not necessary, but we have to describe the vessel wall in detail.
Sign is positive, they have to mention it.
Yeah.
If it is not there, then let us not make it a routine.
Not necessary, because aortic coarctation is very rare, and most of the patients do not reach beyond 40 unless they have undergone some surgery.
You are highlighted well-lit room and all. What is this well-lit room means what?
With
Artificial lights?
sunlight is a good.
Which one sign don't want to use the artificial sign, light? One sign you elicit without using the artificial lights.
So the trans illumination is the one which.
Okay, any other general examination? Icterus.
Icterus.
Icterus you have to use the natural light. What is the difference between icterus and jaundice?
Icterus is the thing, sir. Yellowish discoloration of sclera. Sir?
Yellowish discoloration of sclera, skin, mucous membrane is called icterus. If the yellowish discoloration is due to elevated bilirubin, it is called jaundice.
Go to the local
You can say
examination.
jaundice can be a symptom, icterus can be a sign. In that way also you can substantiate it.
Go to the local examination. Regional examination.
Local examination. Patient's right lower limb is normal. There was no ulcer or no no ulcer or no wasting noted. Examination of the left lower limb. Patient in examined in supine position. There is a sir? Patient is only.
Now, do you have the PowerPoint slide or the foot? Do you have the slide? Is there a slide here? Other? Okay, it is not that, not taken.
Yes. A patient patient has an ulcer of on inspection. Left lower limb inspection, there is ulcer of 5 into 3 into 1 centimeter, 5 into 3 centimeter noted in the dorsal aspect of the left foot, and there was no the reddish discoloration or blackish discoloration.
Sorry, is it an ulcer now?
Yes, sir. The debridement and the re-amputation has been done for
has been done. He's undergone a procedure.
Yes, sir. Yes, the procedure, sir. Now there is a ulcer.
Oh, it's a post-operative case. Okay.
Post-operative case, sir. And the ulcer has a the surrounding skin of the ulcer is red, and sloping edges noted, and raised margin noted, and slough is present in the base of the ulcer, and and capillary refilling time of the left foot was noted to be 7 seconds, which is raised, and the girth of the left lower limb at the thigh, it was 41 centimeter, and at the calf region it was 33 centimeter. Compared to the right sided thigh circumference was 42 centimeter, and calf was 34 centimeter. And there was 1 centimeter less compared to the right side. And coming to the palpation, all the inspectory findings were confirmed by palpation. There was no local rise of temperature, and the ulcer noted to have a sloping edge and raised margin. Base was formed by the underlying bone, and slough noted in the ulcer. And coming to the palpation of the peripheral pulses, there was no pulses felt in the left dorsalis pedis artery, anterior tibial artery, and posterior tibial artery region. Popliteal artery pulsation felt, and common femoral artery pulsation felt, as well as on the compared to the right side, dorsalis pedis, anterior tibial and posterior tibial artery were not felt, and popliteal artery felt, and common femoral artery was felt, and Burgess critical angle was noted to be at 90 degree, and there was no significant ischemia noted in the left lower limb. And there was no peripheral nervous system examination. Bilateral foot, there was loss of sensation for the pain, and on local examination there was no inguinal lymphadenopathy noted, and the external genitalia is normal. Coming to the
why you examine the external genitalia?
Just sometimes varicocele also will be there, sir, like in chronic venous insufficiency. Yes. Yes.
Any other examination?
Cardiac is worse. Respiratory. Yes.
What's your diagnosis?
Sir, I want to conclude to be a peripheral peripheral arterial disease of distal arteries due to atherosclerosis, and maybe with the underlying type 2 diabetes mellitus as the cause, sir.
No, your examination, some 1 or 2 points. Did you mention about signs of chronic arterial insufficiency?
Yes, sir.
What are the signs of chronic arterial insufficiency?
So the skin changes are the ones, sir. Like there will be loss of hair, muscle wasting, and the nails will be brittle, and the surrounding skin will be edematous, and dry, scaly, and sometimes. Sir? In between the toes, we'll have the.
Can you get cracks and fissures?
Cracks and fissures.
Can the patient come back to you with a painful walk or a limp-like thing? So attitude of the limb, walking style, gait is also important there.
Yes.
Now, since you've already finished, we'll just summarize it there. Now, we have an elderly gentleman here, around 70, 72 years, known case of hypertension, and an diabetic on treatment with the history of CVA along with the thing. He has come to you with gangrene there. What would you like to do in such patient or something? Since he's already been amputated, you have a residual raw area there,
yes, sir.
And he has come back to you. You think you have done the surgery. What would you like to do further with this patient there?
Sir, we have to first evaluate for the level of occlusion where it is actually present.
Now, before you go back, just give us an idea saying that since he's already been investigated and already been surgery, you would like to get all the previous reports over there. Assess the previous reports, come back to what exactly you want to look for. B, look into the status of right now what is present. And you would like to predict and find out how exactly it's going to fare well then. Now, why are we looking at predicting factors here is mainly because you have a residual area or raw area. You think it might affect the rest of the other toes. It may be affecting the foot also or the leg. We do not know. Right now is not on sepsis. Right now he has got a wound, maybe a raw area which is going to be there. Our job is to make out whether the predictability factor which is there, it will heal or whether it's going to progress there.
Yes.
Those are the key things which you require to do in that wound management, whatever you there. Now, if you have an underlying patient who has come back to you with atherosclerosis and so on and so forth, you are required to re-examine them and reassess and speak to the patient, then talk to him, continue with the medication. That is what we are looking. Now, how would you like to manage this patient?
Since we had taken all the opinions and we had forwarded with the gone forward with the surgery, sir. When we got evaluated for his cardiac evaluation, we got to know he has LV hypokinesia and for low LV global hypokinesia.
What's the ejection fraction?
Ejection fraction of 40%. Sir.
Yeah, that's all. Be very specific.
Yes, sir. Ejection fraction of 40% we have gotten it to know, sir. And his Doppler was only done, sir. Bilateral arteriovenous Doppler, which showed there is monophasic flow in the anterior tibial, posterior tibial and dorsalis pedis, and biphasic flow in the popliteal artery of left lower limb, and with triphasic in the common femoral artery, sir. So I will want to go ahead with CT angio to look for whether any bypass procedures can be possible for the patient.
Now, why do you want a bypass procedure? You are not asked for a flow velocity there. You have a color Doppler, you have a flow velocity, it's gone to a monophasic phase. What is the critical flow velocity by which it will be compromised?
Less than 5
5 what?
centimeter.
I'm asking you flow velocity. See, each vessel which is there in the body has something, there is a velocity which has been done by that, and you do a color Doppler, you will come to know. Now, if you say triphasic, biphasic or monophasic, there will be some amount of flow which is going on there. What am I looking there as something, it might be a good flow there. You are asking for an angiogram, you are thinking that you are planning to get to over there. That means if your flow velocity is less, it's gone below critical, then only you may think of that. Okay. If there is a segmental block, or if there is a trauma thing or something, if you are trying to bypass, you are required to look at the distal flow with an healthy vessel or something for reconstruction there.
Yes.
That is the time when you look for things. But if you are looking for predictive factors or something, whatever you are asked is right. Until and unless your color Doppler does not give you any other added information. Is it very clear?
Yes, sir.
Now you have to rethink your strategy here.
Yes.
Okay.
Yes.
Now since you have done an arteriogram, where is you have a film with you?
No, sir. Arteriogram was not done for the patient.
Okay.
I was like, can we go ahead with this thing? I just wanted to.
You have a doubt whether it will heal?
Sir, it will heal, sir.
Then why you want? No, there is a thing that, see, you are required to be more aggressive there, you are required to be more research oriented, you require that.
How will you know this is going to heal? Are there any predictive things available? Since you said nothing is palpable below the popliteal, how do we know? How are we not sure it is not a progressive disease? Only 2 have gone now, that is the tip of the iceberg. Why not others also on the pathway of dying?
Sir, but the skin margin of the ulcers are
No.
raised.
Ulcer is showing a good amount of slough. There is nothing else is seen. There are no signs of healing here. Why is it not? Why it will not progress? He already has. You can see the grade 2.
Yes.
The nail changes are already there.
Yes, sir.
Edematous.
Edematous and brittle.
There will be some amount of sepsis. This is not a dry gangrene. This is wet. So what do we have clinically? You said capillary refilling time. Anything else? Of course.
Venous refilling and...
Yeah. One more at this point, which is no more investigation, which is a norm for most of the hospitals. Did you do ABPI? Gauss,
Yes.
that is the basic thing here.
Yes.
Actually, ABPI should be part of your clinical examination.
Okay.
Every diabetic foot clinic should have handheld Doppler. And it should be part of clinical examination. It should no more considered as special investigation in any case of diabetic foot, isn't it? Now, what
It's
are
a
the
bedside examination.
indications for angiography in diabetic foot like this?
Sir,
Already you have got done Doppler ultrasound, isn't it?
Yes,
What are the
sir.
indications for angiogram? Let it be any variant of angiogram, maybe conventional or CT angiogram or digital subtraction angiogram. What are the indications?
for the... to assess the flow through the arteries.
You have
sir.
got done Doppler
Vessel
ultrasound.
wall characteristics.
See, most of the information can be got in simple color Doppler, isn't it?
Yes.
Only when you plan for definitive vascular surgery, when you feel that patient needs definitive vascular surgery, then only angiogram is indicated. As a general surgeon,
Yes.
with a good Doppler ultrasound, and as sir told, there are good signs of vascularity, and if you are not planning any vascular surgery, we need not submit the patient for CT angiography.
Now, I'll give you a practical situation. Now, how long you want to wait for it to heal? What's your cutoff limit?
At least another by 2 months, if he is able to walk with his foot, it will be better.
No, my question is healing. I'm not asking whether it's mobilizing. How long do you think you can wait? 1 week, 2 weeks, 3 weeks, or 4 weeks?
4 weeks up to...
Why do you wait for 4 weeks?
Since
If you're waiting for 4 weeks, how would you like to manage the wound? What antibiotic would you like to put? And what are the medications which you'd like to continue? When would you like to reassess the patient and then call back and say that, okay, you are not progressing, we require to do something better. May have missed something, we require to investigate that. And we will suggest you a little bit better option for a treatment. When is that cutoff limit which you have with you?
After 2 weeks, at least. Sir.
Already 2 weeks are over.
Yes. So now the definitive treatment will be the debridement of the tissue.
No,
stuff
he has
tissue.
already been debridement, amputation is done, is a residual raw area. Our concern is about healing, is mobilization, and maybe offloading, or maybe the antibiotic. Foot care will be there, educating the patient will be there. You're required to be, as a surgeon, you have to look into all these things before you come back. Let alone the dietary aspect and the rest of the other things. Now at the end of another 2 more weeks or something, when it comes to 4 weeks, if the wound doesn't heal per se, what would you suggest him and what would you like to do as a surgeon?
So when after 2 weeks also, if the wound is not healing, we have to see what is actually going wrong with the, like whether he is actually taking all the medications or like
He's taking medication, not responding. He's taking medication, responding, everybody is fine, everybody is look, everybody will ask you to continue. He's taking medication, not responding. What would you like to do?
want to evaluate for the other causes.
That is what my question is. What would you like to do?
Can you highlight us about what are the components of treatment in this patient?
So,
You are concentrating only on vascular component, isn't it?
yes, sir.
What are other components of treatment?
So mainly, since he's
There
a
should be comprehensive treatment, isn't it?
yes, sir. Since he's a diabetic patient, he should have the diabetic
Very good glycemic control or
glycemic
metabolic
control
control.
and oral hypoglycemics, and if insulin is
Oral hypoglycemic better, or insulin is better for better glycemic control?
insulin is always better,
insulin.
sir.
Right.
And patient should undergo regular cleaning and dressing of the wound, so that, and he should take care of the foot, and he should start using MCR footwear so that it will help him in the
See, MCR footwear has got a preventive role, not a curative role. Already has landed up to you with ischemic ulcer, isn't it?
Yes.
And I better label it as a neuroischemic ulcer, isn't it?
Is there a medical treatment to improve the blood circulation?
Sir, we can start him on the phosphodiesterase inhibitor. Silestazole can be started for him. Pentoxifylline can be given, and patient also can be started on ecosprin with 150 mg, and clopidogrel also can be given for the patient.
What about statins?
Statins will help in the reduction of the triglycerides. No, sir. Many of the studies have showed statins didn't have any.
Then why do we put still?
He said he is hypertensive.
You want to start him on an ACE inhibitor, I can agree with that. But if you're putting something else like statins or something, it's going to have myalgia. They may have rhabdomyonecrosis over there. Patient may come to you with saying, the problem is, whatever statins you start or something, it's only for about 6 months to 1 year, maximum is for 2 years. Anything beyond than that or something, the sequelae is, it may reboundly affect the thing because the patient may. The better thing would be to have a lifestyle modification there. You don't tell me that you are putting an MCR rubber chaplain. You have to tell me that you are putting an offloading device for him there. Third, you require a foot care analysis. You require a gait analysis to be done. You require a vascular thing to be done. Following which you will be assessing the peripheral neuropathy, autonomic power, then you're followed by you're talking about the wound management. As since I told you yesterday, since you are in the center part of the wound management there, you're required to make a right decision in order to see what exactly is the status there. Look for like red flag signs, look for complications, look for anything which is going to progress, which is going to worsen then. Because if this worsens, you will land up with a 4-foot amputation. Maybe that worsens, you'll land up with a below-knee. That means you're very ready to have it to receive him to do an amputation rather than conserving that. The dictum now is to preserve the foot, save the foot, not amputate the foot. Now, the next modality, if there is something, you have done an arteriogram, one of the radiologists or intervention radiologists will come back and say, no, we will do some other procedure in order to save the limb. Have you heard about that procedure?
Fogarty balloon
angioplasty. How effective is it in this foot?
So since it's a distal vessel disease, it might help in the.
You want to be a specific thing? Give me a specific. 20 years diabetic.
No,
foot is gangrene. He has come back. SBS CBA. You want to do a thing that. How effective is that modality? Is it better than doing a bypass? Or is it a salvage procedure which you do? That is what exactly we are looking for.
So it's a salvage procedure, sir. It will.
How effective is it?
Sir, it will improve the distal flow, sir. The distal blockage is removed from the Fogarty balloon, then it might help in the revascularization of the vessel.
That is where you require an angiogram to be done. You understood?
Yes, sir.
If you are doing an interventional procedure, you're required to do anything. You started with a limb salvage procedure. You require an angiogram. You have to have a roadmap. Then you have to assess whether it is able to take up. If you're doing for a triple vessel, a single vessel, or bivessel disease, you require any one of the 2 vessels can be done. Now, if your system or treatment fails, you will land up with amputation, you will land up with gangrene, you will land up with complication there. You should be able to accept the fact that he is going to that, counsel the patient, prepare him for accordingly, then only you will have to come back there. See, it's not a single modality treatment. Gone are the errors there. You're required to put everybody on the board before you go up with a conclusion there. Because tomorrow, at the end of the thing, whatever you do at the time, you request either walk or you will be bedridden there. The second aspect, what I am looking down there is something is the opposite limb. I don't want him to cut up any more complication and come back with that. So prophylactically, educative-wise, as well as treatment-wise, as well as your perception-wise, you're required to involve him, make him a part of the treatment, and then only go about it. Okay?
Yes.
In this case, after angiography, if the distal vessels, there is a small segment block, say because of atherosclerotic stenosis, at that time they can try, vascular surgeon can try PTA, percutaneous transluminal angioplasty without stenting. If wide diameter proximal vessels are blocked, maybe long segment, at that time your bypass will be better, vascular bypass. Yes. So that's a vascular intervention you should know. What are the definite indications for them?
Any role of back dressing, back therapy here?
Yes, post-debridement since
By vac therapy or vac dressing?
Vacuum assisted
Closure.
closure
Right.
dressing,
What should be
sir.
the pressure, negative pressure here?
Here it is around 80 to 100 millimeters of
Minus 50 to minus 150.
No, sir, since it is
That's why I asked you what is the flow velocity which is there.
yes, sir.
If you are putting too much of negative pressure or something, it sucks everything out. Even the arterial pressure also
will come.
create a zone which is in and around the vac or what another thing there. It will go for more gangrene than what is required. That is why if you look at the vac therapy, if you have a compromised foot, if you have a foot which has got a borderline thing there, flow velocity is less, do not attempt to put a vac there. Negative pressure is not there. If you want to put a vac there, do the PTCA plus or minus with your stent, followed by which you may have to wait for about a week, see the progress, then only apply the vac. Very clear indication.
Yes.
Now, if you apply the vac, either you should be there an intermittent vac, not a continuous vac. If you're putting that, make sure you have a standard proforma on that. We have tried that. We had a problem. And what is the problem is, we asked them to apply vac. PG applies the vac and he goes home. Next time morning he comes and says, sir, it's become black, sir. What do you want to do? Take out the vac and make him for amputation.
One more thing you forgot to mention in the local examination. You mentioned about pulses, neurogenic examination, lymph node examination. You have not mentioned about presence of varicose veins. Can patient have arterial insufficiency and varicose veins? And which is that condition?
Well, we are going to close because we are beyond the session. This was a very interesting thing. Gone is the era when one doctor could have treated this kind of patients. This is a multidisciplinary approach to the management of this kind of patients. Now, as I already told by our panelists, this would need a further evaluation. Few things that needs to be there. One is a handheld Doppler. It should be there in every medical college, every hospital, every ward. One more thing that we can have is a TCPO2 to know whether there is a good circulation into the other toes. That will predict whether other toes are also ischemic. In this particular patient, he is a neuroischemia. He doesn't have pain sensation as well as he has got an ischemia. So it is very difficult to predict at this point of time. Coming back to the investigation, CT angio, that is done only when we plan some kind of a definitive procedure for the arteries. Having said that, there is nothing known as small blocks. There are particularly diabetes of these stages will have diffuse calcifications. Even though vessels are big, the pressures are not good enough. So they may have NBP of 1.5, 1.6, which is erroneously high because the valves are like steel pipes, but still it is not going to perfuse. So this takes quite a long time, but you don't wait 4 weeks, 6 weeks. If you don't see a granulation, granulation is a first part of healing of an acute inflammation. You don't see granulation within 2 weeks, that means there is some problem. You need to go ahead with further evaluation. This is a common thing. In fact, when the patient had a black patch, at that time, instead of wasting time on dressing, he should have been referred to a hospital wherein the patient could have been given a better care. Any other comments from my seniors in this? Any other questions from the audience? Well, there are no clear-cut one single answers for this. This depends upon the individual patient. I want to do angioplasty, he does not have even 10,000 rupees, I can't do. Because it's going to be too costly. One, suppose the facility is available all over, it could have been done. It is an individualized treatment also. He would be better off with an amputation if he doesn't have other facility and where you are giving the care.
I was telling about arterial insufficiency and varicose vein. You get in arteriovenous fistula. So you have to examine the patient, pulses, neurologic examination, lymph nodes, plus presence or absence of varicose veins.
Yes.
Any questions from students? Flo?
Thank you, sir, for that clinically enriching presentation and to our chairpersons for their insightful observation. I now request Dr. K.R. Bhagwan and our chairperson to kindly proceed towards the photo booth for a photograph and to collect their certificates of appreciation. I request Dr. Shiv Prakash, District Surgeon, Mangalore, to kindly do the honor. Moving forward, our next case presentation focuses on abdominal mass, a diagnostic dilemma that requires sharp clinical acumen and sound decision making.
To moderate this session, we are pleased to invite Dr. Kalaivani V., Professor, Saptagiri Institute of Medical Sciences, Bangalore, a highly respected academician and surgeon with a profound passion for teaching. To offer their expert opinions in clinical pearls, we invite the chairpersons, Dr. Harish Chandra, Dr. Dayanand Nuli, Dr. Suresh BP, and Dr. Vishwanath Patanshetty. The presenter for this case presentation on abdominal mass would be Dr. Koshi Varghese, junior resident, third year, Shema.
So this is to move the slides, and this is the pointer you can use to.
Good morning, everyone. Thank you. Welcome to the faculty who are going to be our expert panelists. And
Dr. Koshi.
Dr. Koshi, please start with the presentation. I would request the faculty that we'll stop him at the end of the history. So after the history, we'll have the first discussion. Then at the end of examination, the next discussion, then diagnosis, and then management. Let us go in that order with my request.
Good morning. I'm Koshi from Shema. I'll be presenting the case. Presenting the case of Miss Nagamma, 62-year-old female hailing from Dairapura, homemaker by profession. She came with the complaints of abdominal pains in the right abdominal pain since 4 months in the right lower abdomen. History of presenting illness. Patient was apparently normal 4 months back when she started developing pain in the abdomen in the right lower region. Insidious in onset, gradually progressive, and colicky in nature. The pain has aggravated since the last 1 month. There is no variation of pain. There is no variation of pain with intake of food. The non-radiating in nature, intermittent, no aggravating or relieving factors. Patient also gives history of loss of weight as depicted by her clothes becoming loose, but she has not measured her weight in the last 4 months.
Excuse me. This slide has to come.
Only one slide is there, sir. There's no slide.
Okay, continue.
So history of loss of weight is there as shown by patient gives history of her clothes becoming loose. Patient also gives history of loss of appetite. There's no history of fever. There's no history of trauma. Patient doesn't give any history of vomiting. There's no history of altered bowel habits. There's no history of yellowish discoloration of skin or sclera. Past history. Patient is not a known case of type 2 diabetes mellitus, systemic hypertension, bronchial asthma. Patient has not undergone any other previous surgeries in the past. Patient doesn't give any history of previous admission before this. For this same complaints, patient had consulted near a local hospital where she had undergone imaging, ultrasound from what the patient gives history as, but the reports are not available, and she was referred here for further management because she was informed there is a mass in her abdomen.
Done with the history?
Menstrual history is only.
Anything significant?
No.
Can we ask, may I request the faculty to...
So you are telling patient pain over the right lower abdomen with colicky pain.
Yes.
And loss of weight and appetite.
Yes.
So what you can think in this patient? Probability.
Probability, sir, it could be malignancy, carcinoma, or could be tuberculosis. First 2 DDs I want to keep in my mind, sir.
How old you said? The patient
62-year-old female.
Any other thing? Tuberculosis, you told, malignancy, you told, any other disease?
Tuberculosis,
What you can think in this patient? No, what is the cause? You are told colic pain. Where you get colic pain?
In hollow viscous we get colic pain, sir.
No, hollow viscous only. Why a patient will which condition will get colic pain? Conditions.
Sir, in appendicitis,
No. This is asking a general question. When do you get a colicky abdominal pain? It can be anything, any organ. So,
causes colic pain.
Colic pain causes, sir, for most commonly it is seen in appendicitis, cholecystitis,
no, see,
renal
you have to
colic.
tell what they're asking is
Colic pain.
any luminal obstruction.
Any luminal obstruction cause.
Answer it. Okay, any lumen. It can be bowel lumen, it can be CVD lumen, it can be ureter lumen. That's what is the question they've been asking. You have to be able to say colicky pain, so probably some lumen is obstructed. Now, which lumen is the next step of examination?
If that patient has ureter colic in this patient?
No, she's no.
Now, what you can think? Analyze yourself. You are telling a patient in glass of 8, appetite, colic pain. So what it could be? You think of obstruction?
Obstruction.
That is what commonly should come thinking.
That's all. Spontaneously, your answer should be some obstruction in the lumen.
As per your history, other than the abdominal pain, which is there since 4 months and which is aggravated since 1 month, there are no any other symptoms other than the weight loss and loss of appetite. So what are the possibilities? The first, the anatomically which organ it may be, or the symptoms might be originating, or next one is the pathology. Can you just analyze?
The anatomically could be involving the ileum, cecum, appendix, ovaries could be involved, sir, or most commonly in these all anatomically should be involved, sir, depending on the site she's telling.
Considering the symptoms, what pathology? Where other than the pain, nothing is there.
Other than the pain, sir, pathology could be ovarian cyst, could be an ovarian cyst, sir, but she's ovarian cyst, or could be there's no history such strong other history, but TB.
Simple ovarian cyst or twisted ovarian cyst?
Torsion could be.
That should be more every tumor, ovarian cyst won't cause colic pain.
Yes.
Okay?
Yes.
Just going back to that one particular point, what is a colic? When do you call the pain as a colicky pain?
Colicky pain, sir, any, as ma'am said, any hollow viscous, any tube obstruction is there, that will cause of the spasm.
No. You're giving the explanation why there is a pain. I'm asking when do you call the pain as a colicky pain?
Usually when it's with sweating and nausea, if it's associated, we call it colicky type of pain.
It is a sudden severe pain, occurs in episodic pain, and in between the attacks of pain, there is no pain.
Yes,
there is a pain-free period. That is a colic. And it occurs whenever there is obstruction to hollow organ. Hollow viscous, tubular structure mainly, like intestine. Any other typical colic pain you can get?
Biliary colic, renal colic, and
yes, ureteric colic.
Ureteric colic.
It's very typical. What about biliary colic?
Biliary in cholelithiasis is also there.
Biliary colic, yes, though it is called biliary colic, it is not as typical as other intestine and the ureter, because the wall of the biliary system, extrabiliary hepatic system, does not have thick wall. Muscular wall is very deficient there. That is why it is not a very classical colic. And you said no relation to food intake. Why you mentioned about that? For somebody with a pain in the right side of the lower part of the abdomen.
It's not that significant, sir, but
yes. Thank you.
Menstrual history, any previous surgery?
No.
Menstrual history, what all you have asked?
You can go ahead with the menstrual history and...
when she attained menopause?
She attained menarche she attained at 14 years of age. After that she had regular cycles, sir, 20-30. Menopause she attained 15 years back. There was no history of menorrhagia, no history of any previous surgery.
And issues, how many issues she has?
How many children?
Male, female kids?
Two kids she has.
She has undergone tubectomy?
No, sir, no surgery, no tubectomy, normal deliveries, everything. Sir.
So you didn't mention about vomiting, whether history of vomiting is there?
No vomiting.
Negative history. Distension of abdomen is there?
No, sir, no dominant.
Constipation is there?
No, sir. She's passing through regular stools. She's passing. No history.
So you think it is a true obstruction or no obstruction? Or partial obstruction?
Currently, patient not in obstruction.
Partial obstruction or no obstruction or obstruction? Three things.
No obstruction, sir. She's passing stools regularly. She doesn't have any complaints.
No, partial, full, no. Which one you will consider in this?
Partial. Partial.
At the end of discussion, what we understand, I think we have to revisit the understanding of colicky pain, whether really that patient has got colicky abdominal pain. Because it is not correlating with any of the other findings. Okay?
So to just add on to the point, see, the pain is in the right lower abdomen. So if the pain at the age of 60 years, keeping the age in mind, we have to keep malignancy in mind first. So if you take that as a consideration, if we say pain, then what is the cause for pain? Can the malignancy cause pain, or due to malignancy, the obstruction of the lumen is causing pain? So that is why everybody is concentrating on colicky pain. So it is not the malignancy that's going to cause pain, it's the obstruction. So is the pain due to obstruction? Is she having colicky pain, intermittent? Then if it is colicky, you have to ask once in how many days the pain occurs. Is it occurring every day? And if it's coming, once in how many minutes it's coming, and how long it lasts, and how does it get relieved? Sometimes associated with the pain, there can be bowel rolling movement, means some peristalsis is happening. That means some subacute obstruction is going on. And these pain can be relieved with passing of flatus. So these are the things which you need to ask, so that at the end of history, you will arrive at a diagnosis. It's like Google Map. You arrive at a diagnosis, you should know where to start, which road to start. If you don't know which road to start, then you may be going in the opposite direction. Right? Yes. So that is why clinical diagnosis is important. Yes. So for that, the detailed history. And as I said, since it is in the lower abdomen, you have to give more importance to the lower GI symptoms. Whether there is constipation, whether there is diarrhea, there is altered bowel habits. These are the things which you should have concentrated on. And you asked what history of jaundice. Why jaundice? What did you keep in mind to ask history of jaundice?
As a separate, just to ask in the rule out if any other involvement does this.
No, you can't give a, what to say, you have to involve in why this history. Whatever word you utter, you must say why you utter. When you say jaundice, you should have in your mind, why did I say jaundice? So you can have an explanation. If you are suspecting malignancy in this lady, since there is loss of weight and appetite, is there any secondaries there?
Secondaries.
Because lower abdomen mass giving rise to jaundice, we have to think far. That is why that doesn't come first. Yes. You should always put these things little bit at the end. More common will be the lower GI symptoms. Yes. Then we will go for secondaries of the disease. Yes. Then you will go for etiology of the disease. So the history has three parts: the complaints, its associated symptoms, the etiology for that complaint, and the complication of that complaint. If you go in that order, you wouldn't miss any of the history which the panelists are asking. Fine? Have I missed anything?
History of trauma you told.
Yeah,
what is the importance here in this correlation?
Since
history
4 months 4 months history she was giving that time, if any fall is, I asked, so that's why. Trauma.
No, how trauma?
How trauma? According to your symptoms you told, how trauma history of trauma is going to help you to put a diagnosis.
It's not at all relevant here, at all. It is not, please don't even utter in the exam. This is what happens. So the examiner takes you in the direction of trauma, like how he is asking trauma and you're stuck. Don't even utter those words which are irrelevant for the case. It's no way it's going to trouble you. I mean, give you a diagnosis for trauma in right iliac fossa mass. Not at all relevant. Okay, please.
Just another point, radiating, you said no radiation of pain.
Radiation.
What radiation of pain was in your mind? I mean, what exactly was there in your mind? Patient had pain in the right iliac fossa.
If along the thigh, if it radiates iliopsoas if patient has an iliopsoas absent, that might radiate down towards the thigh, or if it's a uretary calculi, might go radiate towards the groin. Like
yes, good. Those are things. I think some pain can radiate from back to the right iliac fossa.
Yes.
How many months history is this?
4 months.
4 months.
Yeah. The one other thing is different gender, probably from the scrotum it can radiate to the right iliac fossa, towards the right side of the lower abdomen, to the groin in the male gender. Testicular pain can radiate. But in this case, I think these are a few other points. Now, if you are thinking of, if there is a history of radiation or pain, I think these are the other points that you have to think of.
She had gone to some doctor, no? She had lost the reports. Sonography was done and the reports are not there. So she has consulted a doctor. What did he tell her?
He is not aware of
No. In general conversation,
that there's a swelling inside. There's a mass is there, needs further evaluation to go. That's why they had gone to.
So their conversation was there between the doctor and the patient, that there was a mass in right iliac fossa and you need further evaluation. That doctor told her.
Yes, sir.
This is an important history you should tell us.
Yes, sir.
Isn't it? She has lost the sonography report, it's okay. But what the doctor told, that also is important.
Because now that he has said there is a mass, now naturally she'll try to keep her hand and check whether there is a mass. And when she's noticed a mass, then you have to say whether that mass has been increasing or decreasing. Because she's come to you after some time, after she met the previous doctor. So all these becomes important. Okay?
And sometime, no, that doctor will be your friend. Means I am a practicing surgeon. We directly call them. This lady has come, your patient has come. She has lost the report. What was it? Like that also we can LC.
Yeah, proceed further.
Menstrual history, then after family history, patient doesn't have any similar complaints in the family. Personal history, her diet, she consumes a mixed diet but predominantly vegetarian. Her appetite has been reduced. Her bowel and bladder habits are regular. She's been passing regularly. There's no habits of addiction. Patient doesn't no habits of consumption of alcohol or cigarette smoking or tobacco consumption. At the end of my history, I would like to summarize. We have an elderly female patient named Nagama. She presented with the complaints of abdominal pain in the right lower abdomen since 4 months, and who has present with the complaint of right lower pain in the lower abdomen at the end of this, and has been evaluated outside and been diagnosed with a mass in the right abdomen. For the end of my diagnosis, the probable differentials I would like to give is could be a ovarian cyst, could be a ovarian cyst, could be cecum or appendicular carcinoma of the appendix, or could be abdominal tuberculosis.
Even there, no, you just stop at mass in the right iliac fossa. Probably, keeping anatomy in mind, cecum or appendix, since it is 6 months, 2 months history, 4 months history. So you have to think of chronic conditions only. Okay, don't go on till appendicular carcinoma and all that. These are all rare. I will keep these pathology in mind and then proceed further. That's all.
The order of preference, it is the ovary you are keeping first?
Yeah, repeatedly is we telling.
So that is against your diet.
Yeah.
You say on one side that it is obstruction, partial obstruction. There is a colicky pain, and your first diagnosis is ovarian.
Cecum.
No, you are repeatedly telling ovary. They are correcting you.
Yes,
You can't put ovary as your first diagnosis because she's come with pain. Okay, at this age, I mean, any time ovarian pain means it is due to torsion, as he said, isn't it? Some torsion or some hemorrhage into it. And at this age, 15 years back, she's undergone menopause. Where is the question of ovary being very active and causing torsion and all that? You should keep these things in mind. If at all ovarian pathology occurs for her at this age, you should think of malignancy. And malignancy means by the time it goes to a big size and they may be causing abdominal discomfort. Acute pain is unlikely. So you should avoid telling these things. Get it?
So at the end of the history, even though there was no mass as a complaint, okay, so you're trying to tell the differential diagnosis of the masses.
Yeah.
So rather you try to understand whether if the colicky pain is there or not, but pain is there, what are the pathologies in that area? Even the appendicitis can occur there, the subacute appendicitis. Even that also you have to keep in mind. So think about all the pathologies which are going to have pain. While taking history or what the interpretation you are getting from the patient's history as a colicky pain may or may not be correct. So you have to think in a broader way, think of all the pathologies which are going to occur in that right iliac fossa.
Yeah. Shall we proceed with the examinations?
General physical examination. Patient's elderly female, conscious, cooperative, well oriented to time, place and person. Patient was examined with consent with a female attender. Her pulse rate of 80 beats per minute, regular in rhythm, rate and volume. BP is 120 by 80 millimeters of mercury. Respiratory rate of 16 cycles per minute, thoraco-abdominal type. Rest of the examination, pallor is present. There is no icterus, there is no clubbing, there is no cyanosis, there is no generalized lymphadenopathy, there is no edema present. Coming to moving on to the systemic examination, on the examination of the abdomen, patient is abdomen appears. Abdomen is scaphoid abdomen on inspection. Abdomen is scaphoid. Umbilicus is central. The corresponding quadrants move equally with respiration. There is no dilated veins. There is no visible dilated veins, pulsations or peristalsis. Umbilicus is central and inverted. There is no fullness noted. There is no fullness noted in the abdomen on inspection. Then rest of the hernial orifices appear intact. Moving on to palpation. On palpation, abdomen appears soft. There is no local rise of temperature. The tenderness is present. Tenderness is noted in the right iliac fossa. There is an solitary mass of size 10 into 12 centimeter palpable in the right iliac fossa region, which is firm in consistency. Consistency globular in shape. The surface appears with smooth surface. It does not move up. It does not move with respiration. Intrinsic mobility, side to side mobility is present. It doesn't move up. Up and down. The lower border of the mass is palpable. On extend, ma'am. It's present from the present in the right iliac fossa region. It is 5 centimeter above the mid-inguinal point, and 5 centimeter above the mid-inguinal point. The lower extent is 5 centimeter above the mid-inguinal point, and the upper extent from the costal margin, it is around costal margin is around 15 centimeter, and from costal margin is around 15 centimeter. From the midline, it is around 4 centimeter towards the right, the extent medially, and 4 centimeter from the right mouth. And on leg raising test, the mass becomes less prominent. There's no mass becomes less prominent. It's an intraperitoneal. So based on this thing looks like abdominal pathology. And then patient on knee, elbow, on tilt test, when turning the patient towards the right and knee elbow test, it feels like intraperitoneal only. It falls forward, doesn't disappear. So it feels like intraperitoneal pathology based on that. On percussion, the tympanic note is heard all over the abdomen. Even over the mass, tympanic note is present. On auscultation, bowel sounds are heard. The good bowel sounds are there. Per rectal examination, sphincter tone is normal. There is no the sphincter tone is normal. The normal fecal staining of the gloves. There is no melena noted, and is this. So
You're done with the examination. The faculty, please.
So, in the examination, palpation, so all the borders are well made out, is it?
Yes.
Okay. So, how do you start the palpation, superficial palpation and deep palpation? What are the things you look for?
So, first we starting for first on inspection, we have to see if the shape of the contour of the palpation, sorry.
Superficial palpation and deep palpation.
Superficial palpation, we start from the quadrant opposite to where the patient has the complaint. So she has complaint on the right iliac fossa. So first we'll just to feel the From the left hypoquadrant, we'll start to see if abdomen is soft or not, if it yields on palpation, if any other tenderness is there or not, and superficially then, and then
so what exactly you look for superficial palpation? What are the things?
If tenderness is there, localized temperature, anything is there, and if mass is palpable or not palpable.
Tenderness, guarding, any
guarding
mass
rigidity,
guarding and rigidity, and any mass
mass
is
is
felt.
there.
So on superficial palpation,
Tender mass.
Tender mass, yes.
any mass is felt on superficial palpation.
Super is there.
So it is easily palpable.
Easily palpable, yes.
In the right iliac fossa.
Yes, sir.
And all the borders are well made out.
Made out.
Okay. Did you check for change in the position of the mass when you make the patient change the position left lateral and right lateral?
Yes, sir. On tilting, same. Yes, sir.
So whether the mass moves or it remains in the same position?
Mass moves a little forward, like doesn't stay fixed.
In the lateral debicuitous position.
Yes.
In the right and left. And where in which condition do you examine this test specifically?
And, just to differentiate between intraperitoneal mass and retroperitoneal, to do this test.
Do you understand the right lateral position and
Right
left lateral position?
Yes,
Okay, knee elbow is a different. Okay. So in which condition for which pathology this test is performed, especially when mass is there? In that also in particular area. The other postgraduates can participate in the interaction.
You can answer from there.
Anyone can volunteer and you can answer.
Even as students, we were in the front, and even as faculty, we will be in the front only. I think this trend will continue.
Have you heard of mesenteric mass?
Mesenteric.
So what is the speciality about it?
Freely mobile in the.
In which direction?
In all direction. Perpendicular to the root of the mesentery.
Perpendicular
to the attachment of the mesentery. So do you know the attachment from where to where it extends?
From the left side of L1 to the cecum ileocecal junction, it extends. The ASI is not sure.
ASI?
No, it's not sure.
Our association is also ASI, so please use.
Anyone else can answer? The attachment of the mesentery? It's very important. Without that, you can't actually proceed further, because any mobile mass, we have to rule out whether it's an omental cyst or mesenteric cyst based on only mobility. If it's perpendicular to the attachment of this mesentery, then it becomes mesenteric cyst. Anybody? Sacroiliac joint. Somebody raise your hand, please. I think we should have some chocolates here, so that at least whoever is answering will give them some good cupboard. May I request the organizing team to get us some chocolates, if possible? There he is giving something. Oh, Mike.
Right.
I thought he was giving him a chocolate.
It's from the right sacroiliac joint. Attaches to the right sacroiliac joint. From
Examiners?
the duodenojejunal flexure.
Do you agree, sir? For his answer?
Anatomically, it is okay, but clinically how, and on radiologically on X-ray also, you should be able to make it. What are the landmarks?
So just about 2 centimeters posterior medial to the anterior superior iliac spine.
So can you please help them, sir?
So as you know that the jejunal coils are located in which quadrant of the abdomen?
Coils.
There are only 4 quadrants. Don't think too much. Only 4 quadrants, 9 regions.
Hypogastrum.
Quadrant.
Quadrant.
Which quadrant? Just think anatomically.
Right and
Is it
left,
right side or upper or lower?
Lower.
Jejunum. He's asking jejunum. Sir is asking jejunal coils. It's immediately after duodenum, right? So where is the duodenum? It's in the upper or lower?
Lower.
So, I'm stuck now. 4 quadrants. Abdomen is divided to 4 quadrants at the level of the umbilicus, right? So stomach.
Right lower quadrant.
Okay. Sir Haley, sir, please.
As you know, the jejunal loops are located in the left upper quadrant and the ileal loops are located in the right lower quadrant. So as you know, the mesenteric attachment, the way through that the mesenteric vessels run and supply the jejunum and ileum. So the attachment extends from the upper left to the right lower. So exactly the landmarks.
Yeah, above and to the left of the umbilicus and below and to the right of the umbilicus. So
Okay.
that is the grossly on the abdominal wall. You can see that way. Sacroiliac joint you can't see from outside.
Yeah.
So bony attachments, you were right, but on the surface marking, because you're not going to see the sacroiliac joint, you're not going to see the L1.
Sir,
So
we,
this
sir,
is a surface marking, which sir has explained. We have Balian love, sir, here. Mike, please, Mike.
Into the root is only 25 centimeter. It extends like this, and near this one becomes 6 meter. So it is mesentery is very short.
Very
On the
short.
left L1 is at right sacroiliac joint with the root. Of course, left side jejunum. This is the thing.
Yes. Sir, all are giving explanation like hand, hip, fan, how it fans out. Good attempt, doctor. Definitely you are better than the people who are hesitating. You should start answering. Yes.
One couple of points regarding your presentation. Actually, you didn't really specify the right lateral border of the mask. One other thing is with regard to digital rectal examination, specifically you mentioned about no melena.
So we'll finish the abdomen, then we'll go to PR, sir.
He finished with the
abdomen. Any other questions in the abdomen? Done. He also said moves with respiration. Any comments from the faculty?
All the borders are well felt, you told, no? Yeah. Even lower border.
Lower border.
From costal margin and from the inguinal ligament, you told 5 centimeter and above is 15 centimeter.
15 centimeter.
So what has remained now? Costal margin to inguinal ligament, almost 20 centimeter is taken by this one. And the mass is of how much size?
Mass is 12 into 14 centimeters.
No, movement with respiration. Comments, sir, please.
It's moving with the respiration.
It doesn't move with
He said it doesn't move.
Doesn't move with respiration.
And movement with your hand?
Side to side is movement is there.
See, there are some examination headings will be there in the textbook. According to your case, you should present. Okay. So as it is in the mass is arising in the right lower quadrant, is there a need to tell about whether it moves with respiration? Yeah. It's like sebaceous cyst on the forehead and telling no peristalsis. The UG students, many of them, they just write down the headings in the DAS and they just present, absent, daily. It should not happen with the PGs.
There should be some application, right? So when does it move? It isn't totally in relation to the diaphragm. We are at the right iliac fossa. Diaphragm is there. So you should not even comment about that. Okay? Anything, say, if the mass was in the right lumbar region, it's close to the right hypochondrium or mass in the hypochondrium, then we'll talk about it. Or in the upper abdomen. This is totally in the right lower quadrant, well away from the diaphragm. We should not even comment about the diaphragm, right? Don't even utter.
Clinical approach is entirely different. If in emergency this thing patient comes up, what is the case? Pain abdomen. What is the diagnosis? Pain abdomen. This is not an attitude of a doctor. Doctor, when patient comes, you have to go through everything, and whatever patient, don't tell the symptom as a diagnosis. So same thing in examination, you have to very particular.
So anything else regarding examination he has to comment, sir? And when we talk about extent is not, you don't have to measure from hypochondrium and all that. Tell whether mass is in the right iliac fossa, whether it's extending into lumbar region, extending into umbilical region, extending into the suprapubic. That's what we exactly mean when we talk about extent.
You can also add whether the mass can be pushed into the pelvis.
Yes.
Because you've been harping on ovarian cyst right at the beginning. So that's one other thing that you should see. And when on moving the mass to the opposite side, whether there is any pain in the pain that gets exaggerated. And even few other things you have not mentioned. For example, if you are finished with the your
abdomen
examination,
is finished, sir.
Examination is finished. I was commenting about the. Yeah, other masses in the abdomen.
Yeah.
Whether other masses are palpable. Then digital rectal examination you mentioned about specifically about negative finding for melena. It's here lower abdomen mass you really don't look for a melena. Altered blood may be fresh blood, and a few other points you have not examined. Left supraclavicular lymph node you didn't specify at no point of your presentation. What about the spine? What about the lumbar area, lumbar angle? And these are the findings you have to mention. You cannot miss out on this.
Rectal examination, and I think, and in the lower abdomen mass, if it is lower border is not felt, you have to ask the patient to pass urine and examine again. In the upper abdomen mass, upper border is very crucial. Lower abdomen mass, lower border is very crucial, deciding factor. Whether it is going to the pelvis or not, that point is very crucial in the lower abdomen mass. Like Madam rightly told, movement with the respiration is mainly in the upper abdomen mass, not below the level of the umbilicus.
No.
Percussion here to
Yeah,
go.
we were just coming to that. So you missed.
You are sure that lower border is well felt?
Yes.
Sure, no?
Yes.
Because our diagnosis depends on that now.
Yes.
Oh.
So you missed telling about hepatomegaly, splenomegaly, and please don't mention organomegaly. All organs don't enlarge. There are many organs inside the abdomen. They don't enlarge. It's only hepatomegaly and splenomegaly which are involved as a systemic organs. So when many of you say organomegaly, means bowels don't enlarge like that as a general. I'm just telling. So no hepatomegaly, no splenomegaly, free fluid. Very important was the free fluid. So no shifting dullness should have been mentioned. Okay? And what was the note on the mass, on percussion, whether it is tympanic or whatever. You should have mentioned that. Tympanic note. Yes. Again, all of you know the basics will not go into when it is tympanic and when it is dull. What else he missed? Renal angle, sir was mentioning. Renal angle should have been mentioned. And per rectal and for her, per vaginal examination was important because you've been repeatedly saying about ovarian mass. Yes. So per vaginal examination first and then per rectal examination. All these were missed. Anything else, sir? Have I missed anything? Supraclavicular fossa. So the examination of the abdomen is complete only after examination of the renal angle, supraclavicular fossa, in males, external genitalia, per vaginal in females, and per rectal in both genders. If these are not examined, examination is incomplete. And another thing is in females, please do not say on inspection external genitalia is normal. Please. The organs concerned are inside the abdomen, so it does not hold good for females. In males, yes. If you don't examine the external genitalia on inspection, because the testicular tumor can present as mass in the abdomen, and if you don't examine genitals, you may be missing a testicular mass. So that's the reason. The corresponding organs in female is intra-abdominal. So please, in females, do not say inspection external genitalia normal. In females, you will only talk about for pelvic mass per vaginal examination. For upper mass, you may not require to do PV. But per rectal examination is a must for both the genders.
A similar
Have
mass,
I made it clear?
Suppose there is another mass on the left side. Would you have a few other examination? Even otherwise, you should have done that examination, considering her gender. Elderly lady, can you think of any metastasis in the abdomen, in the pelvis? Krukenberg's tumors.
Ovarian
Breast examination should have done.
Okay. So now shall we go to diagnosis? We have just 7 more minutes. Come to the diagnosis, please. What's your diagnosis?
It could be malignancy involving the cecum or the appendix is mostly what I'm thinking of.
What is more common, cecum or appendix?
Cecum.
So stop at that, okay? I'm just trying to moderate. You don't talk about appendix, you will be in trouble. Examiner's
Why are you
case.
using first the term malignancy? Why not you're just coming out with the pathology arising from the cecum?
Why you are telling only malignancy? You specify, which is common.
Because she has lost, considering her age, because she is given history of loss of weight, loss of appetite is there, and she's not, and she looks pale also. Anemia is there. Because of that, I was thinking that she's could be malignancy.
No, you specify. No, why you are put a very vaguely which malignancy you are considering? You can always
cecum.
Consider,
he says cecum, sir.
Cecum. Which type? You can tell carcinoma cecum or GIST or something else. You have some idea. You have got this one, which is common. Put it like that in that order fashion. Telling only as a malignancy is, I don't think, accepted. You need to go little more deeper and tell the diagnosis.
So his diagnosis is carcinoma cecum.
Carcinoma cecum.
So please proceed with the next question.
Any other disease, same thing. History of loss of weight and appetite is this thing, other than malignancy.
Yeah, other than malignancy, yeah, tuberculosis.
So,
where will the mass be in tuberculosis?
Iliocecal region.
It will be little higher up. It will be more in the lumbar region.
Mass is mobile.
For the want of time, we are just
mass is mobile.
Mobile, side to side, it's mobile. Not
Is ileocecal tuberculosis usually it will be mobile or not? Fixed. Usually pattern.
It will be fixed.
It is not mobile, no, because adhesions are there. Mobility is very restricted, almost nil. So if something so freely mobile is less likely to be tuberculosis. Okay.
Any other benign condition would you like to think there?
Would you like to give differential diagnosis? So any other benign condition?
Any infective pathology?
If she has typhoid.
Infective pathology common there. Appendix, you're going on saying carcinoma. Tell what is inflammatory pathology. Appendicular mass.
Any other infection? Parasite infection.
What comes there? Some parasites say, sir.
Parasite also.
In right iliac fossa. See, DAS, if they had read clinical methods of DAS, it's beautifully given, the differential diagnosis for mass. So please answer, sir. There's less time. Amoeboma, there are. So these are the things you choose there. And so can we go ahead with the investigation? So keeping carcinoma cecum as the first diagnosis, points in favor are loss of appetite, weight and mass, and age. Okay? Fine.
Why this carcinoma of cecum present only with mass and hardly any GI symptoms?
What is the common presentation in carcinoma cecum?
With bleeding PR, she is present with bleeding PR, anemia, weakness.
Loss of weight, loss of appetite, anemia.
Anemia.
They don't require to have a GI symptoms, at least in initial phases. Unlike in the left side.
Why do we ignore ARS? We start giving them medicines which is required for anemia, come back another 4 weeks later or something. Then they will have land up another more problem. Then they will come for loose stools, that thing, this thing gets evaluated. Then the mass gets come back there. Then by the time you put your hand inside there, they already late. Answer the question very specifically, straightforward.
It's a specific reason why the right side colon and the left side colonic presentation, malignancy presentation is different. That is the point here. Just to try to explain why, carcinoma cecum present differently compared to.
Which will present late? Carcinoma cecum or left side growth?
Right side growth.
Right side growth. Reason you know, because it won't cause obstruction. And cecum is very much, the size is bigger, wider, lumen.
Sir, your question, please give the answer, sir.
That's what. The patient is presenting only with pain, and on examination you are finding there is a mass, and as such there are no other GI symptoms. So the possibility of carcinoma of cecum is present. And of course the severe anemia or anemia should have been much more. On your general physical examination, that finding would have been there.
So basically the right side malignancy presents with vague symptoms, especially like general symptoms, because the lumen is wide and the stool is liquid. So obstruction does not happen. When it comes, by the time it comes to the left side, they'll present with obstruction. Because two reasons. One is lumen narrowed and hard stools. The stool becomes solid by the time it comes to the left side. So they present with obstructive symptoms.
And also the type of pathology, apparently the left-sided colonic growths are more constricting type.
Constricting variety.
Encircling type, right side is more of exophytic. This is what pathology is.
So keeping this in mind, now we'll proceed with investigations.
Have you heard of mucocele of appendix?
Yes, sir.
What is that?
So,
does it have any significance here?
Yes.
What is mucocele of appendix?
So,
I an answer from the audience too, please.
Anyone mucocele of the appendix? What is mucocele of appendix?
You should help your friend. He is standing in stage, so he's probably.
Anyone
tensed also.
mucocele of the appendix? What is mucocele of appendix?
Okay, shall we proceed with the investigation, sir?
You can think of colic interception in this patient.
Yes, sir, but
can present as a mass mark.
Yes.
Malignancy, it's how to explain the pain. Could happen. Yeah. Investigation, sir. Shall we proceed? Okay. Questions from your side. How will you start with the investigation? Please don't tell
Only
the routine.
this patient, how
What
you are
is
going to
specific
approach
for
for your
her?
diagnosis?
First, we like to get an imaging done based on the imaging. Then CCT ultrasound abdomen first. If that doesn't show anything, then progress to CCT abdomen pelvis. Based on the findings, my plan for colonoscopy for this patient, and then colonoscopy and biopsy to get a diagnosis.
Do we have the reports here?
Don't have.
No.
So on ultrasonography, would like to know the origin of organ, from which organ it is
Origin.
originating, the pathology. And I'm just telling on ultrasonography what are the things you would like to know. So one is the anatomical organ from which this pathology is originating, and any characteristic feature which can be picked up by sonography of those pathologies, that also can be diagnosed by ultrasonography. And also your differential diagnosis like pelvic, any other condition which is associated with it, and ascites and other lymph nodes you can pick up by sonography. And of course CT scan is going to give you the much more clear picture. And if it is originating from the cecum, the mass, then colonoscopy.
If it is wall thickening is there, you can pick up in ultrasound. Usually if it is malignancy, definitely on ultrasound they'll the thickening of wall. So from that you can think probability of your diagnosis. That is what you are already made diagnosis is adding your it will help for your further management, what you can do.
Ultrasound will also tell you whether there are anything else.
Any other pathologies that
What?
lymph nodes are.
Be very specific, quickly. 1, 2, 3. It tells the mass, anatomical region. What else? Mass first. Second. You said jaundice, no, in your history?
Liver mets, anything mets.
Metastasis, that's more important. Liver mets. Then next. These are all you should just tell.
Yes.
Abdominal distension you look for.
Bowel loops.
Ascites.
Ascites is there.
Yeah. Then any ovarian. I mean, if it was primary, not otherwise. So ultrasound will only give you even diagnosis. Like if it is stage 4 also, it will tell us. Then probably we can avoid the next set of investigations. Right? We can avoid CT scan. If ultrasound does not show any of these metastases, then you will proceed with CT. But before that, if it is cecum, as the faculty said, colonoscopy and colonoscopy directed biopsy is important. Any other questions, sir, from your side? We are actually run out of time.
Madam, we can have 4 more PGs here. We like this faculty we are sitting now. On that side, 4 chairs, 4 more PGs. That is, we can think, association should think.
We actually had a panel discussion last year with the PGs.
No.
PG panel discussion.
Yes, sir.
Yes, sir.
So with him, another 4 PGs should be made to sit here.
Yes, sir, I agree with the sir. Actually, I had gone to a North India CME. There 4 PGs were sitting. And we 4. It was better because many people get interacted.
Any other questions from the students? Because for want of time, any other questions from your side? What you should ask, what you should not ask? No more questions from your side? So shall we wind up? Okay, if it's coming as CSCOM, how will you proceed? And no metastasis elsewhere.
You can go right hemicolectomy with iliotransverse anastomosis, we can plan, followed by chemo.
What do you call it? Properly give a correct word for hemicolectomy.
At this point, do you want any other additional investigation? Ma'am gave you the diagnosis carcinoma cecum. So anything you want to know?
To rule out metastasis, any other?
It will
No.
it will help you in the
Help
follow-up
in-
of the patient.
Any blood investigations?
Blood investigation.
Which one?
Tumor markers, you have to get
Yes.
CEM.
Yes, please be clear in it. So CEM, tumor markers. And what hemicolectomy is that?
Right.
Anybody?
It is simple or radical?
Answer is given.
It is simple or radical? That's all.
It's a radical hemicolectomy.
Right radical hemicolectomy.
So,
Or right hemicolectomy with the complete mesocolic excision. That's also fair enough. And transverse anastomosis.
oh, we'll wind up now.
Suppose
So,
it comes biopsy, hyperplastic tuberculosis. What can the treatment?
The
if it comes as tuberculosis,
Texturoplasty.
In the surgery for ileocecal tuberculosis, hyperplastic ileocecal tuberculosis, and carcinoma of cecum. Both you are doing right hemicolectomy. What's the difference? I think that's what is the question.
We'll see carcinoma cecum will remove radical.
so it is radical hemicolectomy. That means till the root of the mesocolon we remove.
Total.
Whereas in tuberculosis we can do even local resection anastomosis or a simple hemicolectomy, but under the umbrella of anti-tubercular treatment, since the patient is not in obstruction right now. So treat them for 14 days or 2 weeks and then do the surgery to relieve the obstruction. Okay.
More in ileocecal tuberculosis than carcinoma cecum.
Okay, no more questions from the audience? Fine, shall we wind up? Yeah,
Yes,
we're
ma'am.
already late. Thank you.
Koshi.
Thank you for the
Thank you,
clinically
Dr. Koshi,
enriching
and I thank the panelists here. Thank you so much.
Thank you for the clinically enriching presentation to our esteemed chairpersons and moderators. We now request Dr. Kalaivani and our chairpersons to kindly proceed towards the photo booth for a group photograph and to collect their certificates of appreciation. I request, yes ma'am. I request Dr. Gopinath Pai, Professor HOD, KVG Medical College, Sulia, to do the honors. We'll be beginning with the paper presentations in another 5 minutes.
Our next session would be a lecture on principles of pancreatic resection by Professor S.S. Prasad. To chair the session, we have Dr.
Dr. Abhinandan and Dr. Kumar Krishna. The first presenter is Dr. Shreyas Gangadhar, and after that we'll have Dr. Vivekanand Desai, FRP 105. Kindly be ready with your presentation. Judges for this session, session number 5, Hall A, would be Dr. Professor Leo Francis Toro, Dr. Abhinandan, and Dr. Kumar Krishna. Judges, please note, and presenters, please note, the timings allotted would be 5 plus 1 minute. So the first bell would ring at 5 minutes, and the concluding bell would ring at 1 minute later. So that is 6 minutes. Dr. Shreyas Gangadhar. He's not there. Okay. 12 it will start. No, we have. To judge this session, we also have Dr. Satish Rao, Dayanand Medical College, Bangalore. HOD and Professor, Dayanand Medical College, Bangalore. This is the same order, yeah. One more is there. Pen you want? Is it ready, Kaushal? Okay. Dr. Shreyas, the first participant is Dr. Shreyas Gangadhar. Judges, please note this is FRP 94. Judges and presenter, please note the timings. It would be 5 + 1 minute. So the first bell at 5 minutes and the next bell at 6 minutes.
Good morning, everyone. Dr. Shreyas Gangadhar from Mysore Medical College. My topic is the study of gallbladder wall thickness in predicting difficulty in laparoscopic cholecystectomy. Introduction. The most frequent biliary pathology is cholelithiasis, and in Western world, gallstones affects 10% to 15% of the population, while the majority, that is more than 80%, do not exhibit any symptoms. Gallstones have been found in 20% of female and 8% in males, over 40 in the United States autopsy series. Globally, there are significant regional variations in the occurrence of gallstones. It is estimated to be approximately 4% in India. According to an epidemiological study, the incidence of gallstones is 5 times higher among North Indians than in South Indians. For the great majority of patients with benign gallbladder disease, both in elective or interval and emergency conditions, laparoscopic cholecystectomy is recognized as the gold standard. The advantage of laparoscopic cholecystectomy over open cholecystectomy are early return of bowel functions, less postoperative pain, better osmosis, shorter duration of hospital stay, earlier return of full activity, decreased overall expenditure. The rate of post-op infections seems to be lower. Nonetheless, the conversion rates usually ranges from 1.5 to 19%. It is necessary to assess the several aspects that contribute to challenging laparoscopic cholecystectomy. The ability to accurately identify an individual patient's risk for conversion based on pre-op information can result in more useful and accurate preoperative counseling, improved operative room scheduling and efficiency, stratification of risk for technical difficulty, and appropriate assignment of resident assistants may improve patient safety by minimizing time to conversion and helps to identify patients in whom a planned open cholecystectomy is indicated. By minimizing time to conversion and identifying patients who should have an open cholecystectomy, the ability to accurately determine a patient's risk for conversion based on pre-op information can lead to more effective and useful pre-op counseling, better scheduling, efficiency in operating. By minimizing time to conversion, the objective of my study is to check GB wall thickness as a predictor for difficulty in lap cholecystectomy. The materials which are needed, it's a prospective observational study which was conducted on 50 patients with cholelithiasis which were admitted in the Department of General Surgery. Inclusion criteria were all the patients posted for lap chole at MMC in a single unit and operated by a single surgeon. The exclusion criteria include all cases of open cholecystectomy, proven congenital anomaly of GB, previous abdominal surgeries, and immunocompromised patients. The methodology is all cases satisfying the inclusion criteria were chosen and informed consent was taken from the patient. Data was collected with the help of a performer containing following details such as age, gender, IP number, clinical examination, and results of relevant investigations, that is GB wall thickness. Then when the patient was posted for surgery. Then intraoperatively, a timer was set to record the timings taken from various steps of dissection. The timer started with the skin incision for first port insertion. Then once the peritoneal cavity is entered and Calort's triangle dissection is started, till the triangle of Seti is demonstrated with cystic plate and the duct is clipped and cut. The total operative time was hence calculated, and simultaneously calculating the time taken for each step of surgeries. The time taken for dissection in various steps has been considered to be the criteria in predicting laparoscopic cholecystectomy in the study. Statistical analysis, proportions, mean, standard deviation, and median. IQR was used to express the data. Data was represented in the form of tables and graphs wherever necessary. Independent t-test and one-way ANOVA was used to analyze the data for a statistical association between continuous variables and outcome variable. Pearson's correlation was used to assess correlation. P-value less than 0.05 was considered statistical insignificant. In our study, difficult laparoscopy came out to be 24 in number, which amounted to 48%. Easy laparoscopic came out to be 26 in number, 52%, total of 50 cases. In our study, out of 50 cases, we had 24 cases that were difficult, which had a time span for more than 60 minutes. We had taken the time of 60 minutes as a cutoff. Here is the mean and median. In our study, out of 50 GBs that were operated, the range of GB wall thickness was 1.5 to 6.4 mm, mean being 3.2 mm. The higher GB wall thickness would make it its dissection of the liver bed difficult, and also very thin wall GB tend to get perforated with cautery usage and result in bile spillage into the peritoneal cavity. In our study, the mean time was taken to be 59.8, and mean GB wall thickness was 3.19 mm. In this correlation analysis, R value was found to be 0.47, P value was less than 0.01. So our conclusion, GB wall thickness is a predictor of difficult laparoscopic cholecystectomy with potential application in preoperative risk assessment. As GB wall thickness more than 3.65 should be considered in clinical discussion, making to optimize patient care and surgical success.
Yes, one thing is about time management, you said, no?
Yes, sir.
The problem is your introduction was too long.
Yes.
So when you came to the technical aspect, we are not able to get much, and you are not able to elaborate much, one.
Yes.
And other criteria you say you have given a lot of importance to duration of surgery.
Yes, sir.
So what are the other criteria to call it as a difficult gallbladder? That needs to be elaborated a bit more.
Yes, sir. Mainly dissection of callus triangle.
Probably you had it, but the time part, what I am telling you.
Yes, sir.
So it's mainly what the primary table you are showing is it's the duration of surgery. There may be a lot of other technical factors which may come in to take into play duration of surgery. And again, as you said, gallbladder wall thickness. So
Yes.
that's also one criteria, fine. That is one of the criteria. So what about the surrounding tissues, adhesions, flimsy adhesions, or anything else, which itself will take more time for us to reach to the primary target of the gallbladder. So that also has to be accounted for in your study.
Yes.
One small comment about your slides, full
Yes,
of
sir.
information.
Yes, sir.
I think you know how to make slides. Each slide should not contain like that. So much of information. So write one or two. Second thing is about the timing of surgery. When did you operate these patients with acute cholecystitis?
Sir, all of these cases were taken as elective cases, sir.
Elective cases.
Elective cases.
So that means if somebody has an acute cholecystitis,
Yes, sir.
usually there are two school of thoughts. Say which one you have taken? Early surgery or interval?
Interval cholecystectomy.
Interval cholecystectomy.
Did you take consent for open cholecystectomy?
Yes, sir. Conversion were consent for taken for all the cases, sir.
Is it only the thickness of the gallbladder was the criteria for opening, or is it because of some other reasons?
Sir, intraoperative difficulties like GB perf, bile leakage, and additions, sir. Too many additions were considered, and difficulty led to conversions into opens. Sir.
Bleeding? Did you accustom?
Bleeding also, sir.
Is all the surgeries been done by the same surgeon?
Yes, sir, same surgeon.
Oh. Slide should be improved. Yes. You can't bombard all the things on the PPTs.
Yes.
Okay?
Yes.
Take it.
Thank you, sir.
Thank you, respected judges.
Thank you, sir.
Please note, this was FRP 94. Up next, we have Dr. Vivekanand Desai, FRP 105. Dr. Vivekanand Desai, FRP 105. After that, we'll have Dr. Basveshwari, FRP 110. Kindly be ready with your presentation.
Good morning. I am Vivekanand Desai from Chamarajanagar Institute of Medical Science. Today I am going to present a paper on role of serum albumin in evaluation of post-operative outcomes of post-operative emergency abdominal surgeries. So coming to the introduction, we all know that nutrition is critical for identifying the patients who are at risk of developing the post-operative complications as a result of severe malnutrition. So one of the routinely used marker to assess the nutritional status is serum albumin. So serum albumin of more than 3.5 grams per deciliter, it implies adequate protein stores for the normal physiology. Several studies have shown that the patients with a poor nutritional status, they are at increased risk of complications such as surgical site infection, wound dehiscence, anastomotic leakage compared to their counterparts. So the aim of this study is to evaluate the relationship between the post-operative, between the pre-operative serum albumin levels and post-operative outcomes in the emergency abdominal surgeries. So it was a prospective analytical observational study which was conducted from January 2024 to March 2025 in our institute, Chamarajanagar Institute of Medical Science. It was conducted on 50 patients who underwent major emergency abdominal surgeries. So I included the patients who underwent emergency abdominal surgeries in our setup. Exclusion criteria excluded the patients whose age is under 18 years with altered LFT, who are on CKD, who are on steroid treatments, and who is with diabetes and seropositive cases. So now let us come to the results. In our study, the most common indication for which we took for the emergency abdominal surgery, it was the peptic ulcer perforation. So out of 50 cases, there were 24 number of cases pertaining to the peptic ulcer perforations. Out of these 24 cases, 9 cases went on to develop the post-operative complication. And there were 13 cases of intestinal obstruction, out of which 5 developed the post-op complication, and 8 were appendicular perforation, gallbladder perforation were 3, and cecal perforation were there 2 cases, out of which 1 developed the post-op complication. So, what were the post-operative outcomes in my study? So, in this study, total number of cases were 50. So, out of these cases, 18 has developed the post-operative complication. In these 18, there were 12 cases who developed the surgical site infections, which constitutes to the 24% of the cases who developed the surgical site infection. And 4 developed the wound dehiscence, remaining 2 anastomotic leakage, which constitute to the 4%. Okay, so total out of 50 cases, 18 developed the post-op complications, which mainly includes surgical site infection. Now, coming to the serum albumin level and the post-operative outcomes. So in this study, we all know that the normal level of serum albumin is 3.5 to 5.5. So the cases whose serum albumin level was more than 3.6, there were 8 cases and only 1 developed the complication. But whose albumin level was between 3.2 to 3.5, 31 cases were there, out of which 11 developed complication. Okay, so and the serum albumin level, whose serum albumin level was less than 3.2, out of 11, 6 patients developed the complication that constitutes to the 54.5%. Okay, so it clearly indicates who are having very low serum albumin, they developed highest percentage of the complications. So these are some comparisons where all other studies shows that the albumin level, when it is less than 3.5, the morbidity increases. So it is just comparison of other studies. Coming to the discussion, albumin, it serves as the main serum binding protein in the body. It takes part in various metabolic activities across the body. So it constitutes to the 60% of the total protein in the body. Okay, so we know that the main function of the albumin is to maintain the oncotic pressure, okay, at the capillary level. And homeostasis of various organ systems like circulatory, renal, immune systems, they all depend on the normal albumin level. Okay, so malnutrition, it is one of the major risk factor which leads to the poor outcome with increased morbidity, and serum albumin, it is a direct indicator of this malnutrition. Okay, so in response to the various stress factors like infection, trauma, surgery, there will be increased level of cytokines like tumor necrosis factor, interleukin-6, where in these, in turn, they will increase the vascular permeability and decrease the anabolism. Okay, so increased vascular permeability, they will cause a leak of albumin into the extravascular space, they will decrease production, leads to hypoalbuminemia. So although serum albumin level, it influences both emergency as well as elective abdominal surgeries, but here I took a study for 1.5 years in our tertiary care center, 50 cases, including emergency surgeries that met the inclusion criteria. So to conclude, albumin is an excellent prognostic predictor due to its capacity to detect the proteinuria malnutrition, which is not always linked to reduced body weight, and it may not be clinically recognized, but it is associated with the considerable increase in the morbidity. Albumin level less than 3.2 was found to be the major detrimental of subsequent sequel as well as mortality in the post-operative period. Thank you.
So, have you done the pre-op albumin levels? Normally, do you do for the?
Yes, sir. For all cases which we undertake to the emergency surgeries, we do pre-op.
So, a straight question is: would you advocate? Suppose the albumin initial albumin level is low, would you advocate albumin transfusion in
No, sir.
immediate post-op or this one according to you?
No, sir. Because
is it going to be helpful?
Since we are taking it as emergency cases.
No, you know, you are taking as emergency case. You know that as your paper says, predictor low albumin level is going to give rise to more morbidity. Suppose your pre-op screen says that albumin is low. So immediate post-op or something, would you advise albumin transfusion?
If it is
because
very
we have to
less,
conclude something from the paper, no?
If it is very less than 2.5 albumin, then we should start albumin infusion. If it is at moderate level from 3 to 3.5, then we are going to start from protein supplements.
Okay. And another thing is regarding the standardization of the patients, because some of them like perforation may just need an ordinary perforation closure, whereas some of them may need resection anastomosis. And colonic surgery is another category where itself the mortality and morbidity may be higher. So that needs a bit more elaborate study, what you have done to come to a proper conclusion regarding the albumin. No? Yes.
It's a prospective study, observational study. Yes, sir. Two colon perforations, sir. Other. Like, sir, colon perforation, they had more complications, sir. With around 2 cases were there. 1 developed complication, so it constitutes 50%, sir, in our study. No, because it was related to serum albumin and
in your study, when we consider healing and complication, in addition to the albumin, there are other factors also can influence, like any comorbidities, other micronutrients as well as. Have you made any comparison whether the increased complication rate just because of the albumin, or if they had any additional
so those things, other comorbidities I have excluded in exclusion criteria, sir, because albumin, if other factors are there, then along with albumin, they will also cause the increase the rate of complications. So only albumin level, low albumin levels I have taken into consideration.
Without any comorbidities?
Comorbidities I have put it in exclusion criteria, sir.
Okay.
So that to know the exactly how much albumin causes, low albumin causes complications.
Okay.
One more clarification. You have excluded deranged LFT as exclusion criteria. Does albumin comes under LFT?
Yes, sir.
Then
no, sir. Like due to the other comorbidities, decreased LFT, sir. Like
you are
CKD.
Considering only bilirubin and
yes, sir.
SGOT, SGPT, not albumin in that.
No, sir.
Is a surgical site infection related to your low albumin level, or is immunity?
It is due to the low albumin level which caused the surgical site infections.
Okay, thank you.
Thank you, judges. This was Dr. Vivekananda Desai, FRP 105. Next, we have Dr. Basaveshwari, FRP 110. Dr. Basaveshwari, FRP 110. Next, we have Dr. Raj Vikram, FRP 130. Dr. Raj Vikram, FRP 130. I request Dr. Vedansh, FRP 136, to kindly be ready with their presentation. Dr. Raj Vikram, FRP 130, will be presenting now.
Good afternoon, everyone. So I'll be presenting my study, use of routine UGA scopy as a tool for preventing post-cholecystectomy syndrome. Okay, coming to the background, cholelithiasis or the gallstone disease is one of the most common presentations of abdominal pain by patients coming to the outpatient department and emergency department worldwide. It is, however, difficult to distinguish whether the dyspepsia or the other GI symptoms might be due to exactly the gallstone disease, or it might be due to any other upper GI pathologies that can be detected by routine UGA scopies. So to help in better management of symptomatic patients, performing an UGA scopy before lap cholecystectomy can help diagnose other GI pathologies. And post-cholecystectomy syndrome is known to occur in these patients even after successful laparoscopic cholecystectomy due to either biliary or non-biliary causes. And post-cholecystectomy syndrome is persistence of biliary colic or abdominal pain in the right upper quadrant after cholecystectomy procedure, along with any other gastrointestinal symptoms similar to that of cholecystitis before the procedure. And these symptoms often mimic diseases like gastritis, duodenitis, gastroesophageal reflux disease, peptic ulcer disease. Differentiating this plays an important factor, as gallstones may be an incidental finding and patient might have persistence of symptoms in the post-operative period also. So upper GI endoscopy helps identify the non-biliary causes of these symptoms, and early diagnosis allows for more timely management. It reduces surgical morbidity and patient dissatisfaction. So the biliary and non-biliary causes of post-cholecystectomy syndrome may be understood by use of comprehensive patient history physical exam, laboratory testing, abdominal imaging, and or endoscopy. The causes of PCS may be either biliary or non-biliary, biliary being bile reflux, sphincter of audate dysfunction, retained gallstones, bile duct injury, or cystic duct remnants. And non-biliary factors would be our peptic ulcer disease, esophagitis, GERD, duodenitis, and hiatus hernia. So differentiate diagnosis of post-cholecystectomy syndrome may be challenging and time-consuming. So these symptoms might arise from various GI organic disorders. My aim of the study was to evaluate the role of routine UGI-scopy in symptomatic cholelithiasis patients undergoing lap cholecystectomy. My objectives were to evaluate other different causes of dyspepsia in these symptomatic cholelithiasis patients, to determine whether the prevalence of associated other upper GI pathologies, assessing the correlation between symptom severity and endoscopic findings, and identifying the advantages of preoperative diagnosis and concurrent management of these pathologies. So methodology, it was a longitudinal cohort study. Total sample size was 135 patients collected from June 2023 to November 2024. Setting of Department of General Surgery and Gastroenterology in KSCASI. My inclusion criteria was symptomatic cholelithiasis patient proven with ultrasound imaging who had underwent upper GI endoscopy 1 day prior to laparoscopic cholecystectomy. My exclusion criteria was patients with complicated gallstone diseases such as pancreatitis, cholelithiasis, cholangitis, cholecystitis, empyema of gallbladder, and any GI-induced gallstone-induced pancreatitis. And other patients who are unable to give consent or medically unstable were excluded. My follow-up period was postoperatively at 1 week, 2 week, and 1 month post-op period. So the tools used were upper GI endoscopy 1 day prior to the surgery. VAS scoring system was used to assess the pain postoperatively, and RUT testing during the UGI-scopy to find out the H. pylori positivity or not. And coming to result analysis, 92% of these patients who were included in this study out of 135 patients had some pathological UGI findings. The common pathologies were H. pylori-induced gastritis, duodenitis, peptic ulcers, esophagitis, and hiatus hernia. And 97 of these patients were H. pylori positive. So coming to the results of these study, the common symptoms that patients presented for symptomatic cholelithiasis were abdominal pain, vomiting, nausea, burning, bloating sensation, and loose stools, out of which 92% of the patients had abdominal pain and 80% of the patients had vomiting. Vomiting was found to be significantly correlating with the abnormal UGI-scopy findings, whereas nausea, bloating, or retrosternal burning sensation had no significant correlation. So endoscopic findings were independent of the demographic factors as age, sex, and other criteria. Coming to the post-operative treatment for these UGI-scopy findings, H. pylori-induced patients were started on triple regimen and followed by proton pump inhibitors for about 1 month. Patients who were diagnosed with esophagitis post-surgery had underwent a PPI regimen followed by lifestyle modifications. Patients who had duodenitis were also treated with PPIs. Patients with polyps either underwent observation or polypectomy depending upon the HP results of the same. And patients with Barrett's esophagus were continued on PPIs and surveillance, and gastric ulcer patients were started on PPI. So coming to postoperative VAS scores, H. pylori induced gastritis patients had improvement in VAS scores from VAS of 5 to 2 at the end of 1 month, and patients with esophagitis had a better VAS outcome after 1 month, and patients with hiatus hernia had improvement in the VAS scores from 3 to 0.5 at the end of 1 month. So pain and dyspepsia resolved or reduced in most of these patients, and medical therapy, which included the triple regimen, use of antacids, PPIs, and moderate lifestyle changes, contributed to better recovery post-surgery. So coming to discussion, UGI detected GI abnormalities in 92% of the cases, help identifying the non-biliary causes, and symptoms like vomiting and persistent pain were significantly correlating with the endoscopic findings. And H. pylori positive gastritis patients had excellent symptom relief following treatment and reducing the risk of postoperative dyspepsia and PCS. And conditions like peptic ulcer and duodenitis and hiatus hernia were managed medically, preventing their contribution to the post-op symptom persistence. And VASCOS improved significantly post-treatment, showing that addressing the endoscopic findings pre-surgery led to fewer PCS complaints. And UGA symptoms or findings were consistent across age and gender and supporting its use in all patients to reduce PCS risk. And routine UGA-scopy before cholecystectomy enabled a targeted therapy, preventing unnecessary surgeries in some cases and reducing overall PCS incidence. Conclusion, the study demonstrates that routine UGA-scopy with symptomatic cholelithiasis patients effectively identifies the coexisting upper GI pathologies that mimic or contributed to gallstone-related symptoms. By diagnosing and treating these conditions preoperatively, the incidence of persistent postoperative symptoms is significantly reduced. So this proactive approach leads to a better symptom control, improved recovery, and a substantial reduction in the occurrence of PCS. Therefore, incorporating UGA-scopy into the routine preoperative workup is a valuable strategy for enhancing patient outcome and surgical success.
When do you time the endoscopy? Suppose a patient has come, you're diagnosed as gallstones.
Yes, sir.
So when would you advise the scopy?
Sir, 1 day prior to the surgery or...
Okay, so 1 day prior to the surgery, what will be your criteria to defer lap chole? Suppose the patient comes with, antral gastritis root positive. Would you go ahead with lap cholecystectomy?
Patient comes with antral gastritis?
Yeah, 1 day prior you have done the scopy,
yes,
and
sir.
it has come as antral gastritis and your H. pylori positive.
I would not defer surgery, sir. I will still go ahead with surgery, and post-operatively I could treat the concurrent findings with proton pump inhibitors or something.
Then what special advantage will it give? The problem is it is H. pylori positive, fine. But
yes,
if your just endoscopy report comes as antral gastritis by the look of it, but there is no H. pylori positive, and how are you so confident that post-operative, that post-cholecystectomy syndromes can be controlled?
Sir, I'm just, in this study we are tackling the non-biliary causes only, sir. And however, there was significant reduction VAS scoring post-operatively.
What I'm trying to get at is, would you like to have a relook at the timing of the endoscopy? Well, two things happen. One is like you take from commercial point of view, you admitted the patient, you're probably, if he's a scheme patient or insurance patient, then you have got all the approvals in place. And 1 day before you do a scopy, where you feel that this has to be deferred. So it's going to create technical problems, practical problems what I'm talking about.
Yes, sir.
So would you like to rethink or revisit the timing of the endoscopy prior to lap cholecystectomy? That's what my question is.
Now, according to you, what is the definition of symptomatic cholelithiasis? Because I saw there so many patients who have done scopies with so many findings. So that can give rise to same kind of symptoms.
Yes, sir.
So how do you know that it is not due to this and it is due to gallstones?
Yes, sir. That is why I am doing this UGA-scopy, and in here symptomatic cholelithiasis, patients who had that typical biliary colic kind of pain post-meal, we had taken them for first UG imaging followed by UGA-scopy, sir.
You have done a UGA-scopy,
Yes,
there
sir.
was a finding like that. How many patients you have not done surgeries in this patient?
Sir,
on the next day?
Surgeries were delayed for some patients, sir. For around 5 patients, the surgeries were delayed because preoperatively they were started on vonoprazole, PPIs, and severe gastritis patients, they were treated accordingly.
According to H. pylori treatment,
Yes,
how
sir.
long this treatment lasts?
14 days, sir.
Yeah, patient next day you are operating.
Yes, sir.
Whether the treatment is going to affect that patient immediately.
No, sir. In that case, relook endoscopy to check for the H. pylori positivity again would have been.
So, rather than going for invasive procedure, that is endoscopy,
yes,
can you give 3 weeks of proton pump inhibitors and later on take for surgery? That is, the symptoms may get relieved when you give PPIs, na?
Yes,
can
sir.
you think of that rather than going for invasive endoscopy, which itself has got some complications? Correct?
Yes, sir.
Can you try that? Can it be tried?
But
3 weeks of proton pump inhibitors.
Yes, sir.
Followed by surgery or endoscopy.
If it was gastritis alone, then we could have gone with that, but we don't have a definitive.
But most of the findings you told is as gastritis, 82% I suppose.
Yes, sir.
So many are there.
Yes, sir.
So classical thinking is you give 3 weeks of proton pump inhibitors,
Yes.
wait for some time, see the symptoms. If it is persisting, then we can go ahead with surgery. Opinion.
We could have done that, sir, but since most of these UGScopy findings, including gastritis.
No, what is the standard protocol when you find out so much of findings in the gastroscopy?
Preoperatively manage the UGScopy findings, sir. I mean gastritis before taking up for surgery.
Thank you, judges. This was Dr. Raj Vikram, FRP 130. Next, we have Dr. Vedansh, FRP 136. Delegates to note, up next we have a lecture after the paper presentation on principles of pancreatic resection by Professor S.S. Prasad. And to chair the session, we have Dr. Anand Ravi, Dr. Savita Kalwad, Dr. Sriram Bhatt, and Dr. Vijay.
Good afternoon. There's a discussion on the paper following impact of the thyroidectomy on the quality of life and the complications in patients with the thyroid nodule. The study is done in Department of General Surgery in AJ Institute of Medical Sciences. Coming to the introduction, as we know, thyroid nodules are a common clinical finding, and there is a around prevalence of 68 to 70% in a general population, in which high resolution ultrasound is commonly used for detection following a clinical examination. The prevalence for the same increases with the age, common in iodine deficient areas and falling exposure to radiation. Usually, what we find in clinical practices, most of the thyroid nodules are benign, but a small proportion can be malignant. They can cause compressive symptoms, which may require further surgical intervention, or there can be cosmetic complaints for which, commonly in females, the thyroidectomies are usually done. Coming to the aim of the study. So the aim of the study is about a prospective study, which was to investigate the impact of thyroidectomy on the quality of life in patients who have undergone, who had a thyroid nodule, and we wanted to assess the significance of the factors which affect the outcome of the same. So the objectives of the study were to evaluate the pre and post-operative quality of life and analyze the factors which affect the outcome for the same. The following patients were included in the study: patients with age more than 18 years, patients who had a thyroid nodule which required surgical intervention, and they were willing to participate in the study. Certain factors were excluded, like if the patient has had a previous history of neck surgery, or the patient is unable to understand the questionnaire due to the language barrier, or the patient has had other malignancies which could affect the quality of life, they were independent of the thyroid disease. Like any cancers of the head and neck region or cancers of the lip or the oral cavity were excluded from the study. Methodology. The study is a prospective cohort study which was done from March 2023 to June 2024 in the Department of General Surgery in AJ Institute of Medical Science, which included 40 patients, and the patients had undergone thyroidectomy for a thyroid nodule. All these patients, there was a quality of life assessment which was assessed using the validated ThyPro questionnaire, which was given to the patient pre-operatively and following 6 months post-operatively. Then the data on the patient demographics, surgical approach, complications, final histopathology, all of these were collected and analyzed, and the data was analyzed using SPSS version 26 software. Coming to the study method, so all of these thyroidectomies were done by experienced endocrine surgeons, those who were doing annually 25 thyroidectomies using a standardized technique, and the extent of the thyroidectomy was determined based on the preoperative findings. Most of the patients anyhow underwent a total thyroidectomy. Further on follow-up, the patients were followed up as per OPD basis at 2 weeks, 3 months and 6 months post-operatively. And at each of the visit, patient had undergone a clinical examination, thyroid function test and serum calcium levels, which was based on the questionnaire also. Coming to the result discussion, which was the quality of life outcome. So the following parameters were assessed on ThyPro scale, that is symptoms of goiter, symptoms of hyperthyroidism, eye symptoms, tiredness, cognitive problems, anxiousness, depression, any emotional susceptibility, impaired social life, impaired daily life, impairment in the sexual life, cosmetic problems, and they were all given a composite score. So as per the study, we can see that the goiter symptoms, which were around 40% in the post-operative period, reduced to 12% itself, with a significant p-value of less than 0.001 and a Cohen score of 2.18%. Also, the tiredness was also severely improved in the patient with a significant p-value, and also anxiety and cosmetic symptoms, cosmetic complaints. The analysis of the result, so there was significant improvement in Thiopro scales following thyroidectomy, with the particular large effect on the goiter symptoms, anxiety complaints, and cosmetic complaints in the patient. There was lack of significant change in the hypothyroid symptom and the cognitive complaints, which may reflect the challenges of achieving optimal thyroid hormone replacement in the post-operative period. There were certain factors which affect these quality of life. So age, preoperative nodule size, preoperative thyroid function, whether the patient was euthyroid or not, or subclinical hyperthyroidism, gender of the patient, at what extent thyroidectomy was done, and the final histopathology, if it was benign or malignant. In this we can see the preoperative thyroid nodule, which was the most significant factor, and the younger age is also associated with the greater quality of life benefits, possibly because of the physiological recovery and the higher baseline expectations. And a larger preoperative nodule size, this predicted the greater improvement, likely due to significant symptom relief. There were certain complications which were anchored. So post-operative complications include transient hypoglycemia, which occurred which resoluted in the 3 months, transient RLN palsy. One patient developed wound infection, which resoluted between 2 weeks, and there were no permanent complications. So overall, there were a percentage of 18.75% complications were estimated, with transient hypoglycemia being the most common one, which is 15%, followed by RLN palsy. But all of these were temporary complications and resolved maximum within 3 months. Our discussion. So this study demonstrates the thyroidectomy for the thyroid nodule leads to improved quality of life as measured by our ThyroPro analysis, and the larger effect size observed for the improvement in goiter symptom is the most noteworthy thing. Thank you.
Okay, you have mentioned goiter symptoms are improved. So what are the goiter symptoms? Because you have put the hypo, hyper and pressure effect separately.
Yes, sir. So
and here most of the time surgery is because of, like you said, it's a euthyroid and it's because of cosmesis.
Cosmetic.
Right? So what are the initial goiter symptoms which they found significant improvement post-operative?
The patient had better like dysphagia, or they didn't have any hoarseness of voice. But on questionnaire, most probably it's the psychological feature that they have resolved.
Because what happens is you're taking straightforward cases you're including. In the sense you have excluded most of the
malignant cases are not.
So when you say goiter symptoms, you have put it as separate in the table separately.
Yes,
so
sir.
what are the symptoms which they found improved? Because again you have mentioned hyper is separate.
Yes,
that's
sir.
what I mean.
So like tiredness.
That also you have mentioned.
Like feeling better.
So, no, exactly. Those are there in your questionnaire.
Yes,
so the first one is goiter symptoms.
Yes, sir.
So what all you include under goiter symptoms?
So the
because you said that was a significant improvement.
Like general habitus of the patient, feeling all right, following surgery. They had that psychological picture that.
No, see, the only thing you can look for is it's a big goiter. Post-operative, they look that size has gone down. So that's, if you look at psychologically, that is one. Rest, all the goiters run the risk, same thing. They have the same risk of hypocalcemia, same risk of any injury.
Yes, sir.
Right. So that may not be a very significant yardstick. That's what I mean. That's all. It's definitely can consider, but it's not the primary one to be taken care of.
Okay, sir.
What is the type of study?
This is a prospective cohort study, sir, between March 2023 to 2024.
And about the surgery, what is the extent of surgery done here?
So we have done mostly total thyroidectomies. We haven't done hemithyroidectomies for the patient, because we asked the patient that we can do a hemithyroidectomy because majority of the patients had cosmetic complaints also, and we advised them that you may need post-operative thyroxine supplementation, but they wanted the complete resolution of the.
Is it the single surgeon who is operating?
No, multiple surgeons were there, sir.
You said endocrine surgeon.
No, general surgeons, but
according to your study, what you have mentioned is the endocrine surgeon.
All of them who have done more than 20-25 thyroidectomies.
You can't call them as endocrine surgeons.
Okay, sir.
A general surgeon who has enough experience
yes, sir.
in thyroid surgeries, and you have not mentioned that is whether single surgeon or a
Multiple.
Many surgeons were involved in this study.
Okay.
I think it's better to have one single criteria, like what sir told, extent of surgery, or it is hypo or hyperthyroidism, rather than comparing many criteria. That will be better, I suppose.
Okay, sir.
And basically your study is on questionnaire based.
Yes, sir. Whether the pre-operative questionnaire and a post-operative questionnaire, how did they
Questionnaires are given to the patient.
Patient, yes, sir. Pre-operatively and post-operatively.
Thank you, judges. Kindly note that this was Vedant Chugh, FRP 136, and our next presenter will be Dr. Meghana TR, FRP 150. I repeat, Meghana TR, FRP 150. Our next presenter will be Kota Ravi Verma, FRP 35. Kindly note, our next presenter will be Kota Ravi Verma, FRP 35.
Okay. FRP 35, sir. Good morning, everyone. I am Dr. Ravi Verma. Today I am presenting a paper on role of fine needle aspiration cytology in the swellings of head and neck region. Introduction. In the head and neck region, swellings may arise from variety of causes, including infections, inflammatory responses, cysts, and neoplasms. Given the anatomical complexity and the presence of vital structures such as nerves and blood vessels, performing incisional biopsies in these areas are hazardous. FNAC presents a safer, faster, and more economical diagnostic alternative and is frequently chosen as one of the first-line investigation in these scenarios. It is particularly beneficial for identifying the benign lesions or confirming the recurrence of malignancy or spread of malignancy, which may help avoid unnecessary surgical intervention. In cystic lesions, FNAC can also provide therapeutic benefits. It has demonstrated high reliability with diagnostic accuracy reaching up to 90% in distinguishing between benign and malignant tumors of the salivary glands. This study was conducted to evaluate the effectiveness of fine needle aspiration cytology in diagnosing swellings located in the head and neck region. This is a retrospective study and was done after obtaining permission from the Institutional Ethics Committee involving 100 patients who attended the Department of General Surgery at a tertiary care center in Shimoga between May 2025 to May 2024. All individuals presented with swellings localized to the head and neck region and were assessed in the outpatient department of surgery. Each case began with a collection of detailed medical history followed by comprehensive physical examination of the swelling. Specific characteristics such as lesion size, shape, consistency, mobility, and the condition of the overlying skin were meticulously noted. Previously conducted diagnostic tests including ultrasonography, computed tomography, magnetic resonance imaging, and relevant hematological, biochemical, or serological evaluations were reviewed and recorded as part of the patient's diagnostic workup. Results: as per the table 1, majority of the cases were distributed below 40 years of age, that is 75%, followed by 25% of the people who are aged greater than 40 years. Regarding the organ involvement, the most involved organs are the lymph nodes, that is 43%, followed by thyroid, that is 35%, and salivary glands up to 6%, and miscellaneous in 16 other % of the cases. Regarding lymph node lesions, the most majority are reactive lymphadenitis, followed by granulomatous lymphadenitis, lymphoproliferative, and metastasis. And regarding thyroid lesions, majority are colloid, majority of the results from FNAC are colloid goiter, followed by lymphocytic thyroiditis. Salivary gland lesions, majority came as C. eldenitis, followed by C. eldinosis, Warthin's tumor, and benign salivary gland lesions. And other lesions are like lipoma, epidermoid cyst, benign spindle cell lesion, benign inflammatory lesions. Discussion: the predominance of the patients under 40 years, that is 75% in the prevention study, yielding a mean age of 27 plus or minus 2 years. Similar to a large Nigerian study which was done in 2004, reported peak FNAC utilization in the 21 to 30 year age group with lymph node and thyroid lesions as most frequently sampled. Similarly, one Indian tertiary care study noted the highest caseload among the patients with 21 to 30, reinforcing that young adults comprise a significant proportion of head and neck swellings presentations. In the present study, lymph nodes emerged as the most frequently aspirated site, 43%, followed by thyroid gland, 35%. The results are closely aligned with contemporary studies of the head and neck region, FNAC. A 2023 and 2024 retrospective study involving 305 patients found that lymph node aspirates were the most common, followed by thyroid and salivary gland lesions. These studies collectively highlight a consistent global pattern. Lymph nodes dominate FNAC sampling in the head and neck swelling cases, largely due to high prevalence of reactive thyroid tuberculosis and metastatic lymphadenopathy. In this study, reactive lymphadenitis emerged as the predominant lymph node pathology, followed by the granulomatous inflammation. These findings are in close alignment with 4-year retrospective series of 392 lymph node FNACs found reactive hyperplasia in 61% cases, metastatic disease in 15.6% cases, and granulomatous lymphadenitis in 6.1% cases. Metastasis comprised approximately 9.3% in the present study, slightly lower than the other data sets. In the present study of thyroid lesions, colloid goiter was the most prevalent diagnosis, followed by lymphocytic thyroiditis. Several contemporary studies reaffirm the predominance of colloid goiter in FNAC samples. For example, diagnostic series using Bethesda classification consistently list benign nodular goiter, primarily colloid nodules as the most common cytologic category. Conclusion: overall, this study confirms that FNAC is a simple, rapid, cost-effective, and minimally invasive diagnostic technique, providing a high degree of diagnostic clarity, particularly for differentiating non-neoplastic from neoplastic lesions. Its strong performance across diverse studies types supports FNAC's role as a first-line investigations in the head and neck swellings, guiding clinical management and reducing the need for more invasive diagnostic procedures.
What is the take-home message from the study?
Take-home message is we can avoid more invasive investigations by doing FNAC, which will require less invasive.
See, more than telling we can avoid, we can say we can categorize. Yes. In the sense it's not every randomly, FNAC may not be conclusive in every stage.
Yes.
Sometimes it is lymphoma, we may not be able to get full information. Yes. Like follicular, even in neoplasms, we may not be able to get. So what we can say is that yes, maybe in 100 cases, we can avoid extensive, more aggressive investigations, maybe in some percentage of, that is really worth it.
Yes.
So it's more effective as a screening test.
Yes.
So it may not be conclusive in every stage.
Yes.
So that's your message should be very clear.
Yes.
That as an initial investigation, what you are proposing,
which will guide our
further, and in many cases we may, when it's very very clear, say secondaries from say adenocarcinoma or squamous cell carcinoma, your focus will be more on the primary rather than focusing on the. It's more effective as a screening test.
Yes.
Is it retrospective or prospective?
It's a retrospective studies.
So how many tuberculous lymphadenitis you got on this?
Out of the 43 cases of lymphadenitis, we have received 12 as TB lymphadenitis. Most or majority are reactive lymphadenitis secondary to pharyngitis and tonsillitis.
Do you have USG correlation with that after that?
Yes, sir.
After FNAC?
First we did USG prior doing FNACs. We didn't directly jump into invasive investigation. We did first radiological investigation
USG.
And then followed by FNAC.
Was it correlating between USG and FNAC? What
it was correlating, sir, up to 90%.
Thank you, judges.
Thank you.
This was Kota Ravi Verma, FRP 35. Up next, we have Dr. Meghna. Dr. Meghna, FRP 150. Dr. Meghna, FRP 150. Dr. Basaveshwari, if present, I kindly request you to be ready with the next presentation.
My name is Meghana. My topic is comparative study between minimally invasive thyroidectomy versus conventional thyroidectomy. I'm from Mysore Medical College. My guide is Dr. B.N. Anand Ravi. Theodore Billroth and Emil Theodore Kocher were pioneer surgeons, physiologists who revolutionized the thyroid surgery. They conducted thousands of successful operations. The introduction of minimally invasive surgery in the 20th century transformed the approach to complex surgeries. The emphasis shifted to achieving early recovery, minimizing pain, and reducing hospital stays and improving cosmetic outcomes. The first endoscopic surgery in the neck was performed by Gagner in 1966 for parathyroidectomy, and in 1997, first endoscopic thyroidectomy was performed by Herscher. The slower adoption of endoscopic thyroidectomy can be attributed to the challenges of a narrow operative field and the presence of numerous vital structures. Endoscopic thyroidectomies can be classified into direct or cervical approach and indirect or extra cervical approach. The direct cervical approach involves a small incision being made over the neck with carried out conventional manner, albeit using endoscopic instruments, and extra cervical approach includes axillary, post-auricular, and areolar approaches. Robotic thyroidectomy represents the most advanced and rapidly evolving area within minimally invasive neck surgery, and various studies have compared the feasibility and complications of minimally invasive thyroidectomy with traditional open thyroidectomy, yielding mixed results. The objectives of these studies are to compare the operative time, post-operative pain, injuries to the recurrent laryngeal nerve, temporary hypocalcemia, length of the hospital stay, and aesthetic outcomes. This is a comparative study conducted in Department of General Surgery at Mysore Medical College. 30 persons with benign thyroid nodules were included, and the patients were divided into two groups. 15 patients underwent endoscopic thyroidectomy via the axillary approach, and 15 patients underwent conventional open thyroidectomy. And inclusion criteria were people aged from 18 to 60 years, benign thyroid nodules less than 5 centimeter in the largest diameter, and no evidence of malignancy on FNSE. And exclusion criteria were the size of the nodule more than 5 centimeter, malignant or suspicious nodule, sternal goiter, and previous neck surgeries or radiation, and also the comorbidities which were contraindicating for prolonged anesthesia. Pre-operative evaluation. All the patients were evaluated pre-operatively with thyroid function test, lateral neck x-rays, routine blood investigation, ultrasounds of the neck, fine needle aspiration, and an indirect laryngoscopy was performed in all patients to assess their vocal cord mobilities. Outcomes. The main surgical outcome measures include the operative time, that is interval from the skin incision to skin closure, post-operative hospital stay, identification of recurrent laryngeal nerve injuries of parathyroid, conversion of open procedure to open procedures, and post-op hypocalcemia. Post-operative complications. The specific complication analyzed were transient or permanent recurrent laryngeal nerve palsy and hypocalcemia and post-operative pain. Serum calcium was measured preoperatively and postoperatively on days 1 and 30. Hypocalcemia was defined as serum calcium levels below the lower limit of normal range. Hypocalcemia and the recurrent laryngeal nerve were considered permanent if there was no recovery within 30 days postoperatively. And all the patients were followed on post-operative days 7 and 13 through hospital visits. And during the follow-up, hoarseness of voice, swallowing difficulty, paresthesia, and cosmetic satisfactions were assessed. And at 1 month, patients were asked to grade the cosmetic appearance of their wound as poor, acceptable, good, or excellent. Minimal invasive thyroidectomy, the patients were kept NPO for 6 to 8 hours. So patient was laid in supine position with neck extension, arm extended on the table edge, surgeon on the lesion side with monitor at the opposite side, and 1 centimeter axillary incision behind the axillary line, and 2 5 mm ports, 1 in axillary and 1 at the nipple areolar junction. Subplatysmal tunnel created to the neck, and sternocleidomastoid exposed, and the sternocleidomastoid muscle retracted, strap muscles visualized and retracted. Inferior thyroid vessels were divided and recurrent laryngeal nerves identified and preserved. Superior thyroid vessels were divided and glands were mobilized and extracted via the 10 mm ports. Adequate hemostasis were achieved and drains were placed. And statistical analysis, the data were analyzed using the student test and chi-square test. P-value of less than 0.005 was considered statistically significant. These are the pictures showing the pre-op, creating the incision for camera port and incision of laparoscope, and intra-op pics of thyroid gland, and post-op pic. And the age group between 20 to 30 age, around 12 patients were there, and 30 to 40 years of age group, 10 patients, 40 to 50 years, around 4 patients, and only 1 male patient, and rest 29 patients were female patients. And the size of the nodules, 1 to 2 centimeter, there were 1 to 2 centimeter, there were 7%, and 2 to 3 centimeter size, 50% of the patients had range from 2 to 3 centimeter, and 3 to 4 centimeter, 36% of the patients. Lobes involved, right lobe, around 14 patients involved had right lobe, left 7 patients, and both the lobe involved had 9 patients. And the operating time in the minimally invasive group from 60 to 155 minutes, and the initial few cases took longer and last few cases took 60 to 70 minutes owing to steep learning curve, and the mean operating time was 89.33 minutes, and the conventional group had operating time ranging from 55 to 100 minutes, and the mean operating time of this group was 70.17. This is statistically significant difference with p-value of 0.001, and drain removal mean time was in the minimal invasive was 2.53 days, and conventional group 2.82 days without any statistical significance, and suture removal mean time was in minimally invasive group of 6.03 days, and conventional 7.06 with p-value of 0.001, and cosmesis, the most significant difference. Minimally invasive group had a mean of 1.7 on visual analog, and conventional group at 7.1.
You can go to your last slide.
Conclusions. In this era of minimally invasive surgeries and patient demanding better cosmesis, this minimally invasive thyroidectomy is the need of hour, and minimally invasive thyroidectomy provides excellent cosmesis with less post-operative pain with comparable rates of complication. It provides a good alternative to conventional surgery for benign thyroid nodules with size less than 5 centimeter. Hence, this can be recommended for small benign thyroid nodules, and it is technically feasible procedure which can be easily performed once the surgeon has achieved the steep learning curve. In future, the minimally invasive thyroidectomy can be extended to malignancies with small size with central neck node dissection, and it can be incorporated to robotics. Thank you.
You are giving a very bold statement. You said this can be extended to malignancy. Where is the evidence? Second thing is, you have done the surgeries, minimally invasive thyroidectomy. What was the extent of surgery done through this procedure? Whether total thyroidectomy performed?
Yes, sir. Total thyroidectomy was performed.
How many cases of total thyroidectomy?
3 cases of total thyroidectomy. Two cases were done bilaterally. Then one case through one side only, both the lobes were removed.
That means one lobe is one side, other incision separate.
Separate incision, 2 cases, and 1 cases were done through one side only, both the lobes.
Okay, did you compare the cost of surgery? Open surgery and endoscopic surgery, minimally invasive. Have you compared? Okay.
And the basic argument in quite a few of these discussions are that a well-placed neck incision gives quite a bit of acceptable cosmesis. So this is not going to give extraordinary difference. So what's your argument on that? That's one. And as I said, cost. So can it become as acceptable, widespread acceptable as, let's say, laparoscopic cholecystectomy? Because there is not just cosmetic, it is functional. Patient is pain-free much faster. But here, is it worth going through all this effort on a mass scale? That's a conclusion that has to be drawn from this paper. So you have to come up with the answer.
Yes, sir. Because now everywhere, in every aspect, endoscopic is used. We can go with this. In government hospital, if we bring up the setup, management cooperates, we can.
I agree with Satish sir. The cosmesis with a good, well-closed neck incision is excellent actually. It generally hidden in the neck folds. So the cost factor also, I think, many consideration to be taken, whether it was going to be significantly helping the patient.
Okay. Thank you, sir.
Thank you, sir.
That's it. Yes, sir. Thank you, respected judges, for judging this session. Up next, we continue with a lecture on a topic that stands as a testament to surgical precision, principles of pancreatic resection.
To deliver this insightful session, we are privileged to invite Professor S.S. Prasad, HOD KMC Manipal, a renowned surgical educator and an authority in hepatopancreatobiliary surgeries.
To chair this session, we are pleased to invite Dr. Siddesh, Dr. Anand Ravi, Dr. Savita Karwad, and Dr. Sri Rama Bhatt.
Good morning.
Good morning, everyone. Professor S. Prasad, I know him personally. We are working together. Very excellent surgeon, academician, very genius. Good at heart also. We are very close. Very knowledgeable person, especially in pancreatic surgeries. Technique skills are very well known. He's currently a HOD surgery department, KMC Manipal. Prasad.
Good morning. I bring greetings from the Department of Surgery, KMC Manipal. Heartfelt thanks to the organizing committee for giving me this opportunity to share my thoughts on one of the topics that is very close to my heart. Somehow I am feeling like a PG all over again. My teachers or my moderators, my mentors are in the front seat. It's giving me some ectopics and skip beats, but nevertheless I shall put up a brave front. And I believe my target audience are the Gen Z postgraduates. If there are anybody around there, they are going to be my target audience. The approach will be a little unorthodox. Apologies. I'm feeling like Chiteshwar Pujara playing the final over of a T20 match, because I have been given 15 minutes time. Now the clock shows 13 minutes, and I'm supposed to cover up as much as possible. So on most of the occasions, it is going to be a photo, a definition, and rather than take-home message, I'm going to give some thought-provoking points for the postgraduates. On another occasion, maybe we can address the controversies and answers. What do we intend in this session? We would have a look at the indications for pancreatic resections. By definition, what is a resection? Resection is taking away a bit of tissue or a portion of an organ. If you take the entire organ, you call that excision. It no longer gets designated as resection. We look at the types of pancreatic resections. We look at the preoperative workup and how to optimize the patient before you do the pancreatic resection. Your NMC AdCom session will have a session probably on consenting, so that's another thing that we will be looking at. And technical issues, definitely I can spend a day on that, but that's for another day. And then briefly on the postoperative care is what we are going to look at. Indications we all know can be categorized as benign and malignant. Benign, commonly cystic neoplasms. Occasionally, inflammatory head mass might require a resection with the drainage procedure. Malignant is more often, commonest being adenocarcinoma. You can get malignant neuroendocrine tumors. So there's an entire list for indications for pancreatic resections. The list of pancreatic resections, everybody's dream, Whipple's, you know, the charm, the glamour, the thing in pancreatic surgery. Then you have distal pancreatectomy. Not often one encounters that. Nevertheless, it's not as glamorous as Whipple's. RAMPS is something, thanks to Strasbourg, which has come in a big way in 2003, 2004. If you look at literature between 2005 and 2020, you see a number of papers addressing RAMPS versus conventional distal pancreatectomy. Enucleation is what we do. We just scoop out the tumor, commonly done for a benign functional neoplasm of pancreas like a benign insulinoma. And I'm not going to touch upon total pancreatectomy because it is excision of the entire gland. It's a different ball game itself. Lastly, you know, as it is a gray area, as it is in the gray background, role of lymphadenectomy in pancreatic surgery. Starting with what are the pancreatic resections that we do? Whipple's, two types, classical, pylorus sparing. This is, the graphic picture is classical, the specimen that I have put is, the graphic picture is pylorus sparing, the specimen that I have put is classical. Second category of pancreatic resection, which was quite popular for a brief span, right? So this aims at conserving as much pancreatic parenchyma as possible, thereby reducing the possibility of postoperative diabetes. Comes at a risk because common sense tells you that the more the suture line, the more the chance of leak, more the chance of fistula. So you have two suture lines or staple lines there. So not many people follow this these days. Nevertheless, it is something that as a postgraduate you should know, because most universities, I believe, as per NMC guidelines nowadays, are having a question paper with 10 questions of 10 marks each. And there are terminologies that are going to be used in framing those question paper as the medical education people. So one of your questions may be appraised pancreatic resections. If that comes, then your writing a note on central pancreatectomy carries some weightage. Distal pancreatectomy with splenectomy. Now the catch here is if you are doubtful about the tumor in the body or tail of the pancreas being malignant, you have to give adequate lymphatic clearance. So the hilar lymph nodes and the lymph nodes along the splenic arteries need to come out, and you do a distal pancreatectomy with splenectomy. The principle here is that it gives more lymphatic clearance, so technically easier to do. Many a times I have seen surgeons starting with mobilization of spleen coming medially. You can actually call that as a retrograde distal pancreatectomy with splenectomy. More challenging is the spleen-saving distal pancreatectomy. Now here there are a couple of principles that I want to drive home. You can see in this picture that when you save the spleen, you save the splenic vein and the splenic artery. Now the challenge here is to save the splenic vein, because that runs an oblique course behind the pancreas and invariably gets damaged, and you end up ligating that. That leaves a spleen depending exclusively on short gastric veins for its drainage, and that can give rise to certain degree of left-sided portal hypertension and splenomegaly and so forth. So this is another important issue. You are going to consider doing a spleen-saving distal pancreatectomy only in situations where you're pretty sure that this is a case of a benign pancreatic neoplasm, like a serous cystadenoma, which is more than a critical size of at least 3.5 centimeters. Now, this is something that I want the postgraduates to take home. Strasberg is a big name in HPB surgery. It's the same Strasberg who described the critical view of lap chole. The same Strasberg in 2004 came up with an excellent paper on radical antegrade modular pancreaticosplenectomy. RAMPS is the popular abbreviation. Now what happens here is, it's antegrade because you start from the neck of the pancreas. Like you are doing Whipples, you are going to create a tunnel there and then go down. Now the tumor may be on the posterior aspect of the pancreatic body or the anterior aspect of the pancreatic body. The site of the tumor will help you decide the extent of your resection, modular resection. Now the blue line is for anterior ramps. So it takes the gerotus fascias there, goes all the way down there, takes the spleen, starting from the neck of the pancreas. Hence the name radical antegrade modular pancreaticosplenectomy. So if the tumor is reaching the posterior capsule of the pancreas, then probably you need to go a little further. Might even compromise taking out the adrenal, which is, if you have seen carefully, it will be pretty close to the dissecting plane in that area, and then take the spleen with the pancreas. So that would be posterior antegrade ramps, posterior ramps. So you have anterior ramps, posterior ramps, depending upon the situation of the tumor in the body of the pancreas. Sometimes you might need to do an en-bloc resection. An en-bloc resection is where you take out the pancreas with adjacent organs. One would not consider doing this for a case of adenocarcinoma because the prognosis is going to be bad. But in a locally aggressive tumor like a solid pseudopapillary tumor of the pancreas, one might attempt this. Now here is a situation wherein the CT picture was very much suggestive of a solid pseudopapillary tumor of pancreas. We end up taking a sleeve of stomach. We have taken out the splenic flexure, a segment of the colon of the splenic flexure, the adrenal gland, and the tumor with the body, the staple line there, and the spleen. So it was worth it because eventual histopathology came as serous cystadenoma with predominant neuroendocrine carcinoma component. So this technically following this, we did a DOTA scan and it was of a curative intent. What's the role of lymphadenectomy? Gray area. Most of the adenocarcinomas of pancreas require certain extent of lymphadenectomy. Literature is very clear when it says that when you do a Whipple's, the pathologist should be able to retrieve at least 15 lymph nodes for the TNM staging to be adequate. But there is no mention of the number of minimum number of lymph nodes that are required for an adenocarcinoma or any cancer in the body or tail of the pancreas. So these are some of the lymph node stations that you should be aware of. So please note that this is the most important one for all those people who want to do Whipple's, the station 8 lymph node. You take that out, you are on the hepatic artery, and then you dissect on either sides. You will get lymphadenectomy at the porta. Planning is everything, right? Starting with imaging, you want a good CT, a triple phase CT, a CT befitting pancreas protocol. Role of biopsy, again controversial. We have been conventionally taught that there's no need for biopsy, but I personally would be a lot more comfortable consenting a patient for a procedure like Whipple's, explaining in the mortality, morbidity, and the benefits if I have a piece of paper which says that he has got adenocarcinoma. Tumor marker CA99 coming up in a big way. You probably are under impression that if the tumor marker is elevated, Sabiston says more than 38 implies it's likely to be an adenocarcinoma, right? The catch here is if the patient has pancreatitis or some kind of obstructive component to pancreatic duct, it may be false positive. But in the background of a normal pancreas, CA19 levels indicate the disease burden. Studies are being proposed wherein CA19 levels at a very high value, irrespective of whether it is resectable or not, might be in the coming days considered for neoadjuvant therapy in pancreatic cancer. Nutrition, most important. Major surgery, albumin, I would be comfortable if the albumin is more than 3 at least. Should we stent or not? Again, obstructive jaundice, head of pancreas, planning resection, role of stenting, not routinely done. I would not prefer that. Then when we do stent, sure short indication for stenting is cholangitis. If the bilirubin is more than 15, I would stent. If I am contemplating neoadjuvant therapy, I would stent. Otherwise, stenting is not routinely indicated. Coagulopathy should be addressed, concerned renal function. Obstructive jaundice, hyperbilirubinemia will compromise the renal perfusion. These are sitting ducts for hepatorenal syndrome, so that should be optimized. Just to show the significance of fast CT, see if you can figure out anything in this. Your radiologist friend can make or break the deal here. Well, you gave me 15 minutes, so I'm giving that much time only. Right, if you see there, the hepatic artery is actually arising from SMA. It's very, very unusual. You see the right hepatic artery arising from SMA. Here, the whole hepatic artery trunk is arising from SMA. So in the zeal for looping the CBD, if you loop the entire chunk of tissue there and ligate that, you are actually compromising the blood supply to the entire extrahepatic biliary apparatus. So this was the intraoperative picture wherein the exposure is adequate, left renal vein is seen, the hepatic artery arising from the SMA is very, very clearly seen. Post-operative care, pain, epidural. You can place a catheter behind the rectus muscle. That gives equally efficacious post-operative pain control. Manage acidosis, major surgery, almost something like systemic inflammatory response syndrome. So my bosses used to say the next day ABG should be normal, lactate should be normal. Follow ERAS protocol, early ambulation, early enteral feeding. Sometimes you might put a feeding jejunostomy to facilitate feeding. Thromboprophylaxis, first dose of any anticoagulant of your choice should be given within 6 hours of surgery. Antibiotic, as per hospital policy, octreotide, plus or minus, they are believers, they are non-believers. Prokinetics, in anticipation of delayed gastric emptying, look out for complications. I think I just managed to finish in time. I end the slide with 3 rules, particularly for Gen Z surgical trainees who believe in work-life balance. Eat when you can, sleep when you can. Don't, my boss has said, those 4 letters are mess with pancreas. Your vocabulary, use whatever word you want. Thank you very much.
Prasad, no way you are a student. Of course, anybody who is a master also need to learn, continue learning because of the evolving world. But today, the era where general surgeons are not performing pancreatic surgery itself, let alone resections, formal resections or Whipples, as the mainstay in their practice. Now it is going away. And that context, a very relevant topic where if at all any general surgeon wants to continue practicing pancreatic surgery, he has brought out a lot of issues. Of course, he has not elaborated for want of time, but he is really an expert who can all approach and get tips. And he is very academic and he's got a large volume to follow. Obviously, the way he is talking, you can definitely get help from him. My only question, very small question, is would you recommend routine nodal dissection for all Whipples, and what extent you do? Is there a role for sampling intraoperatively? And what you do, like a sentinel node, anything you would like to do, because nodal resection has added morbidity. So I just want.
Sir, this, as I mentioned earlier, is a gray area, but if somebody goes in the anatomical planes, whether we like it or not, there is a significant amount of lymphatic clearance. Most of the stations that are shown in the diagram will be cleared. Now the controversy is about a triangular area between the superior mesenteric artery and the aorta, beyond the cava. Whether clearing that is going to add to the survival or add to the morbidity is a debatable question. As I am aware of, there are no large-scale studies that addresses this, so I don't routinely go in search of lymph nodes, and there's nothing like a sentinel node biopsy or anything for pancreatic cancer. But classical Whipples, on the average, my histopathology will yield definitely more than 15 nodes because of the abundance of nodes in the aortocaval window as well as around the CBD.
Thank you. That was very clear description. Regarding my experience about number of nodes, let it be pancreatic or breast, we need to involve in that dissection, post procedural specimen dissection. Unless otherwise, you will be wrongly depicted that your yield is much less than what absolutely you have performed. You may be a better surgeon, but you look at the report of the histology, you may be rated not such a good surgeon.
What sir said is a very, very valid point. You would finish your surgery by, let's say, 6 o'clock. The pathology lab would be closed. The specimen will comfortably take a bath in the formalin jar. The next day, if you yourself go and see and try to isolate the lymph nodes, you will realize how difficult it is for the pathologist. I say this because I live with a pathologist. So,
absolutely. We have to learn that. We have to live with the other colleagues, radiologists, microbiologists, pathologists, anesthetists, of course, without mentioning, we are become. So we need to have mutual respect and we need to work with them and keep them in good humor also as well. Anything more? Otherwise, a question on borderline resectability. Sir, anything you would like to add on borderline resectability? That is one more contention now because
absolutely,
we are involving multi-specialties. We keep a vascular surgeon and call if there is a borderline resectable pre-op we have evaluated. So imaging, again, you have to be part of the evaluation pre-op.
Absolutely, sir. That's a separate topic and merits a separate discussion on its own right. And as I said in the beginning, this is a topic for a masterclass for one full single day program. So borderline resectable, yes, depends upon the tumor biology. Two options, either neoadjuvant or if you are comfortable, it's not rocket science to take out a sleeve of portal vein. Up to a centimeter of portal vein, even if you take out the segment, the root of the mesentery can be mobilized and vascular anastomosis can be accomplished. If there is a requirement, our vascular surgery colleagues are always there. Absolutely, sir.
Yes, sir. Biopsy is not, biopsy is optional, like you said, not mandatory, both legally as well as planning the treatment.
Exactly,
Yes,
sir.
rightly put.
If the biopsy yield is in excess of 90%, it is worth considering biopsy for all cases of periampullary CAs. The problem is, it's got a very steep learning curve. When the so-called interventional gastroenterologist does a US guided biopsy, so that makes life difficult.
Still, in most of the centers, endosono and biopsy, still they are also in a learning curve.
Correct, sir.
I would
correct.
say for
Absolutely.
the last, it has come up as a concept for the last less than a decade.
Absolutely,
And few centers are there. There is a cost implication. You know now.
Agreed, sir. Agreed, sir.
All this, I think it's a topic again for a discussion.
Yes.
Thank you, sir,
Thank
for
you, sir.
that comprehensive overview on pancreatic resections. Your clarity in simplifying such a complex procedure is truly commendable. We now request Professor S.S. Prasad and our chairpersons to kindly proceed to the photo booth for a photograph and to collect their certificates of appreciation. I request Dr. Satyamurthy Aital, President, South Canara City Branch, to kindly present the certificates.
We now move on to a lecture focusing on a subject of utmost importance in emergency surgical practice, common pediatric emergencies. To deliver this session, we are honored to invite Professor Divakar Gaddi, pediatric surgeon, BIMS Bellary, and also the Secretary, Associations of Surgeons of India, whose expertise in pediatric surgery has been a guiding light for many young clinicians. To chair this session, we invite Dr. Tejaswini Vallabha, Dr. Madhu B.S., Dr. Chandrasekhar S., and Dr. Vijay. To chair this session, I would like to call upon Dr. Rajagopal Shenoy.
It's our honor and privilege to have a first national ASI honorary secretary from Karnataka State, Dr. Divakar Gaddi, is a professor and head of the Department of Pediatric Surgery from BIMS Bellary, same place where I studied. Thank you.
With your permission, sir, good afternoon, everyone. At the outset, I would like to thank the organizers of this beautiful conference and also the members of KSCASI for giving me this wonderful opportunity to present on a common topic. So I don't know how many of you will become pediatric surgeons once you finish your post-graduation, but it's very important to know I'll be focusing on the most common problems which we encounter during our day-to-day practice. This is the alma mater where I did my MS and MBBS. Now it is renamed as Bellary Medical College and Research Center. Earlier it was called WIMS, and earlier to that it was called Government Medical College, Bellary. So the objectives of my topic will be to understand the spectrum of pediatric surgical emergencies as a general surgeon which you will be facing in your day-to-day practice, recognize the difference what they pose from adult emergencies, and know the diagnostic approach and the management of those common conditions. So pediatric surgery per se consists of all these subspecialties. It includes neonatal surgery, congenital anomalies, pediatric urology, gastroenterology, neurosurgery, and oncosurgery. So you can get any emergency in any of these subheadings. So how to identify these types? They can be categorized in various ways. They can be called as congenital anomalies when they exist right from birth, including tracheoesophageal fistula, anorectal malformations, or congenital diaphragmatic hernia. They can be classified as gastrointestinal emergencies when it is intersusception, malrotation with a volvulus, pyloric stenosis, incarcerated hernia, Hirschsprung's associated enterocolitis, etc. It can be called urological when it's torsion of testis and obstructive uropathy. there may be emergencies related to trauma, and also the most importantly, the foreign body ingestion and aspiration. And nowadays, with the increasing small family system, there are no old age people to look after your child, burns and scars. They appear to be the more frequent occurrence. And it can be age linked also. If suppose a patient of particular age comes with some emergency, you can easily classify them into one of these. If it is a pyloric stenosis, the age of occurrence is 2 to 6 weeks. If it's an intersusception, most commonly seen in 16 to 18 months a child, and testicular torsion is usually seen in prepubertal boys. And again, they can be classified based on their urgency levels. Some intervention, some surgical conditions require emergency surgical intervention like volvulus, where there is a vascular pathology, or it can be a testicular torsion or foreign body aspiration. And there are certain conditions which allow you certain time for stabilization before surgery. Those include pyloric stenosis, congenital diaphragmatic hernia, and also burns. So how does these pediatric emergencies differ from the adult emergencies? As you all know, pediatric surgery is not miniature of general surgery. It's altogether a science in itself. These pediatric patients have a smaller physiological reserves, and they have unique physiological requirements. You cannot give bottles of IV fluid, and they require specialized nursing and post-operative care. And because these physiological results are very limited, there is a small delay in diagnosis often leads to complications which can end up in mortality. And as I said, need for specialized pediatric anesthesia and post-operative care is a must. And to treat these children, the prompt recognition, resuscitation, timely referral and intervention is life-saving. And again, a multidisciplinary involvement, including the pediatricians and neonatologists, is a must. And unlike in adult patients, you have to deal with the anxiety of the parents also. As I said, the prognosis and outcome depends largely on timeline of recognition and intervention, underlying condition. When I say underlying condition, majority of these pediatric and neonatal emergencies come in a spectrum of presentation and with associated comorbidities. And age is also an important factor. And resource availability. As you all know, the pediatric surgeons are not available in majority of the centers, and a general surgeon should treat with these cases. The common symptomatology can be grouped either they present with vomiting, or they present with abdominal distension, ascites, respiratory distress, or abdominal wall defects. So I will be highlighting only a few of these conditions, because talking about the pediatric surgical emergency is like talking 75% of pediatric surgery. You cannot cover possibly 3 years course in 15 minutes talk. So if I exceed my time, just let me know, I'll stop there. The most important condition which I would like to highlight is malrotation of the midgut with volvulus. In this, there is a failure, as you can see. What did I do? Yes. As you can see, this is the normal orientation of a rotated bowel. In malrotation, as you can see, the DJ junction is not fixed. It straightly descends down below the pylorus, and even the IC junction is also not fixed. This is basically an embryological abnormality, or you can call it as simple as a manufacturing defect in a child. This can present at any age, and it can be an incidental diagnosis when child comes for a recurrent abdominal pain, and when you subject the child for ultrasound of the abdomen examination. Usually, the patient presents with a bilious nasogastric aspirate, or there will be history of bilious vomiting. If there is a complication like volvulus supervenes on this malrotation of the midgut, the patient might present with the distension of the abdomen. And neonatal malrotation, or for that matter, malrotation in any age, is a dire emergency, because if it goes into volvulus, then you have a risk of losing entire small bowel. This picture shows, the first picture shows the ultrasound picture, which is called as a target sign, where the bowel will be volvulated and it appears like a target sign. And the second picture, how do you diagnose that? If you are in doubt, you have to subject the child for an upper GI contrast study, where, as I said, there will be absence of fixation of the DJ flexure and also IC junction. On an USG Doppler, there will be change in the orientation of the SMA and SMV, and you will be able to see a whirlpool sign. This is the preoperative picture. This is the intraoperative picture. The first one is a picture where it is just ischemic and still salvageable. The picture below Here is a necrotic bowel, and the third one is the operative video, where we rotate it anti-clockwise and the bowel is salvaged. The second condition is incarcerated inguinal hernia. This is the bread, like for a surgeon, the appendix is the bread and butter, and for a pediatric surgeon, inguinal hernia is our bread and butter. So emergency in an infant, if it is especially boy, the obstructed or incarcerated hernia is an emergency. Majority of the times it comes as a small irreducible swelling in the groin area. If it progresses, there will be vomiting or the child will be very irritable. Gently we try to reduce that with the gentle manipulation. If it gets reduced, then you subject for elective repair in the same setting. If strangulation happens, if the child presents to you late and if there is a strangulation, apart from the bowel getting compromised, there is always a possibility of decreased vascular supply to the testis, and if it's a girl, sometimes the hernia will be associated with ovary as a content. There is decrease in the vascularity and chance of losing both those organs. The picture shows an intraoperative picture of incarcerated hernia, where you can see the bowel is perforated, gangrenous, including the edematous and inflammatory changes over the external genitalia also. So when a child comes to with a hernia, the recommended advice is to repair as soon as possible. Even if there is no clinical diagnosis, if a mother complains of a hernia intermittently, then that should be taken as a positive point and subject the child to ultrasonography of the abdomen, diagnose it and then operate it irrespective of the age, unless it becomes an emergency. The third condition would be the testicular torsion. The testicular torsion, as I said, usually appears in a prepubertal child, but not necessarily. It can occur in the neonatal period also. For that matter, pediatric surgical reference is that any acute scrotum, it requires a surgical exploration. That's the dictum. Even if there is some negative explorations, that is acceptable. And a patient with a torsion of testis presents to you with a sudden onset of pain, lower abdominal pain. As the time progresses, the pain gets localized to the scrotum. This requires a quick action because before it gets localized to the scrotum. The Doppler ultrasound, it is still debatable whether to waste time for Doppler or to take the patient emergently for exploration, scrotal exploration. So surgery before 6 hours of onset of symptoms, the testis is solvable. The fourth condition will be intussusception. It's commonly seen in the infants between 16 to 24 months. It's a segment of the bowel, telescopes into distal segment, most commonly ileocolic. And most commonly, if the intussusception occurs below the 2 years of age, usually it's idiopathic. Following a post-viral infection, the enlarged Peyer's patches act as a lead point to pull the bowel into the succeeding bowel, causing an intussusception. But pathological lead points are seen in the 10% of the patients. Mostly, if the child is more than 2 years of age, the lead points will be Meckel's diverticulum, intestinal polyps, or a lymphoma. The child presents to you with a classical triad. We call it as abdominal pain, vomiting, and current jelly stools, with a progressive decrease in the activity of the child as the time elapses. On examination, on per-abdominal examination, there will be a sausage-shaped abdominal mass periumbilically, and there will be absent sign in the right iliac fossa. Abdominal USG is the most sensitive diagnostic modality, and where it shows a target sign again because of the invaginated bowel appears like a target, or sometimes they call it as a donut sign. The management is that the patient needs to be stabilized with respect to the IV fluid and hydration and electrolyte correction, and the majority of the cases, if they present within 48 hours of the occurrence of the symptoms, what we try is a non-operative reduction under the ultrasound guidance. We use hydrostatic or the water to reduce, or sometimes we use air, and in earlier times we used to have a barium picture. That is the barium picture showing a claw sign. That is the claw, and this column of the contrast is not moving forwards because there is a bowel obstructing there. So it can be reduced under fluoroscopic guidance also. So what are the contraindications for this non-operative reduction? The contraindication is that if the child is in shock and the time duration is more than 48 hours of onset of symptoms, then those are the contraindications for non-operative reduction, and the child is taken to the surgical exploration. Acute appendicitis, I will not dwell too much into this, but it's sufficient to say that the acute appendicitis in a children, if unrecognized, has all the potential to become complicated because, as you know, the omentum is not well developed, and the complications like abscess, fistula, and abdominal sepsis can occur because of the perforation. And as soon as the child comes with the classic triad of pain, abdomen, fever, and vomiting, the patient needs to be ultrasounded, and to confirm the diagnosis, if it is there, then an appropriate surgical exploration and appendectomy needs to be done to prevent the possibility of morbidity. The one which is mostly underlooked and in which department we are undertrained is the pediatric trauma. Because of these high velocity accidents, pediatric trauma patients, the incidence is increasingly reported in the emergency casualty. So what we need to know in this pediatric trauma, the unique pediatric conditions, as I said, he is a small child where there is a larger head to body ratio. So there is higher incidence of head injury risk in these patients. And there is a pliable chest wall without any physical evidence of fracture. There may be incidence, there may be occurrence of deeper internal visceral injuries. And the third most important consideration is that there is a smaller circulating volume. So there is almost always a chance of patient going in for rapid shock. So what we need to do, as in ATLS, we have to evaluate for primary survey A, B, C, D, E. Resuscitation priorities include warm fluids need to be given, early blood products if the shock persists, and then comes the secondary survey where head-to-toe examination needs to be done, and a fast and CT-based stability and radiation risk should be, radiation risk to the child should be minimized. What are the pitfalls when you are treating a trauma patient is we try to underestimate the blood loss because of the lower volume, delayed airway in burns and injury, and we almost always miss the signs of non-accidental injuries. So the foreign body ingestion or aspiration is increasingly occurring. So we have to be very careful with the toddlers, and everyone should. I urge that as a post-graduation or once you complete post-graduation, you should be proficient enough in doing bronchoscopy and endoscopies also. So with this, I'll move forward to my concluding slides. So this is the picture. This was taken when I was doing my MS general surgery. These also can come as an emergency. A home delivery, Aya cut that whole bowel thinking it as an umbilical cord. This is the situation in which we are living. Still the condition hasn't improved much. Sometimes it may not be a patient emergency, it may be a surgeon's emergency. Like this, you should be prepared for these kind of accidents when you have become a pediatric surgeon. So thank you all. I thank everyone for giving me this wonderful opportunity, and I also thank the chairpersons for their patient listening. Thank you.
Thank you, Dr. Divakar Reddy, for maintaining the time also. Very importantly, the midcon's aim is the postgraduates to get the experts' comments and how to tackle the situations, because the reading material, resource material is everybody has in their mobiles, yes, all the textbooks to everything. So you have given a wonderful presentation for this. Yes.
Anyway, nice presentation, sir, and expected also. Very nice.
Thank you.
Thank you.
Yes. Very nice presentation, Dr.
Thank you,
Divakar.
Vijay.
Incidentally, he happens to be my immediate senior in WIMS, Ballari. Just a question, what is the incidence of recurrence following hydrostatic reduction of intussusception?
So if it is idiopathic intussusception where there is no lead point, usually I have seen only 2 incidences where the patient has come back the next season of upper respiratory tract infection. It is very less, though there is no specific figures which I can give you offhand, but it's not very common. But if there were to be a lead point, like as I said, polyp or a lymphoma, it's obvious that the patient recurs within next week, say in 1 week. So those things need to be evaluated, and we have to be very careful, and you should suspect some lead point if there is an intussusception in a child who is older than 2 years.
I'll just make only one experience comments related to this torsion and whatever in adults. When we write for, we means whoever examines, you're not done the examination of the testis, right? I look for some pain, patient has, sir, I have done ultrasound, I asked for ultrasound. See, sonologists also should be told. They have not examined the scrotum testis. Counts are elevated, some vague probe tenderness, do appendicectomy, and then next day continue to have pain, obviously turn to be a torsion testis. So what we are trying to tell is that do a complete clinical examination, that's all.
Yes, sir.
And ask for relevant specific investigation.
Thank you, sir, for that engaging
Thank you.
session. The pearls shared today will surely enhance our approach to pediatric emergencies. May I now request Professor Divakar Gaddi and our chairpersons to kindly proceed to the photo booth for a photograph and to collect their certificates. I request Dr. Satish Rao, Professor Dayanand Sagar Medical College, Bangalore, to do the honors.
Ladies and gentlemen, we have now reached the last and the final concluding panel discussion for the MidCon 2025. It's a very pertinent panel discussion on carcinoma breast, a topic that demands multidisciplinary insights and clinical precision. To moderate this academic exchange, we are privileged to invite Professor Dr. B. Srinivas Pai, Dayanand Sagar Medical College, an acclaimed surgical oncologist and an inspiring academician. To be a part of the esteemed panel, we invite Dr. Major Shashi Shekhar, SDMC, Dr. Ayush Bansal, JNMC, Dr. Sanjana, MMC, and Dr. Aisha from MS Ramaya.
I don't. Good afternoon. I think they have normally they save the best for the last, correct? Or the other way around, I don't get it. So the last time I gave a panel in Mangalore, city of Mangalore or outskirts, was also on carcinoma breast, and my co-panelists just walked across. The moderator was the chairman of the ASI, who is now Professor Rajgopal Chennai. The three of us came to Mangalore. And when I came to Mangalore, I was an assistant professor. And when I left Mangalore, I became an associate professor. So the same, I remember that very well. And that's the picture of the opening slide of that panel. So I thank the organizers for giving me an opportunity and to conduct this panel. And I'm a replacement, substitute for somebody else who had to go to US. So I stepped in at maybe at the right time. So my co-panelists will introduce themselves. So this is a program for the PGs, by the PGs. So all the 4 panelists are postgraduates of various medical colleges in Karnataka from all corners. But incidentally, moderator included, all are from Bangalore actually, native. But colleges are different. So with this one, please introduce yourselves.
Good morning, everyone. I'm Dr. Shashekar. I'm a final year a postgraduate from SDM College of Medical Sciences, Dharwad.
Good afternoon, everyone. I'm Dr. Ayush Bansal. I'm a final year postgraduate from Jawaharlal Nehru Medical College, Belgavi.
Good afternoon, one and all. My name is Sanjana Lokesh, a second year postgraduate and from Mysore Medical College, Mysore.
Good afternoon, everyone. I'm Dr. Aisha Nasir from MS Ramaya Medical College, third year surgery resident.
So now that the introductions are over, we'll proceed to the topic. Remember, this is in the Indian context. So we have done a lot of reviews and studies and all, and we have made it into the Indian context. In India, breast cancer is the leading cause of death in women due to cancer. And also of the incidence is in females is no longer CA cervix, it is CA breast. There is a substantial heterogeneity. That means no CA breast will be the same. There's like a fingerprint. No person, including twins, fingerprint will be the same. So carcinoma breast is heterogeneous, so difficult to treat. There are some challenges, and this is all over the world. To our Indian, I'll leave the slides, you do not photograph it. There's no copyright. You can use them, whatever you want to do with them to use, okay? There are challenges unique to our country, which most of us have experienced. Number one is resource constraints. Even in the metropolitan cities, there are resource constraints. The people end up paying from their pocket. And the drugs which are available are so expensive that they may end up killing the patient economically. The cancer itself will be there, but in addition, economical death also will be there. Our country is big and our country has different cultures. So because of that, very difficult to make protocols and guidelines, difficult to create those guidelines. And one more dangerous issue is we don't have a screening. And the reason, even if we had a screening, it's a waste of time. Because in our country, women who get CA breast, if you look at the median age, they'll be around 30 to 35. Mammogram will not pick up. So the aim of the panel is to update the postgraduates and delegates here on carcinoma breast. We have used we have simplified it, basic approach backed by level 1 and 2 evidence. And all these guidelines of all over the world we have collected to make this presentation. So anybody wants to go and refer, the slide will be here. You can go and refer this and cross-refer. And so coming to Shashi,
yes,
which is malignant in this?
The first image is the malignant one, sir, with the circumferential nipple retraction.
Yes. And is it important for staging?
No, sir. Nipple retraction does not imply in staging, sir.
It's only for diagnosis. So it's recent onset, unilateral, circumferential, and it's not important for staging. About dimpling and puckering, they are not this, lot of confusion. I'll take this. There's a lot of confusion, dimpling versus puckering versus tethering. Dimpling and puckering are the same. They are inspectory findings. Tethering occurs before dimpling. When you press the lump, if you get a dimpling, then you get this features. So in the top picture, you see that when pressed, you will get a dimpling. It's not there before palpation. Only after palpation, you get a dimpling. That is called tethering. The bottom one inspection is called as dimpling. Dr. Ayush, what is this?
So this looks like a Paget's disease of the nipple.
And what is the significance of Paget's disease of the nipple?
Sir, Paget's disease of the nipple can occur in cases where there is ductal carcinoma in situ as well. So we need to first rule out malignancy and if there is a lump, and accordingly we
Now
treat
one question a lot of people ask, is Paget's disease important for staging?
Sir, it is added as a prefix or a suffix after the staging, but per se it is not considered while staging the disease.
So what is this?
So this is a Pseudorange. This is a telltale sign of carcinoma breast. It occurs because of the obstruction of the subdermal lymphatics of the skin, and it is a sign of locally advanced breast carcinoma.
So the other signs of LABC are right there. This makes it T4, T4B. So other signs are there. All those signs, if they are there, no other sign is accepted actually when you stage it. So very important, we forget edema. Edema is the first thing that occurs. So now, Sanjana, which is more accurate,
Yes.
TNM staging, after you examine or after you investigate?
So after investigations, after the entire investigations, including the metastatic workup is complete, and then I would like to stage.
So when you are planning a treatment, entire, not clinical TNM, although we in clinical exam must have happened in the morning, we take TNM staging, but that's not accurate. The accurate staging occurs only after investigation, including workup for metastasis. So let's say we are investigating a lady who walks in with a breast lump to the breast clinic. She's 30 years old and she says, doctor, I have a breast lump. Your first investigation will be imaging. What do you want to do? She's 30 years old, ultrasound, mammogram or both?
So,
Dr. Aisha.
So I would like to get both done, both ultrasound and mammogram.
But she's 30 years old. We said that it doesn't work. I just told in the introductory.
So, but she has she could have a palpable lump. It's not just for screening purpose. It will also help me in diagnosis of the disease.
Just like you, I'll also do both. And I'm sure the audience will agree. One is not enough. And like you said, this is not screening. It is diagnosis and treatment planning. So age criteria is only for screening. When there's a client, when there's a patient, only do both. Okay. So does MRI have a role? And there are indications for MRI. Somebody can look up the textbook. Not very commonly done here. It's only a problem solver. So my question to you, Shashi, is why you want to image a CA breast? Just directly do biopsy and operate.
No, sir. If it's a multicentric disease also, we need to know the involvement of the lymph nodes, and also if there are multicentric lesions. Not all lumps may be palpable, sir. So to know about those, and also to know the character of the lump also, we need to do imaging. Second thing is about the lymph nodes. Many times the lymph nodes might not be palpable, but they may be picked up on the imaging. So imaging is a must, sir.
So without imaging, so like you rightly said, multicentricity, but how this going to help, like multicentricity?
So the management differs, sir. If it's a multicentric tumor, then we cannot plan for a breast conservation surgery.
So all these are reasons why this one. So one, we look for bilateral, and it helps us to plan BCS, SLMD, all that. Without imaging, local imaging, we can't proceed with treatment of breast cancer. Now to Ayush, core biopsy or FNAC?
Sir, core biopsy is the gold standard for having a tissue diagnosis. Because the reasons are, firstly, it helps us to differentiate between an in situ and an invasive carcinoma. And secondly, from the tissue, we can also get the biological markers like the ER status, the PR status, HER2 status, which again help us in guiding our treatment if the patient needs neoadjuvant chemotherapy or chemotherapy per se. And also we can grade the tumors based on the grading of the tumors based on the biological markers. So a core biopsy is mandatory.
When in the CPC or when we do the tumor board, I've heard a lot of surgeons saying we operated, I don't care about biopsy, I'm happy with FNAC. I don't think in 21st century surgery or treatment of the breast should be done without a core biopsy. Why? It is gold standard for a reason. You get all this information and you get these markers which help you to decide the chemo and the treatment and prognosis. So you can't deny somebody that right. Okay, you might not be doing all this, but you have to refer to somebody who does it. And to you, Ayush, which is how do you detect metastasis? What's your plan?
Sir, firstly, we'll look at the stage of the tumor, sir. If it is a higher stage of tumor, then I would like to first go with a CT of the thorax, abdomen and pelvis to look for
What about CT brain?
So CT brain I will do only if the patient is symptomatic for any CNS symptoms. Otherwise, generally we do not do a CT brain.
So CT scan is always preferred, although we can do X-ray, but as the stage advances, it's better to do the CT, pick it up earlier. CT brain is not done unless there are symptoms. And the next question, a lot of people ask me to Sanjana, any role for PET CT?
So lately PET CT is preferred, but in our disease, like the one that you're showing in the case scenario, it's not preferred for the early stages. It's preferred for the late, like
yeah, see what happens
advanced.
in stage 1 and stage 2A, there's no role, but stage 2 and beyond, it has a role. And one thing is, it has supplanted bone scan. Will you do bone scan after you do PET CT, or you're happy with the PET CT?
No, I'm happy with the PET CT.
So one additional investigation, bone scan is avoided. Although the bone scan is cheaper, PET CT is 23,000 and it takes appointment and all those things. We do not do an additional test. And things like stage 3 become stage 4. So the treatment of stage 4 is totally different. So let's go to the scenario for Aisha. So here's a lady, she comes in and you do a core biopsy, you have worked up everything, it's T2, N1, M0. She's triple negative breast cancer, ER negative, PGR negative, and HER2 negative. Grade 3 tumor, and she has no family history of breast cancer. Now my question is, will you do genetic testing?
Yes, sir. I would do genetic testing.
So,
because
yes, and can you tell the audience why we have to do genetic testing?
Because it is a triple negative breast cancer below the age of 60, regardless of family history, genetic counseling is needed.
So there's something called the BRCA1 gene. And what happens if she tests positive for this?
We can start her on PARP inhibitors, sir.
Not that. If it's BRCA1, she tests for BRCA1. Then if it is BRCA1 positive, then
genetic counseling further can be given.
Yes, genetic counsel not only to her relative also.
And any prophylactic surgery can be planned for her.
For the ovaries, prophylactics, very good. Any other reason in chemotherapy, in addition to chemotherapy, you said it. So in addition to chemotherapy, you need something called as a PARP inhibitor, which is definitely going to help in BRCA1. Now, Shashi, does everybody needs a genetic testing?
No, sir. There are clear-cut indications. Like if there is a family history in a patient with a positive family history and breast cancer less than 50 years of age, genetic testing is needed. In any women less than 60 years of age with triple-negative breast cancer, again genetic testing is guaranteed. So
there are clear-cut indications. And will you do the entire panel which is available to you, or you are happy with?
No, sir. If only there is a high suspicion, high-risk candidates, we would do the complete panel, or else there are because it also costs a lot, sir, the genetic testing. So based on that, we will scrutinize the patient and decide as to which panel we have to do.
So all these help. Genetic testing helps in targeted treatment, chemo, choosing the chemo, whatever advantage you can get, you will get it by testing it, but not routine. So now, Ayush, what is early breast cancer? So because we are not going to discuss TNM, since it's a PG audience consultant, TNM is set. So what is early breast cancer?
So the tumors which are ductal carcinoma in situ, which are either picked up on screening or biopsy proven, and stage 1 tumors, which is like T1, N0, M0, and stage 2 tumors, T2, N0, M0, or T2, N1, M0, they all fall under the category of early breast cancer.
There is a bit of a controversy as to EBC, that stage 2B, but we read the Bailey, we are taking the Bailey as the reference, which is the reference book in most universities. So that clearly says that 2B goes into locally advanced breast cancer. So what is a locally advanced breast cancer, Sanjana?
So as discussed, locally advanced breast cancer, it's above after 2B. The other criteria is like 2B, the criteria is the size that is more than 5 centimeter with the axillary lymph nodes palpable, and also the ipsilateral ipsilateral intramammary lymph nodes, supraclavicular, and also inflammatory breast cancer.
And there is a term coined called as large operable, which for 2B and 3A. So all the other criteria what you told is there, chest wall fixity and other things, okay? So let's go to a scenario next for you, Shashi. So a 35-year-old lady presents with a breast lump. It is about 2 centimeters in size. No axillary nodes either on palpation or ultrasound. No other findings, inspectory or palpatory. No family history of breast cancer. BIRADS 5, core biopsy, invasive ductal carcinoma, luminal A, okay? And metastatic workup, no metastasis. Now, what would be the TNM stage of this person? Simple case scenario, what would be the TNM stage?
T1, N0, M0, sir.
So this qualify as a EBC or?
It's an early breast carcinoma, sir.
So, correct, stage 1, early breast cancer. So, now, Ayush, how will you proceed?
Sir, since the patient has already been worked up and we have already got that there is no metastasis, it's a early breast cancer, I would like to proceed with a breast conserving surgery for this patient because it's a small lump, 2 centimeters. So I would like to do a breast conservation surgery.
Now what about the lymph nodes, like you want to do?
Sir, here since clinically there were no lymph nodes like palpable, so on table I would like to proceed with a sentinel lymph node biopsy. And then like based on the findings of my sentinel lymph node biopsy, I would proceed with axillary dissection, or I would just abandon the procedure there.
So now, Sanjana, what next?
After the SLNB, like during the as Sir said, SLNB if it's done, and when we take the nodes for sampling, and if 2 nodes are positive or less, then I would just let it go. But if it's more than 3, then I would like to continue with the axillary lymph node dissection.
So if you look at all the trials, if you're able to follow what is written and what she's saying, if you look at all the trials, you'll find this very clearly that thousands of cases they've done, and from that they have got this guideline like what she said, more than 3, or there is an extracapsular spread, then do LND. Yes, let's say you don't have consent, or Aisha, you don't have consent, or it came as positive, it came as negative. Whatever nodes you sent, unfortunately came as negative, and later on it came positive. What are you going to do next?
So radiotherapy, radiation to the axilla.
If there is a very good alternative, there's a Amoros trial, 10 years they did it, and now it's become evidence now. So if ALND is not feasible, not done, then do irradiation, same result it will be. Remember, however, if you are doing an MRM and you get positive nodes, you're right there, just do the axillary lymph node dissection in the standard manner. Now to Shashi, what is a BCS?
Sir, BCS is a breast conserving surgery where we follow all the oncological principles yet maintain the cosmesis of the breast. That is the primary principle of BCS. And in BCS, as it is already shown and we discussed previously, the axilla should be addressed by sentinel lymph node biopsy. And ALND is done only if indicated, or else ALND is not proceeded with.
So if either of the issues are compromised, then it should not be done, BCS. But the rule is do BCS as far as possible, but don't overdo it. MRM is not gone away, but BCS should have cosmesis, yet should be oncologically sound. So, Ayush, what are the contraindications to BCS?
So the contraindications are only in conditions where we are not able to give radiotherapy, like example, if a patient is pregnant, or if the patient is having any connective tissue disorder, or there is already a history of prior chest irradiation. And secondly, if there is a large the lump to breast ratio where we will not be able to achieve a PCS, so they will do it. And in cases of a diffuse multicentric disease, and if the mammogram is showing diffuse microcalcifications, also BCS is contraindicated.
So in the 21st century, offer the woman a BCS unless it is contraindicated. BCS has various forms, lumpectomy, oncoplasty, all those. Try to conserve the breast as much as possible. Give up only when contraindicated. Absolutely not possible, then only do MRM. Don't make MRM as a plan one. The lady deserves to have a breast, no matter the menopausal status, whatever. She deserves to have her breast. So most of the ladies who has had MRM, they have psychological issues. So many issues are there. So try to go for BCS. We have facility everywhere now. So what is the role of chemotherapy, Sanjana? Give or not to give?
So we have to give chemotherapy in this.
This patient?
I'm sorry, could you show the question again, sir? I'm sorry.
No, it is a luminal A.
A luminal A, yes. In invasive carcinoma breast, it is mandatory.
Yes, but not
required in luminal A. Okay.
Except if there is more than 3 lymph node metastasis, or which does not have any extra capsular spread, then you can skip it. But if more than 3 and there is an extra capsular invasion, you have to give. Okay? The regimen depends on whatever histopathology you'll get. And then one more thing is you should give it within 6 weeks. Otherwise, it's as good as not giving it. So 6 weeks is the period. So your radiotherapy comes later. Chemotherapy always comes first. So, Aisha, any further treatment?
We can give hormonal therapy, sir.
What about radiotherapy?
Radiotherapy has to be given in case of BCS, sir.
Yes,
Radiation is mandatory.
Radiation is mandatory. What about the axilla? Is it irradiated? Only
if ALND was not done.
And the other indications are right there. Hormonal therapy, Shashi.
Sir, it's a luminal A subtype as it is shown. So hormonal therapy is mandatory, sir. And we would go ahead, if she is a premenopausal woman, we go
30 years old.
Yes, sir. She is a 30-year-old woman. So we go ahead with tamoxifen. And if she is planning for pregnancy, we would go ahead with GnRH antagonists. And if she is a post-menopausal woman, we would go ahead with aromatase inhibitors. So
theoretically, GnRH is okay, but it doesn't do well. So what we now advise in current situation is banking of the eggs. We ask them to go for a banking, and then we give it for 10 years. 10 years.
Yes.
So Ayush, what is targeted therapy and any role?
So targeted therapies are used, like suppose if the patient is having HER2/neu positive tumor, so then we have drugs specific to HER2/neu positive, like trastuzumab or pertuzumab. So they help in like targeted therapy to that particular subtype. And like mentioned, if it is a BRCA1 positive tumor, then we have the PARP inhibitors as well.
So this targeted therapy is huge, huge. It's a conference in itself. Like we'll have to have 3 days of targeted therapy conference. So to summarize all applications, it means it does have, like they say in Hindi, "Dubte ko tinke ka sahara." These help, just marginally help. Some of them help very well, but they are done and they should be offered. Okay. So the scenario you did it, no? So we got Sanjana. This is a 30-year-old female, no family history, breast lump of 6 into 5, And when you clinically examine, it is stuck to the serratus anterior. There are 2 mobile nodes, BIRADS 5. Mammogram has been done, no multicentricity. Core biopsy is ER positive, HER2 new positive also, no distant metastasis. So what is the stage?
So the TNM staging will be T4A, N1M0. So that will again come to locally.
But why is it T4A? Because
it was fixed, given that it's fixed to the serratus anterior, which is a part of the chest wall,
yeah.
and that's
But
why.
What about pectoralis major?
No, sir, it is not a part of the chest wall.
So there is one difference there. Whenever the lump is in the lower outer quadrant, that you have to do 2 times more. Even if it's mobile, it can still be T4 if it is fixed to the serratus anterior. So what you will do next?
So next, all the metastatic workup, everything is done. So to plan for the further surgery or something, I would like to first, since the size is large, I would like to go for neoadjuvant. But before that, I would like to mark the tumor. So I would like to mark the tumor and then go for the neoadjuvant therapy, and then we will see if it is responding by decrease in the size, and then further treatment or the surgery will be planned.
You want to keep the cancer there? Give chemotherapy? Isn't it going to grow, the cancer?
No, sir. Neoadjuvant chemotherapy, it's given and it's helpful. It will help you reduce the size and sometimes even disappear.
What's that called when the size reduces?
Response, pathological or clinical response.
So don't forget to add trastuzumab because this is a HER2 new positive patient for this scenario. So I would go a step ahead. I would take a photograph also and document the size and measure it and all that. Then only I'll give, so that future, and tattoo it. Yes. Now we'll come to it, why we have to tattoo it. And then when will you operate?
As said before, within 4 to 6 weeks.
Yeah, otherwise again it will no value. Radiation is mandatory here, okay?
Hormone therapy because it is,
yes. So what chemotherapy would you prefer?
Sir, along with trastuzumab, I would like to give the TCH.
So there are 500 regimens available. If you read, you'll go mad. So this is the best one. In all the chemotherapy regimens, they're not the same. If it's HER2 new positive, we give this.
Docetaxel, carboplatin, and trastuzumab.
So 3 cycles for 6 weeks. Remember, HER2 new positive with ER positive, only 6 cycles for 3 weeks. No need to give. Sometimes you add this drug, pertuzumab, but it is compliance is there, vomiting or neuropathy, all these things, so they sometimes don't give. What is the chemotherapy for triple negative breast cancer?
So along with carboplatin.
So this is the regimen. You can read it: paclitaxel and carboplatin, along with pembrolizumab for 4 cycles. Thank God I passed my pharmac long time back. Otherwise, they would so many drugs to read. Then you add anthracycline and you give it for, along with the same drugs which we mentioned, 4 cycles for every 3 weeks. If it's ER positive, we go AC into 4 cycles and taxane into 4 cycles. Now, Ayush, how do we know chemotherapy worked? So Sanjana had said it will disappear, it will go away. So how do we know it works? Sanjana, you only answer.
So the size of the tumor will reduce, that is like the clinical response. And if it completely reduces, then it's called complete clinical response. But if there is more than 30%, then it is partial.
Okay, go on. Suppose it doesn't, it increases?
If it's not responding, then you'll have to change the regimen or you'll have to go ahead and operate.
Fine. Now, can BCS be done, Ayush?
So yes, sir, BCS can be done in this.
How do you decide the margins? The one before chemotherapy or the one after chemotherapy?
So the one before the chemotherapy, sir, because after the chemotherapy, the tumor will shrink in size. So we need to have a pre-operative
So if you go by the new margins, there's a chance of you fail in the surgery. There is a chance of positive margins. So take that previous, so that explains why we have to photograph, tattoo and make it. Right? Now, Sanjana, what if the tumor disappears?
You still go ahead and operate, sir, because clinically we might not be able to palpate, but it might be pathologically positive, or basically the residual invasive tumor. The invasive tumor part might still be there.
Absolutely, and you may have to add. So this is called a ghostectomy. Whenever the tumor has disappeared and you go with the tattooed margin, it's called as ghostectomy. and the tumor is called as a phantom tumor. So many terms are there. There's a tumor goes away. So what to do? Mark it before only. That's the reason you have to put a permanent marker. Now, patient will tell me, doctor, nan lump hogbitide, why you want to operate me? This is the common question. Complete response is more counseling needed than no response. How are you going to convince Shashi, Major?
Sir, we would still convince the patient because breast carcinoma is a systemic disease, sir. So we would still counsel the patient for undergoing a surgery, because more stronghold is for the complete pathological response than the complete clinical response.
So can you tell the audience in a few words, like what is a pathological response?
Yes, sir. Like whenever we are looking for the response of the chemotherapy, there is something called as RECIST criteria, where it classifies the response into a clinical response, complete response, partial response, and progressive disease or a stable disease. In the responders, again, it is a clinical response or a pathological response. Clinical response is what we see clinically. After giving the chemotherapy, compared to the previously marked size of the tumor, if it is reducing in size, it's a clinical response. Whereas pathological response is based on the specimen that is sent for the biopsy. If the margins are completely gone, like the tumor negative, then it indicates a complete pathological response.
So, pathological response, the disease disappears both in the tumor with the negative margins as well as the lymph nodes. So, this is the justification for ALND in N0 locally advanced breast cancer. You have to see whether lymph nodes have no disease. So, Ayesha, is there any role for neoadjuvant chemotherapy in early breast cancer?
No, sir.
LABC established.
No, sir.
No role? Any difference of opinion?
There is a role, sir. If it is a triple negative breast carcinoma, then neoadjuvant chemotherapy has a role.
Yes. Suppose the college you're working in, suppose the tumor board says, we want to do a study. Then you are forced to do it. It's called Institution Tumor Board Protocol, where you go against the norm and you have clearance in the ethics committee. And triple negative breast cancer does very well if you do neoadjuvant chemotherapy, irrespective of the early or late. Now, for you, Ayush, this is a 30-year-old lady. She comes with an ulcer with raised reverted edges. This also slide I have taken from that panel 20 years back. All investigation proved that it's a T4N0M0, stage 3 CA breast. Now, what would you do, Ayush?
So this is also a locally advanced like breast carcinoma only, sir.
There's an ulcer. Now I want to operate it.
Yes, sir. Like so after we give the neoadjuvant,
post this patient. I will say post it. Now convince me not to.
So we can post the patient to do a biopsy from the ulcer, but for the breast carcinoma per se,
you don't need a core biopsy here. You need a edge biopsy.
Edge biopsy.
So what neoadjuvant will work? What do you feel?
So yes, sir. Like neoadjuvant is known to even reduce the size of the ulcers, and it completely disappears as well. So it is treated like a normally a locally advanced, and
so no change in approach. Edge biopsy, BCS judgment is needed, of course, because a lot of skin is involved. And this was the result of the CMF regimen, not all those regimens which you read. CMF regimen, I think it's Sir's patient only. So I just took the photograph. RT, afterwards RT, and then she has gone for BCS. I don't remember that, but the tumor, the ulcer has totally disappeared. Now, Shashi, scenario for you.
Yes, sir.
Now a lady comes with it's a T3N0M0, stage 3 A breast cancer. What do you want to do?
Stage 3, sir. I would treat it like a locally advanced breast carcinoma. I would go ahead with biopsy, and based on the biopsy, then I would go ahead with the surgery, because it says 3A, so it comes under that category of large operable breast carcinoma. So I would proceed.
Remember that if it is triple negative, go for chemo first. It will do best in that. In fact, but it's the best thing to do is to convince the patient. And all others, always neoadjuvant is better. Always, it's got some advantages. To discuss that beyond the scope of this class, if I have time, I'll tell. So this one more scenario where we face bilateral breast cancers. Okay, this lady comes, school teacher, family history is there. Now, elder sister also had, and she has one lump, synchronously it comes, 3 months difference. One on the right side, one on the left side. So, you clinically examine, investigate, no metastasis, T3N0M0 on one side, same biopsy report on the other side, T2N0M0, same status. So, my question is, will you stage separately or will you stage together?
they have to be staged separately, sir. And the stage will be the highest stage which is assigned to among those tumors.
Yeah, about 2 decades ago, when I was teaching that time, but let's say 3 decades ago when I was a postgraduate, that time they used to say one is stage 4, one lump you'll get stage 4. It's not correct anymore. It has to be staged as 2 separate cancers, but you have to do more workup in those patients. Okay? What will be the stage? How do you stage this? That is TNM staging, different. How will you stage it?
The higher stage.
Sir, we put a
higher
prefix.
stage.
Yes,
Correct.
The highest stage is given, and we had a prefix as MTNM, that is multiple carcinomas with TNM staging.
So, Aisha, one question is, how will you treat? Treatment is a challenge. How will you treat?
So individual side.
So, what's your plan for the right side?
So right side, we can still go for BCS, breast conserving surgery, and even left side, breast conserving surgery, sir, with SLNB.
There's a problem there, because in bilateral, one you should do MRM and one you should do BCS. Now there's a problem. Why? Theoretical problem is the radiation. See, left side radiation is difficult little bit, but this is a BCS, no? So on the left side BCS, right side, yeah. But there are studies where bilateral radiation is given, nothing happens, but there is a risk. If the MRM was done, if it was left side, it was easy. MRM on the left side and BCS on the right side. Why? Because radiation can be avoided. And the other side, BCS you can easily give. But I have talked to a radiation oncologist and we have faced this. Bilateral radiation can be given. Chemo of course acts equally. The rest of the things are systemic, so they act equally. Only challenge is radiation, if you have to give. So Sanjana, you have done a mammogram, you are sitting in your clinic and a mammogram comes and there are microcalcifications. No other clinical features. Lady says, the radiologist said you have some calcifications. He is telling some BIRAT, some figure he has told. I don't understand this numbers. So how will you proceed?
So microcalcifications is a sign of malignancy. So I would
maybe a sign of malignancy.
Maybe a sign of malignancy.
Okay.
So I would still counsel the patient regarding malignant breast XCA breast. And I would go again the same protocol as we've been following. I would still go for a core biopsy. And
yeah, here is where core biopsy is absolute mandatory. Not when you have a lump. Here is where it is absolute mandatory. And can you tell us why?
Because there is no lump or there's nothing clinically that we can find. So when we do a core biopsy, we get a larger chunk. And
no, see, what happens is calcification can be T1. You can have non-palpable T1. T1 is invasive. And you can have palpable DCIS, which are detected, maybe small, you can feel a nodule. So here, let's see, get calcifications. There's a half and half chance that one may be DCIS, one may be a T1. So here is where core biopsy is needed. To know T1, because T1, you told, no, treatment is totally different. So let's see, core or FNAC, we will do a core, we already explained why. Let's say the core comes ER positive, HER2 negative, DCIS. What are you going to do next?
so I would like to operate. But I wouldn't like to give chemotherapy here because it's a DCIS.
Correct. So you do BCS if not contraindicated. No SLNB is there here because it's a N0, it's this one. Radiotherapy 100%. If you are doing MRM, no need. No role for chemotherapy. But if hormone, it's positive, so you give tamoxifen and
yes.
And if it is negative,
no hormone.
The tamoxifen is for the other breast to prevent other malignancy in the other breast. Now, you have not had, no? 45-year-old patient, carcinoma breast, triple negative, this is the last one probably. Carcinoma breast, triple negative, CT scan shows liver secondaries. Stage 4. You have done the workup and then, will you investigate further?
Sir, here because the patient has liver secondaries, so there are high chances that the patient might also have bone secondaries as well. Because bone metastasis occur earlier as compared to visceral metastasis. So we have to also first look at if there are any bone metastasis. So for that we will do a bone scan.
So nowadays we do PET also, so we can pick up in one go. But in those days when we don't have the PET in your town, you are relied only on CT, then bone scan has to be done. Even if it is secondaries in the chest or liver, we will do that additional test. You won't say, how will it change the staging? I was asked once, how will it change the staging? So I said, then this is the answer I gave. So that's the scenario, okay? So this bone scan was done, it has spine secondaries. What's the further treatment?
Sir, if there are the spine secondaries, then we have to like provide like radiation to the bone, sir, to prevent any pathological fractures which the patients are prone to. And also with that, we would also supplement like vitamin D supplements and bisphosphonates, which would prevent the osteoclastic activities, because breast carcinoma is known to produce osteoclastic
We
metastasis.
cannot allow a bone secondary to cause quadriplegia. Just because it's stage 4 doesn't mean they have to die bedridden. They have to have some life. So in addition to palliation, radiation, and to strengthen the bone, and then remember that I told stage 4 is divided into those with visceral mets, those with bone secondaries, and those with both. You have to identify bone secondaries, and you have to identify where they are, and you have to treat them. Otherwise, you have a chance of fractures, quadriplegia. Of course, palliative chemo and all will go on. Is there any role for surgery in this, Aisha? Any role for surgery?
No, sir. No.
Why operate? Remove the breast. Chemotherapy load will be less. All these are told by people, that's all. Why you operated? Chemotherapy load will be less, sir, so I operated it. In morbidity
We usually
meetings,
go for palliative.
it has no role by removing the breast. It is metastases are everywhere, no? So it won't change the fate of the patient, nor it will. When will you operate? Let's say I'm forced to operate, Shashi. When will you operate?
Fungating.
Fungating, sir.
Only when there is a fungating growth which is causing nuisance to the patient, then we would think of removing the breast just to remove that nuisance. So it is called a toilet mastectomy, sir. Yes, sir.
So now I'll just summarize, and there's enough time for audience question. That's how we designed it. So the take-home message, always image both. See, a lot of radiology people say, why both breasts? I mean, I have to tell you, have a low IQ. You do not image one breast alone. Bilaterality we image. So USG and mammogram, always before biopsy. Core biopsy is the biopsy of choice because it dictates further treatment. CT, chest scan, abdomen, pelvis. If you say, I want to do ultrasound and chest x-ray, be my guest. You'll miss a lot. You'll miss a lot. Better to refer. See, what I always say, future is here. It doesn't care about you. The future is already here. It is going to push you out of the way. Okay? AI has come in computer science industry, will soon land here in medicine. So please adapt to the modern day medicine by ordering a CT scan, by ordering a PET scan. PET scan has replaced bone scan. BCS is, whenever BCS is not contraindicated, do it. SLNB in N0, otherwise ALND, can do ALND or radiotherapy. Always chemotherapy except luminal aid node less than 2. RT always if you do BCS. Hormonal therapy when ER positive. Targeted therapy when indicated. LABC prefer neoadjuvant chemotherapy. Since this time, the advantage of neoadjuvant chemotherapy is the chance of mortality is reduced drastically. Suppose EBC, the chance of recurrence is 0.3%. In LABC, if you operate, the chance of recurrence is 37%. Your chemotherapy is blind. So you can't identify those where chemotherapy will not work. Though, suppose you operated, 37% people come back. That's a significant number versus 0.3. When 37% people come back, that means your drug has not worked. There is chemotherapy resistant cancers also. Okay? So by not giving, you have denied the patient of a correct treatment. BCS can be done. BCS can be done. ALND always has to be done. There's no role for SLNB. Radiation always. Hormonal therapy on ER positive. In stage 4 palliative chemo, no surgery unless infected or fungating. ALND is not needed. Always try to detect bone secondaries. The slides I'll give it to the organizers. And if you want, you can just take it from them. This is a summary. Huh? YouTube it is there. So thank you for the patient listening, and we have 3 minutes for questions. Any questions, any comments, and the senior surgeons are here. Let the slide be there. Slide. Yeah. Slide. Run the slide.
I just wanted to say that, that patient particularly referred as a breast abscess, incision and drainage has been done, and wound is not healing. That particular, you have seen that ulcer which is not healing. Very carefully you see the edges are everted. I just want to bring you the word that mastitis carcinomatosa, otherwise inflammatory carcinoma. So that is the one of the blunders which ideally we are not supposed to do, because ultrasound they did some suspicion of abscess. So that was that case number one, and one before that that is the one. That before that, yeah, that you look at that edge very carefully. Yeah. That is one. Second is one question to Major.
Sir.
I just want to acknowledge in front of you that we recognize a Major here. I think claps, please.
Thank you.
That is name.
Thank you. Shashi Shekhar.
Shashi. One question to you. When you have done a core needle biopsy, how do you know it's not fat, it's only the tissue?
Sir, we, while sending the sample, we put it in the sample. If it is floating, it's a fat, sir.
Excellent. That's what the answer I wanted.
Yes, sir.
Yeah. So, anybody wants to ask the panel a question to them or to me? Welcome.
I don't know if I'm asking this question to you or the panel, but
it's all right. So I'm part of the panel.
Yeah, no, consider me as the junior most student here.
Yes, sir.
There are the things have taken a total turn from advising BCS to early to BCS to wherever it is feasible.
Yes.
Am I right? That
yes.
That's the message you are giving.
Yes.
Yeah, that means, I came across this in an earlier webinar where I called Rajgopal at 11 o'clock in the night. Because if a PG were to answer T4B, he is going for a BCS. I have serious doubts that I won't do that, because I'll keep my, but we may be putting him in trouble, because there are hardliners who will oppose BCS for anything beyond an T3. T4B is, I'm not objecting to that.
I have an answer. They might not be able to answer. I will answer.
That's why I said.
See, the concept of giving BCS is from 1968.
I agree.
It is not a new. It is NACBP trial number 18, where they gave AC 4 cycles, and then they gave surgery, and then they did 4 cycles. What they found was BCS was possible in T4 lesions. So there is a judgment needed. What I mentioned, T4B, no? That slide skipped, I think. In T4 here, see, BCS judgment needed. There is
I'm not questioning the science behind it.
Yes, sir.
My problem is considering me as a PG.
Yes.
Because midcon is for PGs.
Yes.
So considering me as a PG writing, facing an examiners, 4 examiners, if 2 of them object to that, there will be a fight. Unless the other 2 examiners defend this concept, so it is for us to change our mindset.
Midcon is also for examiners.
Exactly. Yeah, that's the one.
Number one.
Yeah, second.
There are 4, sir.
Yeah.
1 at least will agree. No?
Yeah.
that is the concept of 4.
Yeah, because I faced this difficulty when I was a candidate. Anyway, that's our history. The second is we have specific criteria for. Targeted therapies of trastuzumab, CDK, all those things.
Yes, sir.
What is the criterion for selection for pembrolizumab, checkpoint inhibitors?
HER2 new negative, when it's triple negative breast cancer.
Across the table, or we have selective.
In that much depth, I don't know, sir, because I'm not an oncologist, medical oncologist.
Something like microsatellite instability or one of these genomic studies. How will that help us predict this patient will respond to pembrolizumab? Or
see, all this is like shot in the dark.
Yeah.
All these. See, even if they have some tumor marker to this one, which it expresses.
No, I'm not aware of it. I'm just asking. This is a question.
See, all these are based that this is there, give this.
Exactly.
But that is 7 to 8 lakhs. In theory, it is good to tell, but when you tell the patient you have 1 lakh per month for the next 12, you'll survive 5% more, then they run away.
If they get a question, short notes, 10-mark question, short notes, checkpoint inhibitor, what will they write? What is a CKI? Where is it used? But which subset of patients are they going to use?
That's short time, I really don't know. Somebody's there.
I also don't know.
Yeah. Somebody's there in the audience, they can answer.
Because it is said that an idiot can ask any question that a genius can't answer.
Yeah. No, I really don't know the answer, but what my concept, if it is targeted therapy, is based on some markers. Whether it works or not, it is this one. Anybody, PGs want a question, or we can wind up? So, thank you for giving me, I thank the panelists. They've done a wonderful job. Please stand up and please give them a big hand, please. So the initials in my name is BS. So a lot of people confuse that with breast surgeon. I'm not. The breast surgeon Manipal is my senior postgraduate. Is there? You can.
Thank you, sir, for that enlightening discussion. Thank you to all our panelists for their valuable perspectives on managing carcinoma breast. I now request Professor Dr. B. Srinivas Pai and all the panelists to proceed to the photo booth for a photograph and to collect their certificates of appreciation. I request Dr. Gopinath Pai to kindly hand over the certificates.
We will be beginning with the valedictory function in a couple of minutes. There will be a series of speeches by Dr. Srinivas Pai, Dr. Likith, Dr. Rajagopal Shenoy, and Dr. Sarvesha, who will be concluding with the vote of thanks.
As surgeons, we dedicate our lives to saving others. But who stands by us in times of need? The Association of Surgeons of India, ASI, Social Security Scheme, SSS, is a trust-based initiative designed to provide financial security to your family when they need it the most. Why choose ASI-SSS? Successfully running over 10 years, a trusted support system for surgeons. No hidden charges. Your contributions belong to you. Every rupee you contribute goes directly to the family of a deceased member. Loyalty bonus. Recognizing and rewarding long-term commitment. No insurance company involvement. A direct support network managed by ASI. Surgeons supporting surgeons with complete clarity. By joining ASI-SSS today, you're not just securing your family, you are strengthening the ASI family. Decide today for a safer tomorrow. Enroll now. A surgeon's journey is more than just skill, it's a legacy. Scalpel in hand, precision in focus, and the unwavering commitment to save lives. But beyond the operating table, a greater force unites us. The Association of Surgeons of India, ASI, a second largest surgical platform in the world to share your knowledge and skills, to learn cutting-edge technology with access to global surgical advancement, participation in conference, workshops and fellowship program. Shape the future with research and innovations that redefines surgery in India. Experience the unmatched opportunities to learn, to share and to innovate. If you walk alone, you go fast. But if you walk together, you go far. Be a part of legacy. Be a part of ASI.
Yeah. Today, from yesterday, the program is going on. Most of the postgraduates who have registered, most of them they have attended, and many of them are going around the Mangalore and sea areas. It's a good thing. We have come to the last part of the program. Please be seated.
Good afternoon, ladies and gentlemen. As the curtain gently draws to a close on this two-day academic celebration, it is time for us to pause, reflect, and rejoice in the collective wisdom we shared. The 8th KSC ASI-midCON 2025 have been a confluence of knowledge, innovation, and camaraderie. And today's valedictory function is both a moment of gratitude and promise to carry forward the moment we have built. I request the dignitaries to kindly occupy their seats on the dais. Dr. Rajagopal Shenoy, Dr. Sarvesh Raje, Dr. Naz Jahan Sheikh, Dr. B. Srinivas Pai, Dr. Likit Rai M, Dr. Satyamurthy Aital, and Dr. Kiran onto the dais.
Okay, done. Can I take over? Thank you. So, very nice MC from yesterday morning to till now. Untiring. Very nice of you. Please be seated. Yeah, we'll start the program, the valedictory function, which you people are waiting since few hours or few minutes because you want to finish off and go and right on time. See, today I want to express few of the things before our chairman-elect, the organizing committee people and our scientific committee members, they express, and to upload also about the MidCON 25 at Kanachur Medical Science and Research Center. First of all, I would like to welcome Dr. Rajagopal Shenoy, Chairman, Karnataka State Chapter, Association of Surgeons of India, and I welcome him also. You know, that medallion I have put, it's the pride and the weightage of the Karnataka State Chapter of Association of Surgeons of India. A person worthwhile holding that one is our chairman, Dr. K. Rajagopal Shenoy. Sir, you are welcome. I welcome our chairman-elect, Dr. Naz Sheikh. Madam, welcome. Now I welcome Dr. Satyamurthy Aital, organizing chairman of our MidCON 25. I welcome the organizing chairman, secretary, Dr. Likit Rai, the young and energetic, along with the organizing chairman. They have done a wonderful job since yesterday for the program, which all have witnessed. The other side of it, many know, many doesn't know the hardship behind this one. And I welcome Dr. Srinivas Pai, our scientific committee member, and Dr. Kiran, Joint Secretary of the MidCON 25. So this was a wonderful program we have witnessed since yesterday morning. Though it took little extra time yesterday, but we are on dot today with Dr. Srinivas Pai finishing in time, sir. And we have few records here for this MidCON mid-year conference of KSCASI. That's the registration, which has crossed 550. That is 584 to be online. And we have record number of papers also, 145, the regular one. And addition to that one, we had trauma sessions for the first time in KSCASI MidCON, which all have appreciated that the papers were 145 and posters were 278. We had few more also, some got rejected, and we say you modify yourself, correct it, and you can come over to Raichur to present this modified one or a very good one also. We have trauma papers 13 and posters 8. See, these were the highlight things which we noticed from our KSCASI, and we are proud of it. Are you people also proud of it? Yes, thank you. And without much wasting time, I welcome all the dignitaries on the dais, senior teachers, ASI senior members, ASI members, our EC team, postgraduates, and all the members of today and yesterday's program, MidCon 24. And I now will go to the next part. We will have a comment on MidCon 25 by our scientific committee member and chairman-elect, Dr. Nas. Madam, please.
A very good afternoon. Respected Chairman of KSCASI, Dr. Rajgopal Shenoy, Secretary Dr. Sarvesh Rajayaras, Chairman of MidCon, Kanachur, Organizing Committee of MidCon, Dr. Satyamurthy Aitar, the able, the very enthusiastic Secretary Dr. Likith Rai, and the Treasurer, Dr. Kiran, and the scientific committee head, Dr. Srinivas Pai, all the dignitaries of the dais, my very good friends, Dr. Savita and Dr. Shilpa, Dr. Rekha, and all my colleagues, seniors, teachers, and whose names I couldn't mention, and the MC, wonderful job. Really, I don't know, not on the MC here, and those people who organized the sessions also, they were undergraduates, but I don't know how you people have got trained in such a short time. Commendable job indeed. So that is, I express my heartfelt gratitude to each one of you. And as I stand here amidst the gathering of such brilliance and dedication, I'm filled with immense gratitude and pride. The meticulous arrangements by the organizing committee we were constantly in touch with each one of you, and especially Dr. Likith Rai was, we have had multiple Zoom meetings, and he was always there, and he was agreeing to whatever conditions we were putting forth to. And we never imagined it would be such a feast coming to MidCon, and it was both an academic as well as a feast to our taste buds. It was indeed very good. And I wouldn't forget to thank Dr. Rajan here, and who was the visionary behind this. And all of you postgraduates are indebted to him. This platform, what he has created, is for you. He had you all in the mind when he created this, and he did have his hardships when he was starting this. For the first 2 years, we did have a problem, and I must say I was one of his. I'm proud to be one in his committee at that time when we formed this when we thought of forming this MidCon, and we have risen from that difficulty to the present day. And today we had registrations pouring in like the rains of Mangalore. So we were just, usually it wouldn't cross 280 or 300, and it is nearly double this time. And the papers also started pouring in, and we had real difficulty to select the papers. And I just want to mention a few things about the papers here. Some of the papers we had to reject. And when the papers were rejected, when the papers were sent back to them, many of them at least have not seen them. And then they started calling us very close to the conference that, Madam, I didn't see the mail. I couldn't get the paper. So these things shouldn't happen. So when you submit your papers, be vigilant to see your mail, what you're getting it back. And we have given you a chance to correct them, so that you can send it back, and probably no other conference does this. Only KSCASI gives you a second chance to see this and correct yourself and send it back on time. And then it becomes very difficult for us to listen to your requests, and it doesn't, and that is really going to be very difficult. And then some of the papers are good. So many of you have presented very well, but many of them come in as just for the completion for a university requirement. So that shouldn't happen. So when a paper is given to you, you present it with full zeal and with curiosity, and it is your pride actually. It is your work that you're going to present. So present it with utmost pride and choose topics that are meaningful and relevant to, especially since this is a general surgery conference, relevant to general surgery, and where our experienced colleagues can guide you and inspire you further. And then you should prepare well in advance. So, and then I would say that some of the topics, presentations were like, there are so many lines on the slide. It used to be paragraphs on the slides. And some of them didn't even put some charts, so no diagrams, no pictures. So some of them just read out from the slides. So that shouldn't happen. So you follow that rule of 5, where there are less than 5 or less lines, and then less than 5 words, and so you should follow that rule of 5 when you do it. So that the slides, it should be so that you will be easy. It will be easy for you to read, and then the observer will be looking at you and not trying to read the slide along with you, and then make most of this opportunity. And this opportunity is something most of them wish they had. So I think you are really privileged to have this opportunity. And I want to make a comment about that panel discussion by the postgraduates. I think they need a big round of applause. It was indeed commendable. And it was, I never felt they were students. They were more like MCH candidates, oncosurgeons and breast surgeons. So they were so clear about their thoughts. And Dr. Srinivas Pai, it was really excellent. And I feel proud that we had this thought in our mind again, that we should have PGs giving a presentation, PGs doing a panel discussion, so that you will be inspired to be speakers in the future. So that was the thought behind it. So your journey with MidCon doesn't end here. It begins here. Your presentation journey starts here, and just don't stop. Continue to present your papers, attend conferences, and you might think it's a waste of time. No, it is where you gather so much of knowledge, and then later on you join in as faculty and presenters. That is, and with this association you definitely grow. And I also extend my appreciation to the executive and scientific committee for all your efforts which you have given. And initially we had a little difficult time with the time management, but yesterday, but today we did complete on time. And I also thank all the chairpersons and judges who have been really very cooperative with us and helping us complete these sessions. And with rising expectations come a greater responsibility. So I urge each of you, in whatever capacity you can, contribute wholeheartedly to the continued growth and excellence of this chapter in the coming years. So I ask the students to become members of this association, not even just associated members. Complete your membership and become members. And it would be incomplete if I do not appreciate the hard work of all the volunteers here, right from the students, undergraduate to postgraduate. Each one of you have done a wonderful job. And one more, that applause was not enough. I want a bigger one, please. Thank you. Yes. Heartiest congratulations for a meticulous planning and excellent teamwork. And the food, as I said, was excellent. It was not only served as a platter of love and delicacy both. And hospitality was indeed supreme. And in closing, I thank each one of you for your enthusiastic participation, academic contributions, and unwavering support. Thank you for choosing me as the chairman-elect, and I promise to live up to the standards of KSCASI. Thank you, one and all. Jai Hind, Jai Karnataka, and long live KSCASI. Thank you.
Thank you, Dr. Nas, Chairman-elect of KSCASI. What she said in between is the opportunity was given again for the posters and papers which were not ready to get entry into the poster or paper presentation area. It was like something I remember now. Morning, the bus was sent to Mangalore to get the PGs from there to here, which was postponed from 7:30 to 8 o'clock. But fortunately, what happened was, bus was empty at 9 o'clock also. This is the program for PGs, program by them and for them also, which was started in 2018 with the brainchild of our senior members of KSCASI. But please utilize the things, participate and get the knowledge. And if you have more knowledge also, you give it to us also. We also are ready to take the things, because youngsters also have many things from the Google and the books and and their own things also. Now, Madam very well said, the recognition, the KSCASI recognizes from the senior member to the volunteers also. That's the same thing. And I would like to invite Dr. Likit Rai to comment about or the feedback about your program MidCon 25. Or any of the postgraduates next, please be ready, our delegates, to give a feedback very shortly.
Very good afternoon. Thank you so much, Sarvesh sir, respected dignitaries on the dais, off the dais, my colleagues, teachers and volunteers, my students. Feedback, I'm not the one who is supposed to take a feedback, give a feedback. I'm supposed to take a feedback from you guys. So the Google Forms will be uploaded in the group. I'm waiting for the feedback. Anyways, before that, I should thank Srinivas Pai sir and his team for crafting such a beautiful academic session and executing it. It is definitely a very difficult task, but I know Srinivas Pai sir will definitely handle it smoothly, along with Naz ma'am, and definitely they made my life very easy for me. And definitely I should also thank Martin for that reason, for segregating all the PowerPoints, coordinating with the delegates and arranging the PowerPoints and executing it. I'm really thankful for that. As well as I thank my volunteers, these boys and girls. Without these people, this conference wouldn't been possible at all. If Srinivas Pai sir and Naz ma'am has made 50% of my life easy in this conference, 50% of life has been made easy by these people. They have tirelessly worked since past 1 month or more than that actually. And to say thank you, there are so many names, but few names I have to take. Akid, Faruqi, Ryan, Hashim. I really forget these girls' names usually. After marriage, I keep on forgetting this. Before this, I used to remember. Arundhati, thank you so much, thank you so much. And my group of PGs, postgraduates, Satyam did an incredible work. I should thank my department staff, Rashmi and Hind, for being with me always during this journey of this conference and executing it. Thank you so much, and I'll be always grateful to you people. Kumar Krishna, I should not forget, he is a plastic surgeon working with me, and in spite of that, he is cooperating with my department and ready with all my department activities. I should thank. And two names I missed yesterday, which I have to thank them. One is, they are like two arms of mine. One is Dr. Vinay Alva, who was a treasurer yesterday. He came and just vanished just like this because he was really, really busy. And one more, my strength is Dr. Kiran. Thank you so much, thank you so much. These are the people who are responsible for the conference to be a real successful. Thank you so much, one and all. And if anybody have missed it, it is not intentionally. I thank each and every one of you. Thank you so much. Rajgopal sir and team, yes, I'm always grateful to you. And Aital sir, you too. Thank you, sir.
Dr. Likitra has almost finished the vote of thanks actually. Finally, I will say only one sentence because he has thanked all the people through him towards the gratitude what he has for their effort in bringing this conference a grand success. Now, as a token of honor, we are going to honor the organizing chairman and the organizing secretary symbolically by our KSC ASI. Wherever they are sitting, there only we are symbolically we are doing that one. Bye. Thank you, sir. Now, the presidential address by our chairman, Dr. K. Rajgopal Chane. Sir, please.
So, very good afternoon to each one of you. I'll not be speaking much because most of the things have been already done by chairman-elect and rest of the people here. So I come here only to show my gratitude. The best form of attitude to give the gratitude is just to say that hands of friendship and your, as we said, you are looked after us very well. Your compassion, your care, your comforts, and you have worked hard for this successful MidCon. Remember, it started just as a very low budget affair. This to begin with, there was nothing much. It was just meant for postgraduates, 90%, a small thing for younger surgeons. But the demands, increasing challenges, increasing facilities, everyone wants to have a bigger screens. Obviously, requirements start becoming more and more, numbers also becoming more and more, and this is going to continue also more and more. As we are not all that surprised to get the 250, 300, 350, 400 registration, because all of you know that one of the requirements for the postgraduates for appearing for exam is poster and paper. And we all know very well that all the PGs keep that for the just before final year exam. And all of you know that November it has come to now September. And everyone knows that last moment panic also will happen, and they suddenly you get, yes, sending papers, posters. So these are some of the drawbacks also of the whole system. It is not about anything. So we can also expect a large number of postgraduates in the next MidCon, which will be held in Sulya. So KVG Sulya. Gopinath Pai is here only. So you better prepare yourself well. At the end of the day, we are all proud, no doubt. But then it's equally important also to know the actual your attendance and participation. That's a word of caution for all of you. Because there are many of you are young. Lots of good advice has been already given to you, plenty. Because we keep on advising. And there is always a saying called as you hear from this side and it goes from that side. There is nothing unusual about it because everyone wants to take up MCH, definitely. You want to take up national board, some more super specialization. So please do not have that habit of just coming, do your paper presentation, poster and go away. Remember, so much work has been put. The bus which takes, they're not required from organizers and to get you all these things. But then nobody will come in the bus. So remember, this is MidCon is for postgraduates. So these are some of what you can call as a drawbacks or negative points about that. So a place like this with so much registration of the people, obviously we with the, I believe strongly with the probably the improvement probably can come in those coming years with the probably not just a feedback and other things, probably your presence wherever you are present for each sessions, and then only probably your attendance and all that rather the attending certificates. So these are some of the points. And again, as a chairman, it's my duty to also say that if there are some deficiencies or some negative part of this on behalf of the KSCASI, and I also take the responsibility as a matter of local organizing chairman and secretary on behalf of all of you. After all, Mangalore City branch is also part of KSCASI, correct? We all work together. Our aim is always we have to work together. That is our intention. So if there are minor things here and there, it happens, some delay, something, all that, yes, I'll definitely take the moral, I did that also during the wrong specs. So I'll take the moral responsibility, and we call it as a vicarious responsibility. But I think all of you will understand very well, the program is meant for postgraduates. That we should keep it in mind, and even the slots are very limited. That is very limited, so that we need to cover broader areas and within 1.5 days to give 2 symposia and 1 of the PG panels. So that is a very difficult task, so that to adjust our time, etc. I think that's all from my side. With this, I would like to say a big thanks to the local organizing team headed by Dr. Satyamurthy Aital, Dr. Likith Ray, Dr. Kiran Kumar, and everyone on my right side, left side, front. I request all of you to stand up and giving standing ovation, except you people have to sit. All we have to stand. You have to sit. Thank you. Thank you.
Thank you, sir. Now, this MidCon 25 has noticed a separate part of the poster and paper presentation. That is drama, paper, and poster. This was coined in memory of Dr. Manjunath Shanai, who was then Secretary of KSCASI, who lost his life in a tragic accident on duty. He was going to Ballari to attend the conference. So in memory of Dr. Manjunath Shanai, the poster and paper presentations were started this year. Hopefully we will continue the poster and paper presentation in a separate way also. For this, the chairman said we'll start this year. We'll see if it goes in a good way. We'll improvise it and we'll modify the things and continue the things. We have kept 2 prizes, first and second for the papers and first and second for the posters also. From KSCASI, we are giving 1 prize, and Dr. Lavanya Shanai, wife of Dr. Manjunath Shanai, has also offered 2 prizes for both paper and poster. I'll read out the names. The PGs, postgraduates, please come over on the dais and receive the prizes. In paper, trauma paper, Dr. Trupti SM. Is she there? Which college? I don't know actually. Which college she is? No, she has gone out actually. That will reach her. Dr. Ram Prashant MP, second prize. College is not written here. We'll inform the things again. Okay, for poster presentation, we have Medikonda Ishwar, winner. Yeah, congratulations, Dr. Ishwar. The second prize goes to Dr. Akshata Thakare. This is the certificate of appreciation for the newly started program. So with the permission of the chair, shall we go for vote of thanks? Yes. So from past few months, we have started working for the MidCon 25. Till day 4 yesterday, you people worked till 2 a.m. I heard. Yesterday also till night. Today, you're thinking that it's finished. So early, so fast it has finished, you're feeling that one. But it was a very good, commendable, appreciable conference, what we had, MidCon. See, our team in Mysore, we had the opportunity to host the MidCon for the first time. And in Mysore, we have done 4 MidCons, 2 physical and 2 online. During the COVID time, our Dr. Chandrasekhar S was the KSCASI secretary. During that time also we did. The efforts, what has to be put, how much it has to be, how it has to be, we know to some extent. But further, it goes on increasing, as our chairman said, as the number increases and the expectations also increase. So we have to be ready for those things also. This team of MidCon 25, Kanachur, has done a wonderful job. We thank the whole team wholeheartedly from KSCASI and from your side also. I thank Dr. Rajgopal Shanai, Chairman KSCASI. You know one thing, how much the organizing team has worked physically and mentally. Our chairman also has worked mentally, how to do the things, how to modify the things, how to improve the things, and also. And we have conducted, the KSCASI has conducted 8 meetings for MidCon 25. Online preparatory meetings. Every time something new used to come, for that one to frame the things, our chairman and our scientific committee team, our EC members, and our national GC members all have given the inputs. Though it's a state program, it will be conducted by the branches, one who take it. So that is the thing. We thank you very much, sir, Chairman, sir. And I thank Dr. Nas, Chairman-elect. See, in KSCASI, Chairman-elect, where all in other associations, the elect will not have much work, will not be having any thing to do also, rather than accompanying the chairman or the president of the associations. Here in KSCASI, the chairman-elect will be in charge of all academic activities of the state, along with the chairman. You have done a wonderful job, madam. Thank you. Thank you very much. See, the chairman-elect will be in charge of academic activities. To practically to come into picture, we have a committee of members, the scientific committee members. Represented on the dais is Dr. Srinivas Pai. And one more member is absent here because of some unavoidable reasons, Dr. Preeti SP and our Dr. Shilpa from Huchandanavar from Hubli. Thank you all for these things. Now I thank our organizing chairman for MidCon, Satyamurthy Aital. Nimma swagata bhashana sir. Actually ಒಂದು CME ಇದ್ದಂಗೆ ಇತ್ತು sir. We wanted to do a panel discussion. You have covered all the people, how it has to be covered, how it has to be addressed. It was very nice, sir. Thank you very much, sir. And the next is the person one who said, correctly said, rightly said, after marriage he is forgetting the names. He has worked day and night, worked hard, because he has to contact many people to get into the things. ಹೀಗೆ ಮಾಡ್ತಾ ಇದ್ದೀನಿ, ಹೀಗೆ ಇದ್ರೆ ಸರಿ ಹೋಗುತ್ತಾ, ಇದು ಪ್ರೋಗ್ರಾಮ್ ಇದೆ, ನಾವು ಹೇಳ್ತೀವಿ ಇಲ್ಲ ಈ ಪ್ರೋಗ್ರಾಮ್ಗೆ ಇದೇ ಥರ ಇರಬೇಕು. ಯಾಕೆಂದರೆ ಒಂದು ವಿ ಹ್ಯಾವ್ ಎ ಫ್ರೇಮ್. ಆ್ಯಕ್ಚುಲಿ ದಿ ಅಸೋಸಿಯೇಷನ್ ಹ್ಯಾಸ್ ಗಾಟ್ ಎ ವೆರಿ ಗುಡ್ ಫ್ರೇಮ್, framed by our elders, framed by our seniors. Without the frame, the photo will not look good. That is the thing. Within that frame, he has done a wonderful job. We thank the organizing secretary with your team. See, this is the thing, the recognition we have got. Worthwhile for working for so much time, spending his time. Probably family will now also be very happy, at least now if he says that one, these are the things happened on the dais. Yeah. And our Kiran Kumar, he was here from morning to evening and from morning to afternoon today. And our MC members, what do you want to expect we to say the things? Yeah, ultimate it was. Your voice was very nice. Because some of the times voice also counts, which I also don't have. Very nice. We thank the MCs and the volunteers. Dr. Likitra has mentioned, because I'm coming from there to that side. Because you people, with your efforts, with your selfless or selfful work into the conference, which has made it a very good and successful conference. Thank you all. And I thank our senior members, Director of Social Activities, Dr. Siddesh, who had come from Mysore to attend the EC meeting and the conference. Though he had some work yesterday, he came in the yesterday evening and he stayed here. Our EC members, Dr. Shivram, Dr. Dr. Gaddi Divakar, he is the ASI secretary and our EC member of KSCASI. Thank them. Dr. C. Rajan, Dr. Shivram, all were here, all the seniors were here. And I thank Dr. Gopinath, co-organizing secretary also. And next, who is going to take the conference from here to Sulya, Dr. Gopinath Pai has come. Sir, wish you all the best. Thank you for your participation. The expectations are rising, and we know you people will do it. And I thank our EC members who are present here and who are present here also. All the EC members, Dr. Anand Ravi, Dr. Anand Kumar, Dr. Sangamesh, Dr. Sunil Joshi, and now I come to the major part, our treasurer, Dr. Gurubhashan Gowder. Just he left actually because he had to leave and has to travel. We thank our treasurer also because we need the treasurer as the main part for counting the things, giving the things, and sort of taking back the things and questioning also. Those things will be there. I thank all the delegates, postgraduates, and all the students of the conference of the Kanachur Medical Sciences also. I thank you one and all. Thank you all for the media persons also, and Mr. Martin, Dr. Martin. Yeah, call him. Call him. Where is he? See, he is a part of our Surgeons Association. The chairman may change, the chairman-elect may change, secretary may change, treasurer may change, EC members may change. Martin will not change. He is a permanent invitee of KSCASI. Very good job, Martin. Good. Continue the things. See, each and every messages, mails, everything you get. So I thank one and all. Anybody left out also, for them also thanks. I'm putting the things one and all. Thank you all. Long live ASI. Volunteers on the dais, please. One who wants the photos and one who doesn't want the photos also, they have to come and stand over here. Yeah, these things are there. Place is very wide. It can accommodate all the people.
have to. Yes, yes, yes.